pancreas, and I will call on the stage our moderator, Dr. Naresh Gabani, sir, and our chairperson, Dr. K.S. Patel, sir, Lakshman Khiria, sir, Dr. Manish Mandal, Dr. Manish Gandhi, sir, and Dr. Jitendra Mistry, sir. And now I will hand over to Dr. Naresh Gabani, sir.
Good morning and welcome everybody. Today we have second day of midterm ISC, and today we are going to discuss about way forward in minimum surgery, especially in GI oncology. We have many speaker, and even I think one take is we have so many stalwarts in this field in the GI onco and pancreatic surgery special. So we'll not waste the time and start. The first talk is how do I do robotic pancreatic duodenectomy, and speaker is Dr. Vikram Chaudhary. So we will not waste the time and start with the first talk.
Okay, thank you. Thank you. Good morning, everyone. Responsibility given to me by Dr. Bhavin and Dr. Daivat is to discuss the technique of robotic pancreatic duodenectomy. So this is the typical OR setup for robotic Whipple. We have two consoles, but most of the centers would have one console. This is used as a training console. This is the patient's table for the upper GI surgeries. Most of the times, the robot is on the left side of the patient. There are two monitors. This is used by the bedside assistants to see, and this is by the left-sided assistant. So there are usually two extra monitors. Of course, the surgeon sees in the console monitor, and the robotic cart is on the right side. So that's how we set up. The standard port placement for XI is 4 ports. We prefer 2 ports on the right side, arm 3 or R3 at the umbilicus, just above the umbilicus, and the arm 4 is just to the left of umbilicus. All 4 ports are usually separated by 8 centimeters. XI recommendation is that you can put all the ports in straight line, but most of the times I've seen surgeons manipulating the fourth arm as per their convenience. How much it helps, I don't know, but maybe in some large patients or small patients, changing it above and below slightly it's shown. Yesterday, Dr. Vashne showed us completely different approach where he puts the R1 in ProGrasp in R1, but our standard technique is to put the ProGrasp or the grasper in the arm 4. Arm 3 is the right hand operating port. Arm 1 is the left hand operating port, and arm 2 is the camera ports. So let's go to the video directly. So she is a 57-year-old female. You can see a double duct sign there. We usually prefer patients who have BMI around 25 and who have a double duct sign. Occasionally, we have done the patients who have smaller ducts now, but usual preference is to choose the patients who have relatively moderate to low risk of pancreatic fistula. So this is the first step, the falciform stitch. It should be done sincerely in all patients. The exposure to the porta improves with this. Sometimes if the left lobe is hanging or if it is large, retracting that lobe is also very important. Cholecystectomy is usually not the first case, but in this case, the gallbladder was really overhanging and it is coming onto the porta. So I had to remove it first. Usually I go to the right gastric artery as a first step. Taking away the right gastric artery and denuding the right part of the duodenum is the first step, which gives me access to the common hepatic artery node. My preference is to finish the GDA dissection and the porta dissection as much as possible in the beginning, because you are fresh in the beginning of the surgery, and GDA is one of the rate limiting steps which you need to do very carefully. And if you are fresh to do that step in early in the course of surgery, it's better. So this is a periampullary tumor, so you really don't have to go and take all these neurolymphatic structures around the artery. You can use them to hold the perivascular tissue to dissect around it. So usual is the clue two hemologs. Take care of the GDA node. If you're not on the artery, this node is likely to trouble you. Using this red tape to retract the artery helps in the left periportal dissection, because sometimes access and vision to this left periportal area is slightly difficult in MIS surgeries. And then we proceed. Once the GDA is taken, you can start with other procedures, entering of the lesser sac, and the station 6 of the right gastric vessels are then targeted. We will complete the gastric division after that. Taking this gastrocolic vessel and the right gastric vein should be performed before doing a cauterization, because you won't have a vision to these vessels if you retract the duodenum without taking these vessels, and these vessels are likely to be injured if you give excessive traction. So always take the right gastric vein first, and few other branches which can go from the pancreas, the SMV to the pancreas, before you go for a cauterization, because that area is not under the vision. So this completes the duodenal transection, or sometimes the gastric transection. Then we go for the cauterization. The aim here is usually the progress of the arm 4 helps in retracting the duodenum. This can be also be helped by the assistant 2 port with his suction or the retractor. And this step will involve sampling of few paratic or intra-articular lymph nodes, and then exposing the origin of the superior mesenteric artery partially. So this is not a pancreatic head cancer. This is a likely periampullary tumor. So you would see that I will do some exposure of the SMA, but I will not do an extensive SMA first approach. But this usually helps in ensuring that all the lymphatic nodes, lymphatic tissue is removed and all the nodes are taken, and also helps in finishing the uncinate process earlier, because this part is already done. So when you're doing your uncinate process at the end of your resection, you can fast track this step. Robotic usually going to the other quadrant is slightly difficult. So usually what we try to do is mobilize the DJ flexure and the first part of the jejunum from the right side itself. For that, you have to have this good assistant who is willing to retract carefully the SMV and the SMA, and then you enter the mesentery from the right side, completely free the DJ flexure from the right side. You can see that all the posterior attachments have been removed, and then few mesenteric vessels I am clipping and cutting, and then this will take me to the uncinate. And now already the beginning of the uncinate and the mesopancreas is under vision. A few more tributaries from the SMV or the portal vein can be taken first, so that you can retract it well, and then you start with the uncinate dissection. You can see that this is the uncinate here, and this is the mesopancreas. So this is the level 2 mesopancreatic dissection, which is standard for a periampullary tumor. You really don't have to do a level 3 dissection or anything deeper than this. I think the key here is the retraction of the SMV. You can either use your progress, or your assistant needs to do this. But if your progress is busy in retracting your specimen to the right side, sometimes a good assistant can be utilized. The pancreatic neck transection, usually upper and lower end 2 vessels, so done by harmonic. Rest of it is a wonderful intuitive cautery, monopolar usually. 2 branches, gastric epiploic vein and superior pancreatic duodenal vein is taken, and then we continue. Once all the branches of the portal vein are taken, you can safely retract it slightly more aggressively. And this is now completion of the uncinate, and now we are going to the nodes towards the celiac. We have already finished part of the dissection as you saw in the beginning, and now we go to the celiac and the common hepatic artery from the right side. Sometimes these nodes come as a single bunch, but you may sometimes have to divide them right and left side, and then take them accordingly. In this case, I have divided the right sided nodes first, and then I have gone to the left side and removed all the nodes from the left side. Usually this bulldog should be applied from the right to left. If you put it from the left to the right, it will interfere with your pancreatic jejunostomy. So usually apply this bulldog from right to left. This sling should be slightly smaller. I just realized that it was slightly longer in this case. 6 to 8 centimeters is some like an adequate length for the sling. Then you park the specimen on the left upper quadrant above the stomach. If the left lobe is troubling you, make sure that you retract it properly in the beginning of surgery itself so that your pancreatic jejunostomy, you don't waste your additional instrument in retracting that. First is usually slightly longer. Usual length of suture is around 8 centimeter of 40 or 50 PDS, depending on the pancreatic consistency. We do a standard 4-layer modified Heidelberg duct to mucosa technique. But usually my jejunotomy is smaller and tailored to the size of the duct, and I don't do a complete long jejunotomy. Upper side stitch is sometimes difficult to take if you take the ductal or the lower stitches first. So I take the first upper stitch and then to take the 3 ductal stitches. You really don't have to pre-place the stitches if your duct is large like that, and you can continue doing each layer separately. Because pre-placement of the sutures, though it is good, sometimes you can see that the anterior 3 stitches I will pre-place, but pre-placing more than that is sometimes confusing. And if you have a good duct, you really don't have to pre-place. So this concludes the ductal stitches, and you can see that the 3 layers are complete, and it looks almost like what we do in the open surgery. So robot is an amazing platform for suturing, and you can mimic your open outcomes as far as the reconstruction phase is concerned, which is slightly difficult with the laparoscopic approach. The arm 4 stabilizes the jejunal arm, jejunal limb on the left side, and then you start on one of the side depending upon your preference. I usually start from the right and go to the left 3 to 9, and again from 9 to 3, and again from 9 to 3, clockwise and anti-clockwise. Usual preference is 4-0 V-lock, but you can also use Stratafix, or you can use 4-0 PDS, interrupted continuous, whatever is preferred technique. This is our preferred technique now. Over a period of time, we realized that 4-0 Stratafix for a relatively normal size duct is a good choice. You must not have realized that I'm a left-handed surgeon. That's the beauty of the robotic platform. So most of my surgery I'm doing with the right hand, and this completes the anterior layer and the hepatojejunostomy. Most of the times, whether I will do a intracorporeal gastrojejunostomy or a duodenoscopy depends upon how early I have finished the reconstruction. If it is 7 hours or 6 hours, I may do an intracorporeal anastomosis. This stitch is an identification stitch because, again, finding the proximal jejunum going intracoelic is confusing sometimes. So you pull the jejunum proximally and do identify the jejunum, take that stitch, and then take that jejunum to the stomach. And usually it is a side-to-side gastrojejunostomy in cases of... so this turned out to be a duodenal tumor. 2 nodes out of the 31 were positive. R0 resection, patient recovered uneventfully and was discharged on day 7. Thank you. We do around 230 to 240 pancreatectomies a year. And this is the open outcome. You can see that 2% bile rate, around 18% DG rate, PPH is 4%. Hospital stay is 13 days. Morbidity is around 40% overall, and mortality is 2.6%. And these are the results of robotic surgery. You can see that the blood loss is similar to open, slightly less than open surgery. We have completed around 145 pancreatic robotic resections, total 200 minimally invasive pancreatic dissection. So if you consider we starting around 8 to 10 years back, it is around 15 to 18% of overall resections are MIS. And you can see that the hospital stay is a day less, and overall outcomes are similar. Thank you. This is our team.
Excellent video, Dr. Vikram. I just want to ask that what is the selection criteria? I mean, when will you decide whether you go for the open, lap, or robotic in your institute?
So selection criteria, as I said, we are very selective in choosing the patients who are slightly BMI which is less than 25, 20 to 25 BMI, usually periampullary pathology with a double duct sign, no previous history of cholangitis or pancreatitis, preferably even a patient who was not stented or upfront surgery. So these are the patients where we consider them or offer them robotic surgery. But sometimes even the patients would demand that. And if they generally fit in those criteria, then we would consider them. But now gradually we have become less rigid about our selection criteria. We have chosen patients who are more than 25 BMI, who are pancreatic primary, or who may be 70 plus, or who may have a very small pancreatic duct. So gradually our criteria have become less stricter. So now we choose patients with slightly higher risk for surgery, because we have realized over time that the resection and the pancreatic duodenectomy which we do with robot is almost similar to our open approach, and the perioperative outcomes are similar. So our selection criteria is now less rigid, but we usually avoid vascular resections or the patients who have venous abutments or arterial abutments now. All other patients will be chosen for Whipple now.
Is there a duct size, any criteria for?
Not a strict criteria, but if a visible duct is there on a scan, you can do a.
And do you do laparoscopic Whipples, or it's now more of a robotic?
So motivation to do lap has gone down. So, but we still do an occasional resection. But if you ask me, the numbers have really gone down because of, and the robotic platform is the reason for that.
Is there any study which suggests, I mean, the difference between the histopathological reports for an uncinate margin, robot and lap versus open?
I'm not aware of any prospective study reporting advantage of robot, and I'm not sure. Are you aware of it? Any such study?
I just got an idea that in the recent past there was something about Leeds protocol, and then people realized that that margin is compromised in some of the surgeries.
I think that's more about case selection. I don't think it is related to any approach. If you choose the right case, with the right indication, you will be okay. There is even voice with lap robot and completely not superior, but you can do it well. But you have to choose the right case.
But usually in periams, margin will not be an issue, and you can see that you can do a proper uncinate dissection. So at least the uncinate margin not at risk if you are doing a robotic pancreatic duodenectomy.
Regarding margin, one unfortunate thing is that we have rarely seen positive margin in Indian histopath report, except for bigger institute. That is a harsh reality that we all have to accept. I have never seen in my area single report with positive margin. That is that reality we have to accept. One more question is, you use, apart from monopolar bipolar, you don't use any other energy sources. While in laparoscopy, it is the other way around. So how was your transition?
One of the reasons why we did not, or the technique which developed was with monopolar and bipolar, and now you saw that most of my dissection is double bipolar for the uncinate. So we use a double bipolar when one of the bipolar or the Maryland bipolar is attached to an external source, usually a ValiLab cautery with a macro setting, and it acts as a monopolar. So that's the technique which we are now comfortable. And the problem with harmonic is it increases the cost in robotic. It was not available with us in the beginning, and it really doesn't give that advantage of lap or harmonic, because in harmonic doesn't have an angle like other robotic instruments. So robotic harmony is something which is not great and needs to evolve further. Yes, so that's the reason why I don't use it regularly. So cost and no great advantage. Yes, sir. Yes, sir. We have done. We did that. There was a phase when we had become proficient in laparoscopic resection, and we wanted to do robotic, but the time taken for the resection and the reconstruction phase was long. So our initial robotic experience was around 14 cases where we did the lap resection and we did the robotic reconstruction to complete the procedure and give the advantage of MIS to the patient. But gradually we realized that we can do the resection, and we started doing resections also. And then the resection and recon phase, both we can finish robotically. So there are few centers which do that. But if you can do the whole procedure robotically, I don't see there is any disadvantage with doing that. But if somebody has achieved a proficiency in laparoscopy, giving up that skill is not, maybe some people don't want to do that, and they can definitely do that. I don't think the results will be similar. Some studies retrospectively have shown from Korea that hybrid technique has slightly higher complication rate. But to offer a MIS advantage to the patient, maybe that's also which you can use. But if you have a platform, if that platform can complete the procedure completely without any surgical or compromise, I think that is okay. But I would say that robotic, uh, because if the surgeon has completed the learning curve on lab, we will always take pride in doing that resection laparoscopically. But robot is not inferior, is what I can tell you from experience of both.
Any specific reason to take a GDA first? I think your first step you taken GDA first.
I said, if you do the POTA dissection in the beginning when you're fresh, maybe you've finished a difficult case. That's the only reason. Otherwise, there is no specific reason. You can always go to the lesser sac and do the gastric division first and go to the POTA later.
Some of the portion of the uncinate you have done before the transection of pancreas. So is there any advantage before transection of pancreas to do that?
So as I said, if you take those nodes on the posterior layer in the beginning, your uncinate dissection finishes faster. So that's the only advantage in peri-amps. Otherwise, in pancreatic primary, maybe doing an uncinate first, it's likely advantages because you get a proper plane from the beginning. But for peri-amp, the advantage is maybe it fast tracks your uncinate dissection properly.
And suppose the undilated duct, that patient you choose for the robotic, or otherwise in that patient, what anastomosis?
So as I said, our criteria have become less stricter now. So we choose sometimes the patients who have smaller ducts. So
the reconstruction will be the same?
Almost similar. In fact, I would say that robotic reconstruction of the PJ, even in smaller ducts, is perfectly fine. In fact, it gives an advantage of having a magnified view.
So I think we should conclude the session, and then we'll talk and move to the next one. Our next speaker is Dr. Devat Vaishnav. He is organizing chairman of this conference, and my dear friend, he will be talking on minimal disturb pancreatectomy. Over to Dr. Devat Vaishnav.
Good morning, respected chairpersons and delegates in the audience. Most of the time, this kind of the complex surgery, I think so, how I do it rather than starting. So in this kind of the major surgery, sometimes rather than how I do it, I think that how we do it, which should be there, because there is always the second surgeon's help. Either it is assistance or whether he's standing around in the OT and encouraging the operating surgeon. So this is, I'm going to present coming to the topic. The distal pancreatectomy is anywhere tail and body that we divide the pancreas any point left of the superior mesenteric vein or portal vein junction. And preserving the spleen is not a new idea. Most of the time it's deemed that it is product of minimal invasive era, but in 1940s also from this preserving the pancreatic splenic function has been coined and operated by open method also. Only that due to good imaging modalities, we are detecting the benign and low-grade malignant tumors early, and that impinges us to do the preserving the pancreas more often nowadays. We know that Kimura's or Warsaw procedure. And when it comes to the minimal invasive procedure, it is either a laparoscopic or a robotic. Those who have access instrument sitting in the left is more preferable than right, that we can see in next few slides. Most important thing that we discussed in previous is presentation is also selection of the case. Based on radiological as well as histological findings, and discuss the case multidisciplinary manner. And if we have preoperative 3D mapping and all these things, they will help us even intraoperatively to preserve the vessels carefully. This is operating room setup for laparoscopic surgery. Only main difference between the two is laparoscopic port and robotic port is in laparoscopy we just put the ports like V-shaped or angle, and robotic we put in the straight line. Coming into the operative steps, the first is dissection of the gastrocolic ligament. I have chosen typically two different cases. One is in the body, cystic lesion in the body of the pancreas, and one is in the tail. So choose the most thinnest part of the gastrocolic ligament laparoscopically, and you try to enter. First time I will run both the so once you enter rightly, you can just put your another instrument inside the gastrocolic and reach adequate exposure. The tip is to don't go up to the spleen, or because sometimes even we deem to have to do Kimura's procedure due to bleeding, we may have to convert into the Warshaws. And at that time, if they have preserved the gastroplanic vessels, that will help us to still preserve the do the Warsaw's procedure of spleen preserving distal pancreatectomy. Another video on the left side, you can see that most of the time, this kind of the cases we just get from the medical gastroenterologist after doing US guided biopsies, and that have some stomach adhesions along with the tumor you can see in the body, and you have to release that. The next step is to retraction of the stomach, because stomach is the front, sitting in the front, and most of the time we initially we tried Mathanson's with another port and retract with the instruments, but now we find that putting the stitch properly and stitching the stomach and weld it up, it is a very effective method, and we can keep this stitch loose. So we can tighten as and when required at the anterior abdominal wall. The next step is the beginning of the main surgery, or most of the time we start from the inferior margin of the pancreas, because inferior margin of pancreas is relatively avascular and fibrofatty tissue that we can identify easily. You can see only in the neuroendocrine tumors or some vascular tumors, you may find some vascularity. At the same time, in the robotics, usually we start our dissection with the hook because of most of the vascular planes. You can appreciate that because of big tumor, we are just started at the tumor and trying to get the lower border of the pancreas. Try to get as long exposure of lower border as possible, preferably up to the colonic splenic flexor. You can see now we are appreciating going into the lower border of pancreas and inching into the posterior surface of the pancreas. To gain the access of the posterior, if you are lucky enough while doing the dissection posteriorly, you can directly find the large splenic vein. And from this point, you should be more careful while doing the surgery, because injury to the vessel or that ruin your intended procedure. At the same time, you can see the left, because tumor is in the just in the body, just left to the neck. We have to access pancreatic tunnel, splenic and portal vein junctions. So small articles, how nicely we can do robotically dissect and just put the clips. because of in the robot, camera is on your hand. You can move the camera very nicely and see what you desire, which is not possible sometimes when you have your assistants, because even if a good assistants also have another two eyes, and he will see something else that you don't want to see. The next step is, while creating the tunnel, most important thing is identify the splenic artery from the upper margin, because I have seen many times by enthusiasm, we just transact the pancreas, and then we find that we have already cut or transected artery along with that. So you can see, identify, and then come down again. You can see the arteries again defined from lower border. Same principle applies in the robotic also. You just identify the pulsations and try to make the plane. So by accidentally don't transect the artery while transecting the pancreas. Now after your artery and vein is adequately mobilized, it is better to mobilize the splenic vein and artery enough safely that there is remote chance of transecting, that you can see in the laparoscopic case. Because of this tumor is in the tail, we are able to do good mobilization in the beginning only before transaction. But in the robotic case, you can see in the mid-body tumor, we did the tunneling, past the tap, and then we are ready for transaction, and then proceed for the vessel preservation. Stapling is standard. We can use according to the thickness of the pancreas, tri-stapler or white, initially golden. We can slowly compress over 20-30 seconds. Even after locking, you can wait for 20 seconds. And then in robotic, if you use the robotic stapler, they have automated staplers, so they compress enough, and then only they just transect. So if the next and most important step is continue the dissecting the vessels. In the beginning, like this case, if you have transected enough, you just go around teasing around the splenic vessels, separate the pancreas, very careful dissection. But the cases like that, sometimes your tumor is just adherent to the vessels, and very slow dissection. Sometimes you finish this all dissections in 1.5 to 2 hours, but to separate the tumor from the vessels, it took another 2-3 hours. But with careful dissection, we can finish it off if our intended surgery, if we have patience and follow the right steps. So the final picture is like that. You can see the artery, vein, clips, and spleen is preserved with good hemostasis. So I can say to my younger friends that preoperative careful planning is very important. Right selection of the case, proper positioning of the port, specifically in robotics, step-by-step standardized technique if you follow, and patient dissection over the vessels definitely will succeed you to preserve your spleen. Thank you. Thank you.
What was the histopathology in both cases?
The laparoscopic case was mucinous cystic tumor, and robotic case as SPTs, pseudopapillary pseudotumor.
Dr. Devat, nice video. In a Whipple's, I think because there is a lot of suturing, robot has an advantage. But for a distal pancreatectomy, do you think robotic has any advantage over laparoscopy?
And that's why I have shown both the cases. There is not much added advantage because there is a single pedicle surgery, and if you have good uh, anatomy, you can proceed with laparoscopic also. And still, laparoscopic is first preference over the robotic. I think so.
For spleen preservation, in mucinous neoplasm or any other cystic neoplasm, there are always chance of getting adenocy in final histopathology. So how much you are comfortable in preserving spleen, and we will end up in suboptimal surgery? That is just my viewpoint. I don't know how much it is.
That's why the careful preoperative planning, imaging, see the lymph nodes, whether lymph nodes are not there, any high risk signs are there. If anything there, then definitely we end up with not doing the preserving pancreatectomy. So that is very important, that not single eye. If for team is there, then everybody can raise their hand and they can prevent this kind of post-operative catastrophes.
Only thing is, in few cases without any high risk sign also, you may get malignancy in final case. So I'm a little bit skeptical for that. And same thing for SPT. I think from audience, we can get the comment of how much you comfortable presenting the spleen in SPT. If Dr. Shikhandi can comment on that.
Yeah, Spain.
Just be a little bit more radical than just I think it matters from this.
What is your protocol for pre-op biopsy in pancreatic malignancy?
So I think we have a good strong radiology in the patient that we are dealing with the pancreatic after dissection, all solid tumors of the pancreas. But if you have these doubts of autoimmune pancreatitis behind lesion of the pancreas, whether to offer surgery or whether to observation, those kind of things, or patient resistance of lack of those situations you have to ask for US guided biopsy. This is what we will encourage when biopsies. But not something which is required. You actually
Thank you.
Thank you, Dr. David, for excellent video. Now there is a little bit change in the sequence of talk. Let us say there is a session with debate first. We will have a session of Dr. Melissa Hogg after this one. So the debate is on MIS versus open Whipple's pancreatic duodenectomy. And Dr. Kalarasan and Dr. H. Ramesh. I will invite Dr. Kalarasan first for MIS Whipple's pancreatic duodenectomy.
No. Okay. Okay, so I will speak on 4 MISPD. So frankly speaking, I'm not in favor of debates because generally there are no hard yes or no for many things in medicine, not only medicine, in life also. So if you see a broken clock, even that will show a correct time twice in a day. So which means if you want to look for evidence, you will get evidence for or against anything in the practice of medicine. So I'm here to, and especially to debate against a legend like Dr. H. Ramesh is a challenge. And he told me I have to be brave. So I'll be brave to support my argument. I think whenever we speak anything in medicine, we should talk of evidence. So first few slides, I'll take you through the evidence and what is the conclusion of the available evidence. And then I'll put my points forward. So we are all aware of the trials. I'm not really going into detail. So this is one of the earliest randomized trial, plot trial from India. And if you see the conclusion, the laparoscopy hospital stay was 13 days, laparoscopy was 7 days and open was 13 days. So significant difference in the hospital stay. The next trial, the Padula trial, again a single center trial. The hospital stay was a primary outcome measure, and it was 13 versus 17. So 13 with laparoscopy, 17 with open. And anyone who wants to talk against minimal invasive, this is a trial which will be highlighted. LEPR2 trial, multi-center from Dutch, which was prematurely terminated because the mortality was higher in the minimal invasive arm compared to open arm. Now, this three trials. So when you analyze, while two showed positive results, the other showed a negative result. The major difference is the first two are single center trials with extensive experience in MIS. LEPR2 trial, multi-center trial. So obviously the experience may not be comparable in different centers with respect to MIS. So surgeons have crossed the learning curve here. And in LEPR2 trial, because some of the centers, probably I think they were included in the trial once they completed 20 cases. And the learning curve may not be uniform everywhere. So probably that's the main reason why the LEPR2 trial has the negative effect and it has to be terminated. And the same, this is a trial now comparing robotic versus open published this year. This is from Germany. Again, a center with vast experience of open surgery started robotic. And in this trial, although the conclusion, they did not really mention that as a negative, but if you see the results, it's obvious that the outcomes are not good in robotic arm, either with respect to the functional recovery, hospital stay, and even the complications were more, although some of them did not reach the statistical significance because of the less numbers, but you can see here, most of the complications were more in the robotic arm compared to open. So what we have observed is there is a significant correlation between volume and outcome in minimally invasive PD. But is it only for MIS? I think that's the point which you should remember. Even if you see the open surgery, there is a learning curve. And this is a publication from MD Anderson. And what they have shown is, even in open Whipples, the outcomes improve after 60 cases. So you need 60 cases to cross the learning curve. So it's not something exclusive only for minimal invasive, it is there even for open. That's a first important point to remember. Now, so we have seen the trials during learning curve. Now, what about the trials in centers which have crossed the learning curve? So we have two trials, both are Chinese trials. You can see here, this is a lab versus open, more than 300 patients. But if you see the results, the hospital stay is shorter by 1 day. 15 days in minimal invasive and 16 days in laparoscopy. So it's just 1 day difference. Now this is a trial, again a Chinese trial published this year, comparing robotic versus open. What is the outcome? The primary outcome measure against the length of stay. Hospital stay 2 days shorter in robotic arm with less blood loss. So now this is a level 1 evidence available till now. There are a couple of other trials ongoing, Diploma 2 trial from Dutch and another trial in China. But if you see what the current evidence show, during the learning curve, minimal invasive PD may be harmful. And after the learning curve, marginal benefit with short-term outcomes. So then why I'm here? Because then the obvious conclusion would be do only open, don't do minimal invasive. So that will be the obvious conclusion if you strictly go by the available evidence. But now I'm going to put forward points why MIS PD is still here to stay. Now, if you see the centers who routinely do minimally invasive surgery, the proportion of patients who undergo minimally invasive is progressively increasing. Now, the centers, some of the US centers, Illinois, Chicago, now close to 80% are performed by minimally invasive. And even our personal experience in our center now, we are more than 50% are done by minimally invasive. So the proportion of minimally invasive PD is increasing in centers who routinely perform these procedures because you have advantages, magnification, better appreciation of anatomy. You can teach the residents well with all the steps much better than in open. You have a precision, especially with robotic. You can do a suturing and dissection, which is better than open because you have tremor filtration and you can even do a similar quality suturing. I think Vikram also showed that it makes you ambidextrous and you have the best assistant available for you. The fourth arm, irrespective, you ask them to ask the arm to retract for 1 or 2 hours, there will be a stable retraction, which you can never get in open surgery. Now, there are a lot of advanced surgical techniques in pancreatic surgery like mesopancreas dissection, plexus dissection, arterial divestment, vascular dissection, and all of them can be replicated in minimally invasive. So I'm not going to show a very, because we had an excellent video from Vikram. So this is now the posterior approach, approaching the superior mesenteric artery, approaching the celiac trunk. You can see a much better view, a stable view, and this is approaching SMA from the left side. This is dissecting the replaced right hepatic artery. And again, dissecting over the celiac and SMA. If you talk about the mesopancreas dissection, mesenteric rotation, flattening techniques, you can replicate in minimal invasive the way you do in open. So you can very well understand this anatomy and you can teach the anatomy much better. My residents learn the anatomy much better with the minimal invasive compared to open. And you can teach them about all the jejunal branches. You can go in the level 3 mesopancreas plane below the SMA plexus. You can do the triangle operation. So whatever advancements which have been introduced to improve the outcomes are replicable in minimally invasive surgery. Now, so we should focus on safe implementation. When lap chole was introduced, there was increase in the bile duct injury. But did we abandon the lap cholecystectomy? But we didn't abandon that. We were focusing on how to do a safe laparoscopic cholecystectomy. So don't abandon the technique because there was increased complaint, but focus on safe implementation. Why it is happening, and we need to look to rectify that. You should develop a pathway to MIS-PD from open. But one thing to remember is there is no uniform pathway from MIS to open. It varies to individual surgeon. So it is a responsibility of the individual surgeon to understand himself. You need to ask yourself, am I now ready to shift to MIS? There are various pathways available. You can start with gastrectomy, hemicolectomies, which will simulate some of the steps in Whipple's. And don't look at the studies on learning curve. Don't think that, okay, one study has mentioned 30 cases, then I will cross learning curve, because learning curve is unique to each surgeon. So you need to develop the way to understand yourself, what are my skills, and when I am ready to shift to minimally invasive. You can do a lap resection and an open reconstruction. Any step you feel difficulty, abandon at that time, convert to open, because elective conversion is always better than emergency conversion. It's only the emergency conversion adversely affect the oncological outcomes. So you need to introspect yourself, find the right pathway of moving from open to MIS. No literature will tell you this is how you have to tell, because all surgeons are not same. Now, arguments are there. You should not compare Whipple's with the cholecystectomy. True. Because cholecystectomy, the morbidity is related to access, but here the morbidity is related to procedure. So you need to optimize outcomes. when a morbidity is due to procedure, you need to optimize outcomes. How during the learning curve, you should reduce complications by standardizing the technique and safe implementation. There are various modules available, various courses available, which will help you in standardizing the technique. And because here the morbidity related to the procedure or some of the anastomosis, use minimal PD in patients who would benefit most. We all know pancreatic duct diameter, texture are the important predictors of fistula. We can easily identify the duct diameter imaging. Now, there are technologies available. There are indices like pancreatic attenuation index, pancreatic enhancement ratio, AI being implemented to help you to know how is a pancreatic pre-op. And choose those patients because they are the ones who are going to benefit most from minimal invasive. We all talk about cost. Yes, MISPD is expensive, no doubt about that. A country like India should make better use of resources. But should we not then, India is investing bullet trains, we are going to moon. So does it mean that India is LMIC and we should not be doing all these things? That's not true. Open PD will remain the gold standard and it will still account for 80 to 90% of PD done in a nation. I'll just take a minute. But however, when a patient demands, we should be ready to offer. If some patient comes to me, I'll tell my MISPD results, the oncological outcomes are same like open. You have better short-term outcomes because of the smaller incision, lesser pain. And I'll allow the patient to take a decision. So when the patient demands, you should be ready to offer. You should not tell that I don't do. I mean, you can tell that, but there should be, because you can't expect now the patient who wants MISPD have to go away from India to other countries to get the surgery done. That should not be the way forward. Also, we should focus on training next-gen surgeons, very important. Because there is exponential growth of technology. If you see the literature, there's a progressive decline in the doubling time of medical knowledge. It was in decades, years, now it is in days. So the surgical education should be more comprehensive and also it has to be adaptive to the diverse needs of the trainees. It's true that it's a fact that many GI procedures, the trainees will be directly starting with MIS. It started with cholecystectomy. Now, many of the hiatal procedures like fundoplication, even esophagotomy, many centers, majority are done by minimal invasive colorectal procedures. So it's a change which is happening and it's a fact which we should accept. So, and the current generation surgeons embrace the new technology faster than the established surgeons. So I'll conclude with this slide. I mean, it's more than that. It's our responsibility. It's a surgeon's responsibility to keep the patient's welfare in mind. So that should be the key. Okay, it's always the patient at the heart of the decision making. Now, to me, if I have to tell any decision to the patient, I'll ask this question. If I have to do that procedure in one of my close relative, what I will do? And today, if any of my close relative has a resectable periampular tumor, what procedure which I'll be doing? And this is MISPD, and it will be by robotic approach. Thank you.
Thank you, Dr. Kalarasan. Now I will invite Dr. H. Ramesh who needs no introduction. He will be speaking for open VIPAS, not against MIS, but for open VIPAS. That is what we are given.
Mr. Chairman, ladies and gentlemen, I have great admiration for the academic and surgical skill of Raja Kalarasan, and so I really congratulate him on his presentation. We acquired a robot a year ago, and although we have MISPDs in our repertoire for some time now, I'm going to voice some concerns. I'm going to say not that we should use one technology or one technique, but that we are missing the wood for the trees. And I shall try to emphasize that the goalpost is safe operation and long-term cure, and that is comprises several parameters, each of which is a big elephant in the room, which we are failing to recognize, and we are losing ourselves in video demonstrations which don't tell the whole story. The best way to assess a procedure is to look at the safety applicability. When I say applicability, across the board, efficacy, cost effectiveness. And in cancer, efficacy also means avoidance of long-term local recurrence and cure if possible. And currently, despite Kalai's very energetic and emotional presentation, there is not enough evidence to show superiority of MIS approaches. And mostly we are trying to show equivalence. It is generally well known that open Whipple is safer, more applicable, more efficacious, certainly more cost effective. And on cancer control, we have only surrogate markers like lymph node removal and early survival data. I would like to still settle if the patient has better outcomes in terms of quality of life, if there are better healthcare economics, if there is better long-term oncologic results, then I would really want it. And if this may include even early entry into postoperative adjuvant regimens, which is a big requirement for us, given the fact that many of our patients may require postoperative adjuvant therapy. In order to improve mortality, we have a big task because already the bar is about there. Mortality following the Whipple resection has decreased to really low levels thanks to a combination of factors, including technique, technology, postoperative care, and so on. And when we consider the two arms of minimally invasive surgery, laparoscopic and robotic, and I don't want to look at the trials that Kalai mentioned. I'm not going to talk about the LEOPARD trial. I'm going to talk about the fact that 22% of videos were considered suboptimal surgical technique. I really question the ethics of such trials because will I, as a surgeon, and Kalai referred to that, would I not have the responsibility to do a perfect operation or to do the process which gets the patient to receive the perfect operation? Are we willing to settle for second best? If I can't do it robotically, I must convert, and there is no harm in conversion, as Kalai mentioned. And certainly, if we do not acquire sufficient skills to do a procedure in a certain manner, either you do not do the procedure in that using that technique, or you do not do the procedure at all. And how can we enter into a trial if you have 1/5 of the videos which were considered suboptimal? And this is not acceptable. I always used to think in the beginning of my career that there is no parochialism in healthcare. Surgeons, unfortunately, have mental fixation and they work towards proving those by trials. And that's why we have huge differences in if you look at the robotic studies, we have huge differences in outcomes in different studies, and I'll come to that in a minute. One of the concerns that I have had is that current data does not allow you to get patients on MIS to earlier chemotherapy, which will be a big, big gain in my opinion. So if you look at the, robotics and open PD, Kalai said that these are not high volume centers, perhaps in Europe, 40 robotic PDs they had done. So they were pretty much experienced. I didn't need to do 40 before I had some, control over the technique. Huge differences in outcomes. On the one side, absolutely no bleeding, 75 and 150 mils of blood loss, which is quite remarkable, and completely different outcomes. Is it possible that these surgeons were biased? I often wonder, and I have begun to mistrust trials as a result. A propensity analysis in a single center may be a good way to get out of this. This is Jacksonville, Mayo Clinic in Jacksonville, and they have 3 robots. They have all the technology at their command, and then they found that their patients who underwent open surgery had better results, and the worst results were laparoscopy converted to open. And that is an important lesson. Perhaps some of them were driven to conversion at a critical juncture, and that's where the complications. I'm astonished that surgeons will put a number to learning curve. Having done over 2,000 Whipple resections in my career, I am still learning. And the person who stops learning is dead, at least intellectually. How can you get to become an expert or a master after 34 laparoscopy and 36 robotic operations. And therefore, I don't know how Kalai will say the learning curve and make a lordly business of learning curve. I think it's a constant process, and we all learn, and we need to learn and rapidly. And so this is a slide which was kindly given to me by Sudeep, some of the other slides that came in this study, in this presentation, that even after 500 cases, surgeons improved in open surgery, and that the steps between competency, proficiency, and mastery is very ill-defined and a very long procedure and often never attained. At the end of the day, it does matter what the surgeon's conscience is, and that's something that Kalai did refer to. Is MIS Whipple a case of surgical machismo? I had to ask myself before allowing our center to embark on a MIS approach. We have to mention here that even women have machismo. And I must mention here that there is an invisible peer pressure in a sort of a forum like this. To be able to present a video on a laparoscopic or a MIS procedure is kind of an achievement in itself. And we must thank Sudeep's daughter for telling us about the fear of missing out. And I believe that's a very big problem these days in every walk of life, not just in surgery. And of course, the industry pressure adds its further, nobody has a workshop on open surgery anymore because it's not fashionable. So therefore, is it not something that you need to get the patient home? I think that at the end of the day, the goalpost is still the same. It's still safety, it's still R0, and still long-term survival, which can equate to cure. And we do not look at how we must be doing this, Whipple. What are the boxes we have to tick? There is absolutely no discussion on the goalpost and how we reach the goal. I want to just present one such concept which we have used for the last 10 years. I've always thought of this as a big lacuna in pancreatic surgery, that you do a very big, humongous operation, and at the end of the day, at some parts, you don't actually have clearance. Because of the rotation of the bowel, the jejunum is on one side and the uncinate process on the other. And actually, if there was no rotation, it would be on the same side of the vessels. And because of which, there is a tendency to resect the jejunum so closely that the mesojejunum does not get resected at all, and the meso-uncinate therefore does not get also resected optimally. So you need to really do this, for which it is important to do some derotation, either a partial derotation or a more thorough derotation. You can do a cattle brush in a very difficult case where you have to do vascular dissections, arterial dissections, and then all this mystery of the jejunal veins, all these, whether it's anterior, ventral, or posterior, dorsal, all that evaporates. It becomes a straightforward operation like a right hemicolectomy. And this is how you will see the layout, and this is how you proceed to a resection, and this can be done laparoscopically. MIS, although there are some challenges in how you're going to position your duodenum, and this is how it will look in an open operation. So Kalai did show that in laparoscopy as well. It can be done, but with a lot of technical difficulty. So I'm just going to show you a brief 1-minute video which emphasizes why in the second half of our patients are median survival increased by 10 months in patients with pancreatic adenocarcinoma, not just ampullary carcinomas. And while the video runs, and if you take off this criminal fold, as I call it, which usually carries, chylous lymphatics and it's better ligated, then you can just convert this to a right hemicolectomy, as it were. You can decide where you want to divide the vessels. You can go and hit the superior mesenteric artery and then work your way up, ligate and divide the first jejunal artery and the IPDA. I must mention here that Vikram mentioned about the ampullary carcinomas. You don't have to go to the artery. Ampullary carcinomas, once they involve the pancreas, their survival is abysmal. Therefore, it is important to do, and you don't know that even by imaging, you don't know that by actually mobilizing the pancreas. You have to do at least an LV2 resection in all cases. So either are you going to do a subadventitial in very bad cases, or are you going to do a periadventitial? In all cases, the artery is first or last. The artery is your goal, and so you have to. If you do the artery, then the IPDA ligation or the first jejunal artery ligation is a breeze, and the operation can be performed very expeditiously and efficiently. So we need to use our resources to doing the perfect operation for pancreatic cancer. And I haven't seen a single meeting, whether it's the IHPBA World Congress or whether it is any regional meeting, which actually looks at what are the goalposts, what are the exact boxes we need to tick during this operation, and forget about whether we should do it open, laparoscopically, or robotic. The critical aspects, as far I would look at, is how much of the uncinate process to be resected, the LV1, LV2, LV3 concept. And we need an easier and more transparent method to do adequate uncinate process resection. And I believe that the way to go about it is to do a derotation. I call it the radical retrograde superior mesenteric artery mesojejunal clearance. And you can call it in a different way. How much of the station 14 should be cleared? And that's a big controversy. We can, and then of course, apply a technique in a large body of surgeons, and many of the surgeons here present can join such a study and see how our R0 rates be improved. Talking about R0 resections in lymphatics, and lymphatic clearance is a very nebulous sort of concept. It's very difficult to nail down, and then see how it translates to improved survival. We need biological markers to determine failure to respond to neoadjuvant therapy. Otherwise, we run the risk of abandoning many cases. And also, we need biological markers to find out who deserves more radical treatment. And we should concentrate on that as well. And how can we refine multidisciplinary approach to get maximal results and make all this cost effective while doing so? Quite a challenge, isn't it? So we should be actually using decision tree models to plan which patient requires which type of resection. We aren't getting there. We are still bogged down in doing some procedure laparoscopically or by open. It's probably because we have missed the wood for the trees that less than 10% of pancreatic head resections are performed by MIS worldwide. If indeed it was such a great idea, why would we not be doing more and more? In fact, this is an international survey published a couple of years ago, published a year ago actually, but the meeting happened 2 years ago, where all the big shots in pancreatic surgery, like the ones I have in front of me, sat down and then they had a survey, and they found that they did 66% of standard PDs open, 87.6% of portal vein resecting Whipples open, 92.4% of PDs with arterial resection open, and even in the future, they believe that 43.5% will be open. And that is more a reflection of the type of disease that pancreatic cancer is, and the fact that more and more multidisciplinary, multimodal therapy is going to happen. More and more patients with vascular involvements or at least abutments may be presented to the surgeon. So we need a slew of techniques. We can't just say we will use one tool to or one hammer to ram home the nail. I can say for some degree of certainty that laparoscopic pancreatic, because of the 3 fields that you have to dissect, may die a natural death, and it may be robotic. We need more complex resections, and with that, we must remember that the open surgical master can have precision, flexibility, accuracy, just as a robot can. And they can achieve a shorter hospital stay, and I will tell you how they can do that. We also need, at least we have to make a resolution right here that we have to talk to Da Vinci and say that each one of us who uses the robot have to have a recycling of our plastics, because this is a major mountain of waste that we are generating, and that could mean the end of planet Earth. So I like to speak for Kalay and say that there are some obvious, not so obvious benefits of MIS. He did mention that his residents understood anatomy better. I think what happens is when you are setting out to do a lap Whipple or a robotic Whipple, you need to really examine the vascular anatomy so well, because you are afraid you may lie in trouble, and you got your hands in your pocket sometimes and you can't scrub in a minute. So you have to go slowly, carefully. And then when you do that, you do precise dissection because of fear, and you have perfect hemostasis because otherwise the view gets lost. So you actually end up doing a better job, perhaps. The fear of messing up and the fear of conversion, and also the fact that you are on a monitor and everybody is looking at you, and a knowledgeable anesthetist is a very good critic. It is a mess. Everyone talks about it. There's a greater need to divide surgery into stages and tick the boxes. Only then you can get a MIS procedure done. There is the possibility that more and more people can do the operation, especially younger people with more intuitive skills, but I suppose that's not true. When I tried my hand at the robot, I found that I was as facile as when I started to do open surgery. So, ladies and gentlemen, I'd like to submit that currently open pancreatiodectomy has the edge for cancer, as it is safe, it is applicable across the board, especially in the scenario of more complex resections with vascular reconstructions. It's an available resource across the country, which is cost effective. And I have personally done up to 3 pancreatiodectomies in a single day. And that's something that you simply can't do in a robotic platform. Outcomes have, of course, improved with better techniques, post-operative care and ERAS. And I want to sell you the concept of real minimal invasive surgery, whether you do it laparoscopically open or robotic, that Toshimi Kaido showed in his paper that a median hospital stay of 8 days was achievable by a very good system. So patients with pancreatic cancer have a lot of diminution of patient quality because of jaundice, because of poor appetite and poor nutrition. And there are a whole lot of issues that have to be treated along with surgery, along with treatment of the cancer. And some of them have multimodal therapy as well. We have to do preoperative measures, intraoperative measures, not least of which is meticulous surgery and a systematic postoperative mobilization. And if you do that, as this paper showed, and this paper was 3 years ago, median hospital stay was 8 days. And so you had good results. So I sell to you, MIS is actually MIS, not necessarily laparoscopy or robotic surgery. Thank you very much.
Thank you, sir, for a very balanced and scientific viewpoint. I think it will be unfair if we don't give 1 minute to Dr. Kalaivasan for his counter argument, or if he has any other point to make after sir's talk.
No, I think I have responded to most of the points which sir has mentioned. I completely agree with all the points. As I mentioned, Open PD will remain the gold standard. It will be performed by the majority of the surgeons, but you don't abandon the MIS. It's not, you should not think all this as industry driven. Okay. If there are no real advantages, no industry driven equipment will succeed if there are no advantages. So it's not that we are doing MIS because of industry pressure or all those things, because there are many equipments which have come and have failed because no definite advantage. But MIS is remaining because there are advantages, and MIS PD is being done because there are advantages. So we should not think of just abandoning that, focus on how to safely implement it, how to safely disseminate it. And as I mentioned, it's the responsibility of each and every individual surgeon. You can't give guidelines. It's our responsibility of making sure that patients are not harmed. If you just keep that in mind, and then you can safely implement, there's no rush, do it safely, do it slowly, but achieve, and then you can practice MIS in a bigger way. I think that's my point. Maybe I'll respond to any other queries.
Yeah, to add to what Kalai said before Rajneesh comes up, what do you think about the pressures on the professional? I mean, unfortunately, I have over 40 years become sold on the idea that surgeons have convictions first, and then they work towards making those convictions real. It's not that they happen upon certain findings and then they analyze it carefully and then decide on what they should publish. So often you want to publish early, you want to also be a leader in your profession. So there is a different situation for somebody like you who works in a public hospital and somebody else who works in a completely, private corporate setup. Somebody who works in a large institution where there is no pressure on seeming pressure to actually adopt a certain technique, and some who have to use it as a unique selling point. Please remember what Virender Sehwag said. He said he had to score 180 balls because there were 3 other people, Ganguly, Tendulkar, and Dravid, who were scoring 100 anyway in about 200 balls. So he had to do something differently, and he was pretty good at it for a time, but he couldn't keep it up. So this is what we have to safeguard against, that even in the corporate world, even in the public unit world, we have to emphasize to ourselves that we have a greater moral responsibility not to, shall we say, destroy a technique by using it in a very haphazard manner. So I think it's easier for you working in a public hospital to have a system. If you have a larger team, it is much easier to do that. But if you are a sole surgeon, it's easy to sell the idea that, oh, I'm doing the best surgery in the world. It's not necessarily true. So it's more philosophical, as you said.
And also, just quick response to that. I think pressure makes a surgeon better because I mean, you want to, definitely that pressure is there. You want to acquire the skill quickly, but also that makes you better. Like you put more effort, you record your video. You see that video multiple times, where I went wrong and why I went wrong. Then if you have deficient some other skills, go back to your skills lab, refine the technique, and then you acquire that skill early rather than trying to find negative things in a particular technique. I think that should be the approach. Pressure, you have to take it in a positive way and work hard to achieve the necessary skill.
Now, could Kalai also comment on what should be the fate of patients in a so-called learning curve? Surgeons must abolish this term because I think we are learning forever. And it's almost as though those 30 patients are unfortunates because it is the beginning of your curve. Do you agree? Yes.
Unfortunately, it's made as that said, I think because I'm not sure, but somewhere along the way, from 20 years back, he waits for evidence for function of technology in surgery. That way, you want to find examples of how we use I integrated the reference to the but it was such a language. I don't know if the right step up. I'm just giving an example of the fact that technology means much faster than we can integrate evidence for. And that already the case, and that probably future worse than in terms of venture evidence and it's paid at the point. Today, learning is a very diverse mentioned there, but what they talk about clearly is that this is capable of 20 cases or 50 cases. It's based on one parameter. That would be the run loss, it would be the industry. Unfortunately, for actually that's very easy to define. There's no one main parameter that is defined for that. And so when you define the lowest integrated current after 50 cases. Unfortunately, in a reverse operation, there are many endpoints which are looking at, which includes blood loss, operating scale, and so many other risks that we talk about. They're all those. But to define and say that non-professional because robotic because become very difficult tasks. Because I might get my learning curve of AVM complication at 20 pieces, so 3 complication 50 pieces, and it's not operating in the So then to say that this kind of book because it's serving for 20 cases for the industry. Another trials are because they included a European country as a monitor and there it was 50 cases and the very different problem. In my mind, the way to look at evidence is a bad idea because we never be able to say that this A group is better than B based on X parameter or would be question, whatever is parameters. My significant way of thinking without thinking that we have to do a lot and of course, to address one down that path from operation to laparoscopic to robotic. Displaying their works with all the parameters inside in terms of publications and people have done across the world. Those are far easier than learning at what point my end of scale stabilize, my field will stabilize in an open, now when I move from one X to the right. Far easier to learning things. You can visualize it, you know how to do it. That's my input.
I think it's a very quick comment because the first point, technology, I think that's well accepted. That's why I mentioned it. And regarding the second point about the various, I think as Sarah also mentioned, there are some points which you need to tick. So few things during resection, because that's where the oncological outcomes are going to be taken. The long-term outcome is during the resection phase. Short-term outcomes during the reconstruction. I mean, just simplifying it. Obviously, there are some blood loss also, which determine the short term. So that's why I mentioned first in cancer, it's the long-term outcome that is RS resection. So first you ensure that you are able to achieve that during the resection phase. So you first focus on that. And then the reconstruction phase as a subsequent, once you stabilize your resection. I think that's a way to go forward, and it varies with individuals. That's why I felt use publication as a reference, but you have to find your own pathway.
Please, last comment, please. I think we are 25 minutes late by schedule. It's a quick comment, sir, please.
But some new statements which came out by independently individuals. So I think because why do we talk about like one of the statements that you said that it will always remain the gold standard. I think as it changed in the apostolic system, I think the lesson model of this cannot see the future. And what will happen in due course, one cannot be able to respond to this now. And one of the things that Ramesh, as you talk about that, I will say that one size fits all. Because like a lot of times this has to be happens of minimum invasive was broken. I think mostly they say, oh, you have to show real advantage. What we are talking about in oncological development is not inferiority in terms of oncological results. And the obvious lot of short-term benefits are very obvious. So I think the issue here in every procedure is that can you do it safely and do this with the same results in terms of oncological outcomes and positive advantages of minimal invasive. Like Dr. Ramesh talked about the vascular research. I think there was a time when people were not going there for vascular research. So I think that is an ongoing process, and now we have a lot of videos in which the surgeons have very simply done the vascular resection with minimal invasive technique. So I think that is, and the one more point that you talked about is that you keep learning. Yes, of course, it's an obviously learning process the entire life. But however, when you talk about the learning of number of procedures, I think that was there even in open. So obviously you start somewhere. So you cannot say, because the issue is that those results obviously go, it's not just 30 cases, 50 cases, 100 cases. Your results after 200 cases will be better than whatever there. So I think we have to get out of that mindset that we will stick to what is, I mean, the open, which has been there for a long time, because as you showed in your slides from the 40s, the results have drastically improved even in open. So I think we have to embrace this new technology, and I think whatever procedures simply can be done, and ego aside, whenever you need to convert, and the best outcomes will be delivered in terms of short-term and long-term.
I just wanted to mention that it's probably unfair to compare laparoscopic cholecystectomy, which never required a randomized trial, for example. In the 1992 consensus, NIH Consensus Development Conference said it is the gold standard long before anybody did a trial on mini cholecystectomy and other stuff. Here, trials really actually have underlined the difficulties in assessing these two techniques, and that's why I said we shouldn't dwell on them. What we should dwell on is what constitutes a standard Whipple, and I try to emphasize that what we have failed to do in our seeming debate about the route of approach or what vehicle we must use to carry out a journey, what constitutes safe driving and objective driving, and perhaps we should concentrate on that. I think it's, I have said at the outset that absolutely whichever technology is applicable can be applicable. Obviously, you can't have one technology for all. There's going to be certain cases where you're going to not be find it suitable to do, say, a robotic procedure, and that's perfectly all right. But at the same time, what constitutes a good Whipple in 2024, we have to do that. Earlier, getting patients home was enough. Now we have to get patients home and also have R0 and also have a very long-term survival if you can.
I would say
and very good pros and cons placed in front of all of us as regards the approach. My comment was specifically to what Anil spoke. Just to remind you that in 2013 in Shanghai, at the APHPD, I was debating on the same subject itself. And you said, Shailesh, if you don't do laparoscopic and minimally invasive surgery more now, in 10 years' time, you will see it will be a different world. So we are 11 years down the line, sir. And today you have a situation where less than 10% of the minimally invasive medical resection are performed worldwide. It's not about I being right about what I told you, but it's about the objective pluses and minuses that we saw. Let's acknowledge that there is industry pressure. That doesn't mean technology is bad. Technology also gets a bad name when it falls in the wrong hands or with the wrong minds. So let's respect technology. But let's not forget certain benchmarks which are truly established. You must strive to reach the point of equipoise and then superiority. As long as you convincingly prove to the world that there is equipoise, we must continue these journeys. So I don't want to take one stance versus the other. But there is still a long journey ahead. Rather than putting pressure, I don't think he really put pressure on a younger colleague. He is hardly a younger colleague, point number one. And don't make him older either. So I think this is absolutely fine. But, the Heineken ad is what I will close with. We had this ad in the National Geographic Order, which is an open forum. When you make a great beer, you don't make a great fuss. If this technology and this approach, it is going to be great, without a fuss, over a period of time, it will establish itself. We don't need debates for it. Thank you.
Thank you. Speaker and audience for a great debate. We spent 15 minutes here, but every second were worth because all the authorities in the field were debating the topic. So we'll quickly move to the next topic. Thank you, speakers. The next topic is on tips and tricks to achieve safe pancreatic anastomosis in PD in MIS approach by Dr. Melissa Fogg. I think she is not there, but we'll have our video sent to us.
So for time, to saving the time, tea is available. Those who want, they can take and cup inside. So we are skipping the tea break to save the time, and meanwhile the presentation starts. So we continue with our sessions till the lunch.
Hello, this is Malcolm Logan talking about signature acute pancreatic enteric anastomosis post-Whipple operation in MIS. That's quite a mouthful. I'm here in Chicago. I'm sorry I'm not there with you. I video recorded this now. It's Wednesday night, but I know you guys are seeing this on Saturday morning. I likely will not be able to join you. I'll be at my graduation for our residents on Friday evening when this is taking place. But anyway, I hope you enjoy it, and if I can be there, I will. All right, so I do have some disclosures from Intuitive Analytics. So today we're going to be focusing on the reconstruction here after the pancreatic duodenectomy and zeroing in on the pancreatic enteric anastomosis. I always do this to the jejunum. I know you can do it to the stomach. I've never personally done that myself. So there are a lot of techniques out there. Obviously, that shows superiority across the board. So people do things many different ways. I use a modified Lugart technique, which has posterior mattress stitches, posterior ductus mucosa, pancreatic duct stent, an anterior ductus mucosa, and anterior buttress stitches. All right, so this is what I call my pancreatic vaginostomy 1.0. So essentially, these stitches go transpancreatic and then seromuscular. We all know pancreatic bleeding happens very frequently. We tie down those corners and we do straddle the duct. And here you can see us moving that to make sure the stent doesn't get clogged. So after that, I put 2 posterior ductus mucosa stitches. This is an old video, so one of the reasons it's 1.0 is This is Vicryl, 5-Vicryl. So we use that on a small needle, cuts about 5. We put 2 in posteriorly, and then we tie 2. Now, when we do the anterior layer, we go left-handed so that we're always going inside out of the pancreatic duct. We're not going, from outside in and potentially missing that ductus mucosa. So I'll put 4 on this side, 2 in the corners and 2 in the middle. And then finally, using those same silks, leave the needle on, buttress that. And so you can see we're rolling the small ball up and over to the face of the pancreas. So I do things a little bit differently now, not in terms of the stitches, but in terms of the time. I think it's very important when you are doing these not to have air knots. And the anterior stitches can be different. So let's go through this. So we see the silk stitch goes transpancreatic from each serosal surface. Then on the small ball here, I go way back by the mesentery and take a nice big bite with the silk in a seromuscular fashion. And then we'll go transpancreatic again. But now what I do a lot differently than I did before is I use that third hand to grab and take tension off. And see how you would, that hand pulls that small ball way up against the pancreas. You want to make sure that there's no gap in the back because you know active feedback. So again, transpancreatic, seromuscular, and this one straddles the duct. I'm not really afraid to kind of touch the pancreas or anything like that. Obviously, I had a lot of experience, but you don't want to be too rough. So anyway, I use that hand again to pull everything together. And that this is the third. I always use 3 of these. Again, seromuscular bites. I kind of do it like rounded on the bottom. So then once all 3 stitches are in, I tie it. So here I'm tying the corner stitch. And you can tie these nice and tight. And again, a lot of times in the transverse pancreatic vessel. Now this middle one, I don't tie tight because I want to make sure that that set moves free. So now I make an enterotomy for the ductus mucosa stitches. And now you can see 2.0. I use PDS, so 5 PDS. It is more difficult, I think, to tie than the Vicryl, but I think it works a little bit better. So here you can see kind of at 5 o'clock and 7 o'clock position, these ductus mucosa stitches are done. So I put both of them in, then I tie both of them, and then I hand them. It's very important to be cautious and for the needle. So here I use this stem. It's more of a technical thing. I feed it through so that it passes quickly. So again, using the left hand, I go make sure that I'm going inside out on the duct to the pancreas. So again, you can see that third hand of them holding everything up. And I try to take big bites. Here you can see I come out of a serosal cut surface. So I put the corners in first, and then I split the difference by putting 2 in each one. So once those stitches are put in, see how this third hand lifts everything up, and it takes the tension off these corners here. And I always tie the corners first because there's the least tension. So I do think air knots in these ductus mucosa stitches can contribute to fistula. So I think using that third hand to take tension off is sort of a secret weapon. Now watch here that I pin this left hand and I roll the ball to cover the face of the pancreas. I think that's important. See, you're rolling the ball up and over. And I take nice big bites so it can kind of cover that entire head surface. The other thing I do is I create a falciform flap to put over the GVA stump. I don't necessarily roll it all around the pancreas and tie it. I have done that on some occasions when I'm getting the gland is super high risk. All right, so I think it's very important to have video because you can look at your technique, you can teach other people, but you can also set outcomes. So these are the 7 steps of pancreatic duodenectomy, and we've looked at several of these steps to look at outcomes, like the portal dissection, GVA stump block, unset dissection, margins, hepatojejunostomy, and stricture and leak, gastrojejunostomy, and DGE, and of course the pancreatic jejunostomy. So I'll talk about that now. So I presented at the American Surgical, now it's been 8 years, I'm starting to get old. So this is talking about grading of surgeon technical performance, predicts post-operative pancreatic fistula or pancreatic duodenectomy, independent of patient-related variables. So this seminal paper from Berkmeyer at Michigan looked at surgical skill and complication rates after bariatric surgery. And they used 6 different domains of OSAT on a 1 to 5 point scale, 5 being master surgeon. And they graded these videos, and they saw that if you were at the bottom quartile, like the worst technical skill of surgeon compared to the top quartile, the best technical skills, you had more any complications, surgical complications, medical complications, and that translated to reoperation, readmission, and ER visits. So the best technical skill had the lowest amount of use for outcomes. So what we wanted to do is we wanted to look at grading the pancreatic progerotomy, as I showed you here before. And the goal of this study is to evaluate and quantify surgical skill by grading surgical performance at robot levels and see how it translates to fistula. So we use the OSATs the same way Berkmeyer did with his study, but we also used PJV variables. So I'll just talk about that in a second. But basically, we looked at all of our ripples and we graded each stitch, as well as we graded the overall performance of that. And so the PJV score here looked at each of those in terms of needle loading, knot time, workspace range, as well as each individual stitch, as well as placement and knot. So what we found was that technical scoring was an independent predictor of fistula. So if we look at those stats for the most critical patient-related factor, which is soft lab, it was still significant in multivariable analysis. Now, if we triage each patient with a fistula risk score, again, the OSAT was still additive to the prediction of fistula with the fistula risk score. So what we saw was that technical skill during the pancreatic progerotomy can be objectively scored. Skill measurement correlates with the risk of developing a fistula. And we thought this potentially had profound implications for quality improvement, credentialing, and surgical training. And standardization of training and reporting of video skills grading by procedure was an important step. And so what we saw in our series of 500 of our first robotic ripples when I was select hit was that our post-op fistula rate was about 20, and this includes biochemical leak or what used to be called grade A fistula before it changed. But if we looked at BC, clinically relevant post-operative fistula, in the entire 500 series, that was 7.8%. But if we look at our last 100 cases, it was 3%. And I was just reviewing the outcomes from the last 5 years, and I still have a clinically relevant fistula rate of 3%. I think equally important is drain management. Now, I'm in the drain everyone camp, but we're moving as soon as possible. And I know that's controversial. The second controversial thing is I put the drain on bold suction. And then I measure it the morning of post-op day 1, and I want that to be 5,000. And if it is less than 5,000 on post-op day 3 and goes down from the value of post-op day 1, so say it was 4,000 and went down to 1,000, or say it was 3,000 down to 1,000, whatever it was. That is a criteria, and it has to be seriously nice. If it has that little bit of that Merlot looking or like kind of like tea or anything like that, I'll leave it, and I'll actually put it to passive drainage off suction and stays in past post-op data. Now, also, I'd be remiss if I didn't talk about training. So I don't think you should just kind of decide to go off with rules and not have any sort of prelude into that. So I think starting with the simulation curriculum, then working into an inanimate curriculum, which includes biotissue drills. Mastering the procedures by kind of checking video libraries, specifically unedited video. Having someone help with psychomotor performance, whether you have you go and do observation, or you have people come and coach you on site. And I think it's important for decision-making judgment to record your video and also monitor your outputs. And I've published extensively on this if you are interested. So in summary, you need a solid technique, you need training, and you need good post-op management protocols. Thank you. Hope you guys are having a great meeting. Hopefully I'll get to India one day. And I look forward to seeing you at the next meeting. Take care. No, this is how we're going to be talking about citrix, which you pancreatic and enteroconazole.
I think
Post-Whipple operation.
Please stop the video. I think it is replaying. So Dr. Hogg is not online, but still we thank from our ISG for excellent presentation, and we will move to next talk soon because we are still running, even after skipping the tea break, we are 7 minutes late behind the schedule. So for our next talk, the speaker don't need any introduction. Dr. Shailesh Shikhande, he is from TMH, I think central highest volume of Vipas in India. So directly to sir, his topic is MIPS for a safe implementation and wider expansion. What do we need?
Thank you to my dear friend for inviting me here. I think when Bhavin gives a call, he's always been a very persuasive person, but it's impossible to say no to Bhavin, and of course then also to IISG. It's great to have such a collection of people and experts from all across the country in different specialties. And I'm happy to give a talk which Bhavin specifically identified for me. He offered me the chance of showing a robotic video. And then he also said, but there is another topic which I'm thinking. And very politely he asked me, Shailesh, what do you think? So I said, this is a new topic. Maybe I can do some justice to it. And he was very happy about it. But then when I actually started working on it, I realized that I have to give you a very broad, detailed opinion about what exactly this is about. So let's not repeat what we heard in the previous debate. Pancreatic resections, irrespective of the approach, are demanding procedures. MIPS is now standard surgical practice. The pros and cons were very well laid out in front of you. However, the implementation into clinical practice has been rather slow. And this is not my opinion. This is worldwide data that less than 10% of pancreatic resections are done minimal invasive. Now, we also know that if you standardize any operation, that operation becomes more safe and you are able to do it more efficiently. And if you do it safely and more efficiently, you will also objectively improve the outcomes of the operations. So, you know, surgery is something which you keep on learning for the whole of your life. It's never a finite endpoint that you have learned and now you just do. You keep on learning new things every day. And with this is something which is only 30 years old. And in 30 years, we are still on a very long journey when it comes to trying to understand it. Now, before we understand what needs to be done for wider implementation across the world and adoption, let's look at the trend that the world has gone through. I was a part of this consensus meeting, which was held in Sao Paulo, and I was leading the left pancreatectomy group. But before doing that, we had a worldwide survey on opinions and use of minimal invasive pancreas resection. This was an idea of Chuck Walmer predominantly, and I was a part of this group. And we concluded, based on data of a large number of surgeons all over the world, that minimal invasive distal pancreatectomy is a good and an appropriate alternative to open distal pancreatectomy for lesions of the left pancreas. But when it came to MIPD, this publication is 7 years old. It is still considered to be in investigational phase, is what was this MIPR survey that was concluding. Also, most HPB surgeons would welcome specific training in minimal invasive pancreatic resections and also the establishment of an international registry.
I would certainly request the IASG to look at establishing a registry of our own data. We have our opinions, we sit in these meetings, we enjoy talking in these meetings and also meeting with everyone. But I think we need our own data as a vast country. And I would suggest that we look at a national registry of minimal invasive pancreas resection. Difficult, but extremely desirable. Now, why is MIDP the better option or an equally good option? You have a number of series where the hospital stay has gone down. The morbidity is perhaps the same. You will also have some studies showing that the morbidity is lesser. Pancreatic fistula, some of these publications have suggested that it is more, but you will also have studies which say that it is equipoise or even better or lesser than that of open surgery. So the overall thought process is that MIDP is safe and feasible, but even then, till 2017 and 21 and 23, we are still talking about oncological safety. We heard the word repeatedly in the previous debate about cancer, cancer, cancer. We are talking of cancer. How often do you operate on the left pancreas without a cancer? Uncommon. Less, majority of the times these are tumors or early cystic tumors which could become into malignant tumors. So what's the current state of play when it comes to minimal invasive pancreatoduodenectomy? First operation, Michel Gagnon, 1994. 2017, the Sao Paulo meeting, and then now we are in 2024. The acknowledged usual difficulties are there. A difficult exposure in the retroperitoneum, major vascular structures around, variations and too many factors, as we very nicely heard some time back, in terms of technical nature, the complication profile. There are too many aspects associated with a pancreatic resection as compared to, say, a gallbladder surgery. There is also the problem or the ability or the lack of ability to adhere to oncologic principles due to various factors again. And then there are going to be challenges in training surgeons. And when I say this, it is training surgeons in open surgery, laparoscopic surgery, robotic surgery. So this is not going to be easy, especially if the operation is not a very common operation. Training a surgeon for breast surgery or for head and neck surgery, which are very common problems in our country, or in gallbladder stone disease, again very common, it's easier to train large number of surgeons in pancreatic resections or liver transplantation is not something which is going to be easy and so requires time. We've also had in recent years the Miami Consensus, and also the Japanese HPB Association has come up with a good a series of papers highlighting the importance as to how we should go ahead with MIPD. So this was the Miami Consensus meeting. I was fortunate to be a part of this meeting, an extensive process that continued for a whole year across various bodies to try and reach some meaningful conclusions and look at it in terms of summary of recommendations. There is insufficient data to recommend MIPD over open Whipple resection, but centers performing MIPD should be including all their MIPD outcomes data into national and international registries. So you may have islands of excellence, you may have brilliant surgeons like Dr. Palanivelu, but you need to be sure that you put all your data out there in the literature for scrutiny so that we improve. And then there should be prospectively maintained databases. Both MIPD and open Whipple resection are valid approaches for selected patients with adenocarcinoma. No comparative data regarding MIPD versus open after neoadjuvant therapy exists, and further investigation is warranted, was what was the expert opinion. The grade of recommendations are there in the right column for you to see. I'm not going to go into great details, but this publication is as recent as 2020, Annals of Surgery by Horatio Asbun. The 12th one is no evidence of superiority between lap PD and robotic PD exists. Surgeon training, experience, and available resources currently guide which approach is utilized. It's not a recommendation. It's just stating objectively what is there out in the literature. But despite this, within a year, you have publications like this, which confuses us in this era of information technology and information explosion. You have MIPD remains non-inferior to open surgery for clinically relevant grade B and grade C POPF, but is strongly associated with significantly lower rates of post-operative pulmonary complications and surgical site infection. MIPD can be adopted safely with good outcomes irrespective of annual center resection volume. This is music to the ears of those who do minimal invasive surgery. Kalai would tell us this in the debate, and we would all get confused between what is right and what is wrong. We need to glean and understand data much better. Abu Hilal is a good friend of mine, but I disagree with him based on the available data. And I will tell you why. Because this systematic review with meta-regression, the heterogeneity was up to 100%. So don't compare apples with oranges, reach conclusions, and get into PubMed. You are only confusing yourself. You are not showing how highly evolved you are in terms of science, and you are sending out a wrong message to our surgical fraternity. So are these premature interpretations based or biased by personal opinion? So regarding MIPD, we heard of those two trials. They showed some advantages, but then we had a problem with the LEOPARD trial. So no RCTs on robot-assisted pancreatic procedures as yet are available. I'm preparing the background for you to understand how I will try to suggest we can have wider and better adoption. So I'm not losing focus, and I don't want you to get a feeling in this talk that I'm talking of open versus MIS, but it's a difficult subject to, I need to give you a big background. We have big data coming up, 11,000 patients, 10,000 retrospective studies. It does appear to be safe and feasible alternative to open PD with similar overall survival. So you have cancer outcome also in retrospective data in a large meta-analysis. So yes, maybe for LAP PD we have, and that's why LAP is also a procedure which continues to be done all over the world. The Japanese came in the picture during the COVID times. Again, I was a part of this, and LAP and robotic PD performed by surgical experts with satisfactory surgical outcomes documented. And they came to the conclusion, Japan has been very circumspect, very driven by data, very much like Germany. Only two countries, I would say, in the world would look at data very critically. And they are very careful in adopting, not just for insurance purposes, but also for quality outcomes, adopting minimal invasive pancreatic resection. But Nagakawa and Nakamura are leaders, and they concluded that there is a need to transfer the knowledge of 25 expert surgeons to surgical trainees. And their conclusion was that MIPD experts suggest that surgical trainees perform resection based on precise anatomical landmarks for safe and reliable MIPD. This underlines the importance of what every surgeon must always know from day one. You better be good with your anatomy. You can't say you see things better because of lap and robot, and you can't see with your own eyes when you're training in conventional open surgery. We can't discover new anatomy because of magnification. We should anyway know anatomy. Now, this LEOPARD trial, again, a number of my friends, and in this group, 32 surgeons from 17 centers were trained prior to doing the LEOPARD trial. And even then, they had to stop this trial. Dr. Ramesh raised the doubt of things which were perhaps unethical or not ideal. And then you have a situation where they concluded that experience, learning curve, and annual volume influenced outcomes. So you have this situation where, again, this is a requirement, what needs to be done. You need experience, learning curve, and annual volumes. A good meta-analysis. Why is that so? Because it has looked at only randomized controlled trials. It has not looked at all studies put together. You know, shit in, shit out is what can happen with meta-analysis. Here, it's only RCTs. And the conclusion in 2020 was LAP PD, no advantage over open PD. So this is 26 years after Michel Gagnère started the first LAP Whipple. High risk of bias, moderate to very low certainty of evidence even within the randomized control trials. Future studies, they suggest look at patient safety during your learning curve and also look at potential role of robotic surgery. So you can see the kind of momentum that we have gained in robotic surgery. I'm a part of the ISGPS, and we have concluded again that you still require, based on data, long duration, high conversion rates, poor oncologic outcomes, perhaps increased mortality in low volume centers is a matter of concern. This is again documented, not my opinion. In the early learning curve, patients and their disease outcomes are being disadvantaged is what people think. So today we stand here. I took you through everything from the Leopard 2 to Miami to the meta-analysis from Heidelberg to the Japanese group from 2019 to 2022. That's the kind of progress. And now we want to ask, MIPD should be done for whom and by whom? And for that, we need some sort of objective comparators as well. This is an old slide of mine, and I'm glad that Kalai also showed this. Jennifer Seng published this 17 years ago. You require about 60 cases to master this surgery, just 60 cases to negotiate your learning curve. Remember one more word, it's no more the learning curve, it's also the proficiency curve. Proficiency is something beyond learning in pancreatic surgery. The robotic surgeons, after having negotiated their open surgical learning curve, both in terms of learning and proficiency, have added this new dimension. The biggest group of robotic surgery in the world, you just heard Melissa Hogg before my talk, and they require about 80 cases to reduce your operative time, 40 cases to reduce the incidence of pancreatic fistula, which is a life-threatening complication which no pancreatic surgeon enjoys. So it's a long process. There are no shortcuts to this. And again, I've been a part of this, that standardization of surgical technique will help you to negotiate the learning curve in open, laparoscopic, and robotic pancreatic surgery. There is a systematic review here, and there is also a proposal for standardization. Just ask ourselves how many of us, when we go back to our practice, to our institutions, are actually documenting these things objectively, the way the Germans and Japanese would, because that's the only way that we can really grow as a surgical fraternity for MIPR. What's the ground reality? Look at the percentage of the world which is high income, which is dark green. Look at the upper middle income group, which is Russia and China predominantly. Look at the lower middle income group, to which India even today belongs. And then you have the low income and so on and so forth. So a large proportion of the world belongs to the low middle income countries, low income countries, and some of them belong to the middle income countries. And if anyone in this audience tells me that money is not important when it comes to my practice, I'm very happy for you, but I don't know whether that is reality in our country. There are three words which are important in this busy slide: accessibility, availability, affordability, and then the last is acceptability. If you have accessibility, availability, and affordability, acceptability comes rather easy. But these are the genuine problems, and I know this slide because I had to give this lecture in Australia last year, which was talking about access and barriers to major GI cancer surgery as a keynote speaker. And so I've done a detailed analysis as to what happens in middle-income countries and low middle-income countries. So now robotic surgery in our situation, you have financial implications. You don't have surgeons who are trained. The team which supports the robotic team in the operation theater, that dedicated staff is also not trained. The opportunities to train are not easy. A number of robots are bought without a training console in the same OR to cut down costs. We have infrastructure problems, though we are getting better and better. And then the access for the lower socioeconomic strata to access this technology, again, is a problem. You will keep on feeling that I'm only telling you problems. No, I'm making you aware of problems for you to know that it's not so easy. This is a study, again, from Australia. Implementing a new surgical robot platform costs over 1 million. Can I take 2 or 3 minutes more? Implementing a new robotic surgical platform costs over $1 million and an additional 3,000 to 5,000 US dollars per surgical procedure. Do your homework and see whether this is going to be wider and quicker and easier adoption in day-to-day practice for all of us. I'll share with you the thoughts of what Tata has done. We have developed a number of centers in other parts of the country. We try to establish standards of care. I personally do this for GI cancers, but my colleagues do it for other cancers, whether it's in Varanasi, in Vizag, in Guwahati, it will happen in Bhubaneswar, so on and so forth. I trained in pancreatic surgery in Germany. We could establish something in Mumbai, and we have got people all over the country in a matter of 2 decades who are doing the same surgery that I learned in Heidelberg. So I've enjoyed this process of being a catalyst and to mentor and guide people further. But while doing this, as a cancer specialist, I must make sure that patients go home quicker, faster, with optimal outcomes, because they also require chemotherapy. Doing a Whipple's is not ending our job. They must get adjuvant therapy so that they get a chance to live for 54.4 months with modified FOLFIRINOX. But it doesn't happen with 1 and 2 cycles of chemotherapy. The ground reality is adjuvant chemotherapy is effective only if completed to 6 cycles. And 50% patients do not get it because you have post-operative complications, cancer spreads early, patient's performance status is poor, or they have comorbidities. This is the ground reality when you want to give oncologic outcomes. So let's not focus only on technology. This is Tata data, not important, but we do far more multivisceral resections now. In the last period B, we have done 197 in a matter of few years. This will be out in the British Journal of Surgery very soon. We do these kinds of resections more routinely than ever before. A celiac axis resection for you to see something which is normally considered unresectable pancreas cancer. Vikram shared with you this slide about the volume of work that we do, but that's not what I want to show you. I want to show you that on this background of this volume, we have done so many robotic pancreatectomies. So the blue bar, starting from the first one, which I did with Ashwin D'Souza, which was resection, robotic, and then open surgery for anastomosis in 2014. Now you see the blue bar where every week we would try our best to get one robotic theater and do a well-selected case like Vikram showed very nicely. So do we have unanswered questions? This was a question asked by the chairperson. Tumor size, proximity to critical vessels, BMI, previous surgery, neoadjuvant therapy, MPD size, which is better, lap or robotic? How do we standardize training, and can we standardize the learning curve? These are unanswered questions even today when it comes to high level of evidence. So to summarize in this last slide, evaluate your evidence critically, remain a scientific surgeon and don't become a technician. Precise anatomy and standardization is what we need for wider and better adoption of MIPS. Learning and proficiency curves need to be negotiated and you need time. So if you want to be a robotic pancreatic surgeon, please don't do 50 other surgeries. Then you spend your time, energy, everything, your years of it into doing that one thing and you will become a master. But it needs time and patience. We have to develop our own instrumentation, which can be more reusable and cost effective. We have got new robots coming. Hopefully that will also improve the wider adoption of MIPS. But don't work only with technology. If you improve the perioperative care and cut down costs of a whole procedure, people will take to MIPS better. If there is clear evidence that MIPS reduces cost, I think more of us will embrace it very quickly. But cost is a major hindrance to us, but don't compromise quality. Wider implementation of training programs. Tata is going to get its second robot, but Tata is one place. JIPMER is one place. We will have to develop more and more centers like this, but train the trainer is important. I'm still in my proficiency curve learning. I may have done some basic learning curve over 10 years gradually, fortunately in Tata, but proficiency curve is another ball game altogether, and that is also going to take time. And we, of course, need to see how we can work with policymakers, governments. Don't forget Ayushman Bharat, which is the ground reality in our country, and the industry will be crucial to ensure that we have availability, accessibility, and affordability. Only then it's possible that we can improve and have a wider adoption. Sorry for the delay in this talk, but it was a little complicated talk, so I've taken too much of your time. Thank you so much.
Thank you, sir, for excellent and enlightening talk. If there is any query, comment on from the audience side, then we'll take all.
Sudeep.
The Minister of Ayushman Bharat asked you, should I want MIS metrics of people?
So I will have to say that we need to sustain this technology and you should fund it, but you should fund it on the basis of quality audits. It can't be funded as a unilateral decision across all teaching hospitals, all district hospitals. It can't happen as a generalized thing, which you can do for standard surgeries, or even a standard Whipple will be done in many more places. But a minimal invasive and a robotic Whipple, they will have to follow a pyramidal system and objectively evaluate it. Do we have those processes? I don't know. But this is what I will objectively tell them. And even for open Whipple, we have worked with Ayushman as well. And not just for open Whipple, a whole list of procedures I have worked with Pramesh. We have huge challenges, but it's not easy. So we need to work more with them. Yeah. Yeah. Correct. Correct. Yes. I think it would be worthwhile because we haven't buried robotic surgery by saying that it is a disadvantage and should not be pursued. So we also need to pursue this. We can't say that the evidence is so staggering against robotic in terms of access, availability, affordability, don't give. We want them to give. But whom to give, how to give, and how it is credentialed is going to be important. And then, for example, in Tata, the good thing about the robot is that the clear mandate is that you cannot use it only for private patients. 50% of my work is for poor patients and subsidized patients where they hardly have to pay a little bit extra for the robotic approach, which you saw today morning, the same robot XI, me, Ashwin, colorectal, Vikram, all of us. And the remaining 50% patients, they have to pay about 1.5 lakh rupees more, which is also much less. And perhaps not, that's why we are having problems to even sustain the robot if I look at 10 years from now. So we have challenges even in the private sector in a place like Tata. But that's what I will tell Ayushman if they approach us.
Sir, one question from here. Generally, whenever we talk of MIS robotic, we think of Da Vinci. Now Indian versions are also coming. Anyone having experience in?
I personally don't have experience, but I'm sure that if the technology does become cheaper and is fairly good, it will have its place. So I'm aware of people who are buying different robots, including our SSI Mantra, which is an Indian robot. The people from UK have met me. I've known of Hugo. So there is a new Japanese one, which is also a very good robot. So if costs do come down, it will be embraced more easily. But again, if we don't do a good job as surgeons, we will give this entire technology a bad name by being bad surgeons, which we are not. So we have to choose what to do and what not to do. Yes. Yes, sir.
As you indicated the importance of the brain to animal, and as being the most populated country of the world, and still making the trained surgeons and trained technicians. In such scenario, do we have enough data which can stand against MIPS in favor of open dentistry?
So this is again speculation. The question is, we have a huge potential for data. Do we have documented data? Yes. We have very less. If we document it well, I think most of the clinically relevant questions can be answered by this country, no other country in the world. Yes, but we are talking in an air-conditioned office. The reality is different. We need to document more. I don't want to criticize our own country, but historically also, we are somewhat poor in documentation. And the Japanese and the Germans are the best. None of the others are as good as these two countries, in my opinion, for documentation. Maybe the Scandinavian countries also come together and do a good job, including the Dutch, but very few, not in Africa, not in America, not in other parts of the world, not in Australia.
Those data.
Yes.
Where exactly the newer biology of our patients may be a little different than
But this is all speculation, sir. It may be the same also. For that, we need to disprove them with our own data.
Yes.
That's important.
Maybe.
When we talk about the minimum find a rectum, have a different pathophysiology as far as the rest of the work. So we take it in a different perspective as far as the management. Now, do we see that the right half of the pancreatic surgery is in the left half of the pancreatic surgery? They were different as far as the minimal access surgery is given, and they should be taken in a different way. But when we talk about the pancreatic or duodenectomy, it has a different ballgame than actually. So probably if we see the learning curve and the process of a distal pancreas, so whatever the pathology it is, it would be as good as any other laparoscopic.
That's why Kusheri is great, because in 94 he already told you the insult of the surgery inside compared to the insult of the surgery on the abdominal wall is an important ratio for you to decide. So the acceptance of distal pancreatectomy, which is a resectional surgery without reconstruction, is a completely different operation than a pancreatoduodenectomy with complex reconstruction. So 10% of the world which is only doing lap Whipple, the left pancreas, perhaps 30% of the world is already doing laparoscopic or minimal invasive left pancreatectomy. So acceptance comes more easily based on complexity and ease. Less time, less technology, less money, and you can do a good job. So you will accept it more easily.
Thank you, sir, for an excellent talk. After this extreme high level talk, I think we should conclude this session with a lighter note, sir. Two Sundar asked me, is the MIPS is part of MIPH? So I think, sir, you should change the acronym first. So I think we'll end the session. I would like to invite our speakers for felicitation. Dr. K.S. Patel, sir, we felicitate Dr. Vikram Chaudhary. Please, sir, you come on the dais. Dr. Bhagat Vaishnav, Dr. Lakshman Khuriya, we felicitate Dr. Bhagat Vaishnav. So, Dr. H. Ramesh, sir, please, you also come on the stage. Dr. Manish Nanda, we felicitate you. And Dr. Shailesh Shikhande, sir, Dr. Jitendra Mistry and Manish Gandhi, sir, will felicitate Dr. Shailesh Shikhande, sir. This moment, like when it's happening, those who are outside Gujarat, they might not be knowing what is happening. Thank you, AG, for giving me this opportunity. Next minute.
Thank you, our moderator, Dr. Naresh Gopani, sir, and all the chairpersons for their valuable presence and all the lectures. It was a great experience trying to know about minimal invasive surgeries regarding pancreas. And now we are complex organ, moving from one complex organ, that is pancreas, to another complex organ, that is liver. I hope that it will be made simpler after the lecture. I would like to invite our next moderator, Dr. Chirag Desai, sir, to moderate the next session, which is on liver. And I will also take the opportunity to invite our chairpersons, Dr. Shraddha Bhatkar ma'am, Dr. Diwakar Jain sir, Dr. Abhijit Vegadia, and Dr. Harsh Shah. I hope everyone has had their teas and waiting for the next upcoming lectures. I will hand over the mic to Dr. Chirag Desai, sir. Thank you so much, sir.
Good morning, everyone. And after a very exciting session on pancreas, we are now moving on to a session on liver surgery. And I welcome all the chairpersons, Dr. Shraddha Bhatkar, Dr. Harsh Shah, Dr. Ankur, and Dr. Diwakar. So, we all need sort of roadmap for all surgeries. And the same is true for liver surgery also. And first talk in this session is by Dr. Hitesh Chawda. And he's going to talk on hepatic segmentation and role of intraoperative ultrasound for all surgeons. So, Dr. Hitesh, please.
Thank you, Chirag. I thank IASG and Bhavin and his team from Zydus for giving me this opportunity. I'm going to talk on segmental anatomy and intraoperative ultrasound. As you all know, liver surgery is very challenging, and majority of the patients, they have underlying liver disease. Many tumors are locally advanced, and it's a big challenge, and we must know the proper anatomy and is also prior to surgery. So functionally, liver is divided into two lobes, right and left lobe. It has dual blood supply, hepatic artery, portal vein, and there are three hepatic veins, right, middle, and left hepatic vein, and there is a biliary drainage. So universally accepted classification for segmental anatomy is Klonow, but there are many other classifications which were there in the past. But most of the liver surgeons, they follow this classification, which has 8 segments, which has all got its own arterial supply, venous drainage, and bile duct. So there are 8 segments. Segment 1 is a caudate lobe. Segment 2, 3, 4 forms the left lobe. Segment 5, 6, 7, 8 forms the right lobe. And it has got these 4 vertical planes. Right hepatic vein divides anterior and posterior sector. The middle hepatic vein divides the right and the left lobe. And a plane, that's called umbilical plane, which runs from falciform to IVC, divides segment 4 and segment 2, 3. And a line between the right and the left lobe is called Cantil's line, which runs from the gallbladder fossa to IVC, which divides the right and the left lobe. So this is the classical classification that everybody follows. It has got a significance in the surgical relevance, and this is how we call a resection, and the classification which is commonly used by hepatobiliary surgeon is from IHBBA Brisbane 2000 classification. So this orange area is right hepatectomy, that is segment 5, 6, 7, and 8. Similarly, segment 2, 3, 4 is called a left hepatectomy. So everybody talks the same language. Similarly, right anterior sectionectomy, right posterior sectionectomy, segment 4 resections, left lateral segmentectomy. This is the terminology that everybody follows now, especially in our part of the world and the Western world. So a monosegmental resection or a bisegmentectomy. So this is how, and of course, an external resections like right trisectionectomy or left trisectionectomy. So this is how a classification of segmental anatomy is done, and everybody follows this. This is important because when we consider an anatomical resection, if you ligate same area of the blood supply, for example, this gentleman had a tumor on the left side of the liver. We know that there is a right supply and there is a left supply. So if you clamp one side of the hepatic artery and portal vein, just like this, you can see a line of demarcation. So this is a congested area. You can resect this. So this will have a proper anatomical resection. So this is how a segmental anatomy is very, very important when we plan a resection. Each and every segment can be separately dissected and resected when we know this anatomy in detail. There is an interesting concept which was published by Takasaki, and he said that liver has got 3 segments: the left lateral segment, middle segment, and right segment. This is called a Gleasonian pedicle approach, and this is a very useful approach when we are planning a surgery for segment anterior sector or posterior sector. And if you want to dissect segment 6, 7 or segment 5, 8, it's a very, very useful technique. We just ligate that pedicle. So you can see here the right pedicle is isolated. This is called Gleasonian pedicle approach. This is right anterior and this is right posterior pedicle. So if you just clamp that area, the liver gets congested. So here we are performing a tumor resection for segment 5, 6 tumor. So you can see right posterior sector is clamped, and you can see a very nice line of demarcation between segment 5, 8 and 6, 7, and you can do a resection. So this is how an understanding of segmental anatomy is very important. So there was a huge development in the field of surgery in the form of understanding the anatomy, lot of guided surgery, Gleasonian pedicle approach, ex situ, in vivo, ex vivo resections, anterior approach for large tumors, hanging maneuver. This all has made liver surgery very safe, and we can do complex resections now without major blood loss. The post-operative care has also improved, but an intraoperative ultrasound has got a very important role in the armamentarium of a liver surgeon. In spite of having all sophisticated preoperative CT, MRI, if you do an intraoperative ultrasound, it's a very, very useful tool when we perform a major liver resections. As you can see, it is significantly affecting hepatobiliary surgeons. In terms of liver surgery, it identifies new lesions and it can change plan of surgery, and also for pancreatic surgery and also surgery. So intraoperative ultrasound was practiced in 1960s and 1950s. Initially, it was used for renal stones and for kidneys, and eventually, Mr. Makuchi or Professor Makuchi, who developed ultrasonography intraoperatively for liver tumors. So this was the first probe that he invented, which was like a finger by Aloka, and this is a flat probe which was invented in 1979 by Toshiba. And eventually there was a huge development on the machinery side. New machines and probe came into picture, and it was started giving high resolution image of the liver, and we realized that intraoperative ultrasound is very important in terms of finding new lesions, nature of the lesions, changing plan of treatment, and also doing intraoperative ultrasound, intraoperative Doppler during a major surgery. It is very sensitive for colorectal liver metastasis to find new tumors, to find the location, the proximity of the tumor to the vessels. It is operator dependent, and all the surgeons have a learning curve performing intraoperative ultrasound. Regarding the technical aspects, there are various machines available now. A very good machine that we see now is by BK Medical. It is a very sophisticated machines with so many probes. This is the older one, that is Hitachi Aloka machines, mainly used by Japanese. And this is a fusion machine. And also we have machines from Philips, GE. So all these machines are available with a lot of variety of probes. You can see there are so many probes available depending on what area ultrasound. But in hepatobiliary surgery, we usually use this eye probe or a micro or a large T probe. This is a bioplanar probe. This is for laparoscopy, and this is a robotic probe. So these are the variety of probes that we need to have when we perform intraoperative ultrasound. This is the standard convex probe that we use for a general examination of liver when we just try to find out the lesion. This is a small T probe. When we want to do an examination in segment 7, segment 6, when we have not mobilized the liver, it easily goes to that area and find out any lesion or anatomy. And this is another high frequency T probe, which is also used for the same manner as other probes. So using this probe, we'll find out location of the tumor, which is deep-seated, and it is very useful for metastatic disease. When we are performing metastasis, it may not be seen on surface. You have a roadmap intraoperatively, but intraoperatively, the roadmap. So you must do an intraoperative ultrasound, find out the lesion, have a proper margin, and resect it. So you can see here a metastectomy is performed. It is a very deep-seated metastasis. So intraoperative ultrasound is a very, very useful technique, particularly for metastatic disease. You can see it is very deep-seated. So, and we have started logging ultrasound, intraoperative ultrasound now, radiologists. So this is how a metastectomy is performed. And once we resect it, we also confirm that we have resected it with a proper margin, putting a probe on it. So this is how it is performed. This is a new probe, which is called a bioplanar probe. This is by VK and this is by Aloka. This is a very interesting probe. It has got, it will give you an axial and sagittal together. You don't have to rotate the probe. So you can have the same information. So this is an axial plane and this is a sagittal plane. So with one probe, you can see an axial image as well as sagittal image. So it becomes very faster for you to decide what exactly you want to resect. And it's a very versatile probe which is available in the market. It's called a biplane probe. This is a laparoscopic probe which has got a flexible tip. And this is a drop-in transducer for laparoscopy. So this is available because many centers are performing robotic surgery now. You just drop the transducer inside the abdomen and a grasper will hold the probe. We'll do an intraoperative ultrasound. We'll check the area of the tumor and mark it and resect it. So this is a very versatile probe which is available. And it is very flexible. It has got a flexible one, and with the grasper you can hold it and perform intraoperative ultrasound for liver resection. So this is another probe, very similar probe by Aloka. You can see this is during robotic surgery. You can find out the lesion, mark it, see the area of proximity to vessels, and then resect it. So this is how a robotic transducer is used during intraoperative ultrasound. Now, there are various techniques described. You have to have a proper exposure when you do intraoperative ultrasound. The liver has to be fully mobilized. There is something called a long liver technique where you have to do a zigzag examination to make sure that you don't miss any data. You hold the quadrants of the liver examined, and same thing is done on the surface of the liver to find out the lesion. You can see the same anatomy that you will see in the CT scan. So as you see, all hepatic veins will be similarly seen. Once you focus your probe towards the heart, you can see the confluence of hepatic veins. And when you focus towards the portal vein, you can see the portal vein anatomy, any thrombus, any tumor proximity, everything can be seen during the surgery. Now, the implication is to find out and to resect. And there are tumors which are very proximal to vessels. And for example, in case of colorectal liver metastasis, we even can perform R1 resections. I mean, just detach the tumor from the liver. This gentleman had a tumor which was very, very close to the right portal vein. This was a resection. So the tumor was not seen on surface examination. So intraoperative ultrasound was performed and the tumor was resected after clamping the vein. So this is a very important technique of finding out the location of the tumor, proximity, and resect it. And there are various other techniques like injecting a dye and do congestion in that area, that segmental resection, and also compression technique. Put a finger at the bottom, compress the vein with the help of probe, mark the area which is congested and resect it. So this is a very versatile instruments which is helpful for resections. There is something called contrast enhanced ultrasound, and it is very useful for HCC as well as colorectal liver metastasis, depending on the enhancement, a decision can be changed at the time of surgery. Differential from dysplastic nodule to HCC, and it can be resected. So this A pattern patients should have resection. These B pattern patients, they are not resected. So this is a very useful technique for HCC and also for colorectal liver metastasis. After 2 to 5 minutes of contrast injection, it will show this black hole. So all this area are metastatic area and can be easily seen, especially patients who have steatotic liver. So this is a very useful technique of resecting it. And of course, ultrasound-guided biopsy, ultrasound-guided RF ablation, this all can be performed with the help of this technique, and use of intraoperative ultrasound in liver transplant to see for vascular anastomosis, the flow, the velocity, everything is very useful at the time of surgery. And the current evidence also shows that it has got a huge advantage when performed for colorectal mets and also for HCC, and it improves the recurrence-free survival when performed at the time of surgery. This was very useful, very interesting paper that I found, and it has shown that in modern liver surgery, the intraoperative ultrasound is a very, very useful technique when we perform with the contrast enhanced. We can also do a real-time elastography, and all this method makes it very, very versatile. I'm going to show you a small video of multiple liver resections which were done for colorectal liver metastasis. So this lady had a multiple mets which were resected, which were seen only on MRI, and had about 5 liver metastases which were detected on intraoperative ultrasound. All these mets were identified and resected. I'll just run. So you'd have to dig it, have a proper margin, and resect it. So all these metastases were resected. She had primary surgery for colon cancer, had multiple liver metastases after 2 years. So all of them were resected. So you can see an ultrasound-guided resection. This was close to the left hepatic vein, and multiple mets on the right side. This was near the gallbladder fossa at the top of the hilum. So all these were resected. So intraoperative ultrasound is a very useful technique. So to summarize, I would say that liver surgery, it is important to understand and have a proper knowledge of anatomy. A preoperative imaging is very important. For intraoperative ultrasound, it's a key procedure and every surgeon should know it. And it provides a crucial information in open as well as laparoscopic surgery. A role of endoscopic ultrasound, especially contrast enhanced, is evolving and is promising. And it has a learning curve. Sit with your radiologist. Radiologists are your friend. Just try and understand what exactly they are trying to say and learn intraoperative ultrasound. So we do liver update. We have done about 15 liver updates so far. Our next liver update is in December 2024. I invite all of you to join us in Ahmedabad in December. Thank you.
So intraoperative ultrasound is a very useful intraoperative tool. And so what do you use it for day to day? What is the commonest use that you do apart from transplant?
See, ultrasound we use for almost all the patients now. And what we are doing is, I have trained my assistant to handle the machine because it is difficult to use the switches. So once it gets hang, it is very difficult to start. So my assistant knows how to start it, and now we just want to see the plane transaction and the vascular anatomy, proximity to vessels and everything. For transplant and Dopplers, of course, radiologists will come in the theater. But we use it for almost all the cases. We keep the machine in the theater. And we use the conventional, we have a T probe, but we use the conventional convex probe because the liver is already mobilized. You don't need more probes.
So any question from the chairpersons or audience? Any comment? Ankur?
I think Sir has made a very good point that we should do it in all the cases. All the liver cases, we should try to do intraop ultrasound because there is a steep learning curve, I think, in this area also, because as a surgeon, we are not trained in ultrasound. So I think that's a good idea that you should do it in all cases.
It's not difficult. I mean, because you see CT scan every day, you have to just correlate it. So it's easy. If there is any complexity, if you need to do a Doppler, small vessel, all this, then if you need to find smaller mats, you call radiologists. Otherwise, we do it on our own now.
Sir, apart from this colorectal liver mets, do you find its relevance, intra-op ultrasound relevance in any other important area?
HCC also, when it's a large HCC, you want to see flow in the remnant liver, all this. Suppose if you are doing an external dissection, if you want to, if you are going very close to the vein, hepatic vein, so at that time we keep an ultrasound probe with us and just check at the different stage of resections. Dr. Sudeep?
Here is a PAD care. So you can use an ultrasound. That is your registered as a PAD care. So which is why a lot of people call the radiologist and pays the. So each surgeon doing an intra-op ultrasound needs to be registered as a PAD.
You can register yourself for that. The machine is not registered under your name. If machine is registered in the hospital, the machine is. And that's all you know. So obviously, but any certainly you only thing is machine to register it. Real is next in the hospital.
No, but you need to be registered. No. You need to be registered.
Actually, we had 16 them also.
Reports? I mean,
It is very different data. That is hospital data.
Yeah. So you are using the machine. You will write the report and you need to be registered. You cannot generate a report unless you are registered.
Yeah, you cannot.
I mean, this is an important point. We have to check.
Yeah. It's registered.
Sir, and
the machine is registered to the institution, but the surgeon does need to have a license to use the machine.
Location is defined, but the user has to be registered.
Interesting.
Actually, as you say, sir, it's very important to know knobology. This field is called knobology. According to the machine, a YouTube video is available when I start learning, because it's very frustrating when you don't know the knobology of the ultrasound, because it's need a lot of hand-eye coordination. So you should be well versed with it, so you don't spend time on the knobs rather than doing an ultrasound.
Especially if you have multiple machines, radiologists will send you different machine every time. Then you are stuck. You repeat the switch.
Even radiologists struggle at times. Okay, thank you, Dr. Hitesh.
Thank you.
Now we move on to the next talk, and that's on how I do it. It's a talk by Dr. Unnikrishnan Nair. And the talk is on standardized pure laparoscopic right hepatectomy.
It's a request to all the people who are standing in the corridor. Slightly, can you please make some less noise, because it's detrimental to the sound over here. We have been trying to tell them, but so. Thank you so much.
Yeah. Good afternoon. My name is Dr. Krishnani. I'm from the transplant SPD team in Amrita Hospitals. So I'd like to thank the organizers for inviting me and for conducting such a nice conference. So I've been asked to give a 15-minute talk on lap donor hepatectomy. So I'd like to start off by saying that our unit doesn't do much lap donor hepatectomies. We've done maybe only about 45 or 50 of them. We do mainly robotic, but I think there's already a robotic talk. So we'll present our one of the last lab cases that we have done. So coming to the steps of the procedure and the video, the ports that we put are the standard 5 ports, as most lab centers do. And ideally, such a very small patient so that you have good space for mobilization and operating. So this is one of the ideal case, a case that we had done about a couple of weeks ago. So you start off by mobilizing the falciform. We use the harmonic, you can use hook, you can use scissors, and the point is to go back and identify the hepatic veins. You have to identify the right and middle groove, especially if you're thinking of hanging the liver. So it's a harmonic is an instrument with the jaw open. It actually dissects off really well, and you can get a good exposure. And you can see the right and middle is well dissected. Now we go down to mobilize the liver. So it's best to first go and expose the cava as much as possible, so you know exactly where it is, you know what you're dealing with. And there's always a few short hepatic veins that will be there. If it's less than 5 millimeters, you can just divide them off. If it's slightly larger, you might want to keep it until the end to prevent congestion. So once you've mobilized the initial lower part of the cava completely and divided the inferior hepatic or short hepatic veins, then you move on to dividing the lateral ligaments. And this again can be done using the harmonic, or it can be done using a hook or a scissor, or whatever you're comfortable with. And the assistant or the surgeon, whichever you're comfortable, can use the gold finger, and that actually gives you a good hold on the liver. So this is again the lateral ligaments being taken off. It's important to stay in that areolar plane. If you venture a bit deeper, you might hit the diaphragm and get a cautery burn, which you should avoid. So the liver will be lifted up fully from right to left until you're over the surface of the cava. And now you can see the liver is fully moved up. The assistant is holding with the gold finger. And now the aim is to divide all the veins. And you go all the way up until you hit the makuchi. You don't have to divide the makuchi, but if you want to hang, you have to divide the makuchi to do a hanging technique. So in robotic, we don't generally hang, but if it's a very small liver and if you have a good exposure like this, you can go ahead and hang. It makes the transaction a bit easier. So the makuchi, like we all know, will be a lot of kind of fibrous tissue like this that can be taken with the harmonic. And there'll be 2 or 3 small veins, like you can see. If they're small, you can clip it like this. Or if they're slightly larger, you can staple it also. So here the veins were quite small, so we clipped it. And once you remove these makuchi veins, you get a good vision of the groove between the right and middle. And then you can slowly develop that and put a silicone Foley's, which we use for hanging. So this is just dividing the last bit of the makuchi, and then we'll do hanging. The importance of hanging is your transaction plane just has to follow that tube. So your plane doesn't venture towards the right or left, and you don't lose your plane. It's much easier if you do the hanging technique. But again, if it's difficult to divide the makuchi, then you can go ahead and do it without. It's not an issue. So here we develop the plane, and we're just going to put in the silicone tube. Once this is done, your mobilization is over. And you can go on to now dissecting the hilum, which is the second step. So hilum dissection starts with a cholecystectomy. This is just developing the callo, dividing the cystic artery. If you want, you can divide the cystic duct at this point and use it as traction. Or if you're getting adequate traction without that, you can just continue to portal vein dissection without dividing the cystic duct. So here we're using the cystic duct as a traction upwards, and we start opening the tissue laterally to visualize the portal vein. So the main aim is to loop the portal vein. If you're especially hung the liver, you have to loop the portal vein and artery to get the tube behind so that you can complete hanging. So you first dissect anteriorly over the portal vein like this, and you can see the groove between the right and left. Here, luckily, the anatomy was type 1 portal vein, so it wasn't a major issue. And then once you've anteriorly dissected, you dissect the portal aspect of the portal vein. So here there can always be a vein. There's always consistently a small caudate vein that comes from the portal, right portal to the caudate. If it's getting in your way of this dissection, you can divide it. It's not a big issue. And once you've dissected posteriorly, then you can go ahead and put a loop around the right portal vein. So here you can see we've just dissected that, and now we're going to loop the right portal vein. Once this is done, you have to then dissect the artery. Again, the artery should be dissected and looped and moved away from the bile duct. This particular case was a biliary anatomy type 3B, 3A, sorry, where the posterior sector bile duct is joining the CHD. So there's 2 bile ducts in this particular graft. So the portal vein is looped, and now we're going to separate the artery from the bile duct. What you see topmost structure is actually the 3A bile duct, and below is the artery dissected, and you just have to kind of separate it off the bile duct. So bile duct division time
the artery is safe. Once this is done, you take the lap vascular clamp, springies, and you can demarcate the liver. So we put a small springy on the right portal vein and on the right artery. You can either demarcate using the congestion like most people do, or you can give ICG at this particular point and see the left lobe filling and demarcate accordingly. So here we've used ICG. Now we're just going to inject ICG. It's not so clear in this video, but when you look directly at the monitor, it's much better. You can see the left lobe filling with ICG and the right lobe is more or less not filling. So we look at the ICG picture and we look at the congestion and we mark the plane. And you mark down onto the groove of the right and left and through the center of the GB fossa. Once the marking is done, you move with putting rubber bands. We suture rubber band on the right and left of the transection plane so that you get some good traction during your transection. We put a Foley's catheter around the hilum for a Pringle. We do this kind of routinely for every case now. We've done a randomized control trial also with Pringle, without Pringle. We'll be publishing it next month. More or less up to 45 minutes of Pringle time for every donor. There's absolutely no change in the post-op LFTs for the donor or for the recipient graft function post-op. It's fairly safe. So we use a Pringle standard. Once your Pringle loop is done, then you can start the transection. So the transection starts always with the caudate, exactly at 12 o'clock position on top of the cava. You transect, you can use a harmonic, you can use a CUSA. We prefer to use a harmonic. You go as far posterior as possible. Again, be careful if there's any inferior hepatic veins. You don't want to cause a bleed at this point. Then you start the transection. Unlike open, where you go anterior to posterior transection, in lap and robotic, it's always inferior to superior. So you start with transecting with a harmonic, opening the capsule inferiorly down to the duct, and then you go anteriorly and open it further. So here is just starting the transection inferiorly. We prefer to use in lap a CUSA. Robotic obviously doesn't have a CUSA, so we use the bipolar forceps Maryland, and then we use scissors. So in lap, any vessel that is less than 5 mm, you can safely take it with a harmonic. Anything more than that, we put metal clips or hemlocks. So the transection also at this particular point, when you're starting your transection, it's very important to have the anesthetist bring the CVP down to below 2 is what we're comfortable. So you can tell them not to fill the patient at all, give some Lasix. If they need to maintain the BP, they can start some inotropes. Keeping the CVP low will actually keep the field very dry for at least the first 1/3 of transection without any Pringle. So the CVP is kept low. We're starting the transection with the CUSA. It's very important that the CUSA stays on the left side of the transection plane so that whatever vessel comes up, you can divide it and keep it onto the right. The aim being that the graft we use is a modified right lobe graft. So that means that we take the first half of the MHV on the graft side and then we cross over. So the second half of the MHV stays with the donor. And then the MHV is reconstructed on the bench. So this is the first 4B vein that's coming up. We'll open further the whole transection plane capsule with the harmonic anteriorly. Typically, we'll have 2 or 3 4B veins. You divide all of them and keep the vein on the right side. And when the MHV is a good enough size to reconstruct, you can cross over. So here we're dividing the first 4B vein. So again, you can use harmonic in robotic. We use harmonic to do the transection because there's no CUSA. And you can keep the jaw open and it kind of works like a CUSA when you activate it with an open jaw. But in lap, again, you have the luxury of having a CUSA. So here we are transecting more further up. And you'll see that we see 2 more small 4Bs. That vein coming up right there is a 4B, which will dissect and divide. So you have 1 down there and you have 1 up. So once those 2 4B veins are divided, we use hemlocks to divide them. Once they're divided, you transect a bit more and you'll find the main MHV stump. Whenever you're transecting these veins, it's best to have, if you're using hemlocks or clips or whatever it is, 2 on the donor side for safety and 1 is enough on the graft side is what we follow. So now you have the 2 4Bs divided. We dissect a bit more with CUSA and we find the main MHV trunk and we loop it with a Vicryl thread. So now we found the main MHV trunk. And at this point, we'll cross over the MHV. So we're dividing the MHV now with hemlocks. So again, like we discussed, 2 on the graft side, 2 on the donor side and 1 on the graft side. So again, it's important to do all the planning preoperatively. In a good CT, you should know exactly what the venous anatomy is. Once the MHV is divided, sometimes you'll have 2 big segment 8, sometimes you'll have only 1. In this particular case, there was just 1 8, and that's what's coming up now. This is the one significant segment 8. Once this is divided, then all of your major vascular, structures that come in the transection plane should be over. And then this is where the hanging bit comes. If you have not hung the liver, then you have to find the cava surface and follow the cava surface to complete the transection. But if you've hung, you can take both ends out like this, and then you can just follow the tube. It makes it much easier and much safer. So now in that tube, there should not be any more major vessels. You can continue with the CUSA. Any small vein can be divided with the harmonic. And then once you've completed this, your transaction is done. So once the transaction is finished, the only thing remaining is the vascular structures, the hepatic artery, hepatic vein, portal vein, and then the bile duct. So now we'll divide the bile duct. We use ICG. The hilar plate has to be brought down. Once you've dissected down the hilar plate, you can clearly see the right and left bifurcation. Now we've looped the right and we're going to divide the right. You can cut it and suture it, which we do in robotic because suturing is so much superior. But in lap, we prefer to use hemlocks. Again, 2 on the donor side. If you want, you can put 1 on the graft side. So now the right main duct is divided. Like we said, this is a 3A anatomy. So there's 1 more extra hepatic duct, which we'll divide after this. Again, that is divided with hemlocks. So this is the extrahepatic duct. Now, as soon as this is done, then there's only the vascular structures left. We make the fan and steel incision below, open the skin, the muscle. We develop that plane all the way down to the peritoneum and we keep it ready. And once the fan and steel is made and we're ready to take the graft out, then we go and divide the vascular structures. So now the duct is divided. The fan and steel has been made. I have not shown that in the video, and we're going to go ahead and divide the vessels. So we're just looping the hepatic vein with a thread. So now the right hepatic vein has been looped. And then now we will just divide the vascular structures and finish the case. So this is dividing the artery. We use a hemlock, medium hemlock, green, for dividing the hepatic artery. 2 hepatic arteries on the donor side. And it's important to have a really good sharp scissor. You shouldn't end up crushing and injuring the artery when you cut it. It should be 1 or maximum 2 clean cuts on the artery. So the artery is divided. We're going to just cut it now. And then we'll proceed and divide the portal vein. Again, the portal vein can be divided. Some people prefer staplers, some people prefer clips. We always prefer hemlock clips. We find that the vascular stapler, you lose a couple millimeters of length. So it's much easier to use a hemlock. So again, 2 hemlocks on the donor side, 1 hemlock on the graft side. Anyways, the graft side, you have to open it later. Now the portal vein is divided. Now the only thing left is the hepatic vein, which we use a Signia stapler, gold reload. And usually 1 staple is enough. You just have to be careful that there's no clips or hemlocks on the cava, because then you can end up tearing the cava. So once you've safely put in the stapler, you just fire it and then that should be done. We put in a large endo bag to kind of get the liver into the bag after all the vascular stapling is done. And then we pull it out through the fan and steel. So the donor hepatectomy is done. We take the liver out. Then you go back and inflate. It's important to see hemostasis once more. So now the graft is out. We just wash. We make sure all our hemlocks are in place. Staple line is clean. Bile duct clip is in place. Portal vein, artery, all the hemlocks look good. There's no narrowing. It's important to fix the liver. Once the liver is fixed, put in a drain, and that's it. The case is over. Thank you.
Thank you, Dr. Oni. Now, Professor, she is on the line, so we'll go for his lecture first, and we'll do the question answer for you afterwards. So, there was we can go for So, Professor Vagabayashi, welcome to ISG midterm meeting. And everybody is delighted to have you online. And we are looking forward to an excellent talk by you on the robotic liver resection. Where are we now? So you can proceed with your talk.
I see. Thank you very much for this kind invitation. Can you hear me?
Yes, yes, we can hear you.
Yeah, but I think if I can present my keynote from my side, or maybe, okay, it's fine. Thank you. So let me start. I'm going to talk about robotic liver resection. Where are we now? Can you move forward?
Yeah.
No conflict doing this. Okay. So when we started the lap liver resection, of course, I had a fear for bleeding, and also we suffered ergonomic stress. Then we thought robotic surgery would be better. Change, please. Next. This is our initial experience with robotic hepatobiliary pancreas surgery. It was published in 2011. So next, please.
Yeah, yeah.
So we performed 4 cases. Actually, we realized that these are the first robotic hepatectomies starting from July 2001. And I know Piero Giovanotti also did his first case in 2001. And when we met, we discussed which one was first. So according to intuitive record, mine's first. Anyway, next, please. So we asked our graduate student to perform a system review of robotic liver resection that time. Next, please. So we found out maybe 10, 15 case series, and we realized that the robotic liver resection is safe and feasible in experienced hand, but it requires expert patient-side surgeon with advanced laparoscopic skill. That means that we need 2 surgeons. Then, but we realized that wristed instruments are useful in a variety of maneuver, such as looping a Grissonian pedicle. Even that time, we realized the Grissonian approach is very much suitable for robotic liver resection. And also, if you, in case encounter a massive bleeding, you can suture in a vena cava, hepatic vein as well. Next, please. So later, we asked our ex-fellow Ruben Cilia to conduct robotic liver surgery systematic review. Next, please. He accumulated 2,700 cases, and we realized that when we compare with lap versus robot, robot is worse than the blood loss and operative time longer, and but the robot and open are quite equivalent. Next, please. And actually, cost analysis revealed that. Next, please. Robot is most costly compared to lap and open. Next, please. So this is like, lap versus open. Lap is much better than open. Next, please. But when we compare robotic versus lap, it's not so different. Next, please. So, what is the impact of robotic surgery? It's a high rise. And faster than lap. And it might be beneficial for complex resection and also better images resection, less complication, while time hospital stay. Next, please. However, since that systematic review conducted in 2021, many papers published from many different countries, and especially Brian Go's data collection. So 21, next, please, next, please, next, please. So yes, So most papers said a robot is better than lab. Next, please. Okay. So at this moment, I feel robot is very much easier for me, for myself, accommodate from lab to robot. So let me change a little bit, talk different. So we've been doing limited parenchyma sparing anatomical resection. Next, please. So anatomic resection gives you a wider margin, but you have to preserve more parenchyma. Next, please. Yeah, yes. And the Chinese group published a nice paper in the JAMA Surgery. They advocate that you have to preserve the parenchyma as much as possible, but doing anatomical resection, you have to accommodate yourself using a cone unit theory. That was advocated by Professor Takasaki back in 1985. But unfortunately, this paper didn't mention anything about ICG and also didn't mention our paper, which we published the definition of segmentectomy and segmentectomy. Next, please. We've been using laparoscopic anatomic resection from hilar plate using a negative staining, ICG negative staining, and we have accumulated almost 100 cases of colorectal liver mets and hepatocarcinoma to measure long-term survival. Next, please. As we can see, even the hepatocarcinoma, we can achieve over 73% overall survival, even colorectal liver mets, 60% overall survival. Of course, we've been doing this as in our policy, so we have no comparative study. This is one policy, one cohort. But when we compare this data and publish the paper, I think it's good. It's better because we have less blood loss and, of course, background is different, but less complication. That probably results in the longer survival. Next, please. So this paper published by Japanese NCD data almost 4 years ago, 3 years ago, up to 2017 in our country. Every year, we perform like 23,000 cases of liver resection, whole country, but 5,000 to 6,000, at this moment, probably 7,000 cases of minimally invasive liver surgery. So penetrating rate is around 24%. But most liver surgery by lab is a wedge resection, partial resection. Next, please. From those data, top 10 high volume center of advanced lap liver resection in Japan. That means, over monosegmentectomy, two-sectionectomy, such like this, and Ageo Central General Hospital. Next, please. We are the #1, largest number. Next, please. So when I look back my data in our country, we started the laparoscopic Whipple, inviting Piero Giranotti to proctor us, 2017 February. Since then, we gradually increased the number of robotic Whipple, but in our country, 2020 robotic Whipple became a reimbursement list. So, and in 2022 robotic liver resection became reimbursement list. Next, please. So this is our liver resection, minimally invasive liver resection. So laparoscopic number is decreasing, but robotic liver resection is increasing. And this year, up to now, robot is much larger than lap liver. Because for me, I'm an expert of lap liver surgery, but for me, it's more comfortable using a robot by sitting operation and magnified magnification with, as I said, Grissom approach is more suitable for robotic articulated forceps. Next, please. So this is the data from Intuitive. They don't disclose the actual number, but I suppose 2020, probably whole Japan, only several cases, but last year, 400, 500 cases are whole country. As you can see, this exponential growth in our country. Next. So what are the real advantages of robotic hepatectomy? Next. Steady magnification. and articulated forceps. Next, please. I can show you two examples. This is a hepatocarcinoma located in segment 6, protruted type, but this is just one Brisson pedicle of segment 6. That means, we're going to perform one cone unit resection covering a protruted type of segment 6 tumor. So this is a robotic segment 6 subsegmentectomy for hepatocarcinoma. This is a double speed. So we define what is the subsegmentectomy and segmentectomy, and we refer ICG. We use ICG, IV injection, ask anesthesiologist to 0.5 milligram per body, very light doses. And we also use DICOM data as a navigation data in the Tyro during the surgery. Then we routinely perform a Pringle maneuver. Then we started to cut. We started open luveal sulcus to visualize the posterior trunk. And actually, this is the one Brisson 6, 6, which we wanted to ligate. So we open up luveal sulcus a little bit. Then we take G6. Then the G6 is bulldog clamped. Then we again checked if this area is correct, no blood flow. And before we inject the ICG, we use contrast media for ultrasound. Then we see a demarcation line on the surface like this. And all around the area to be resected should be superficially divided first. Then the area to be resected become movable. So even during the parenchymal transection, you see a nice demarcated ICG coded area and no coded area. This is the exact intersegmental plane. So finally, G6 is a double clipped and divided. So once we started to use the intersegmental plane for resection, intersectional plane, we only encounter hepatic vein like this. So hepatic vein should be divided or should be preserved. So liver resection becomes much simpler. Once you encounter the blood vessel, you should remove or preserve. Then the segment 6 subsegmentectomy is performed, finished. So we saw some ICG shining a nodule, and we sent it to frozen, but it's not cancer. It's hepatocellular adenoma. So finally, next please. Another example is this patient, hepatocellular carcinoma. Patient is 90 years old, and we try to preserve as much as possible. We initially try to perform a posterior sectionectomy because he is 19 years old. But instant green retention test is 9%, so should be correlated to right hepatectomy. Because we realized during, Grayson approach, posterior trunk is covered by tumor itself. So we decided to perform right hepatectomy instead of right posterior sectionectomy. So this is the main portal branch, Grayson branch for right. Then it's clamped, and see the nice demarcation line. Again, we ask the anesthesiologist to inject 0.5 milligram per body ICG, and before ICG injection, we made sure to the perfusion area, non-perfusion area by ultrasonogram, contrast medium. So we started superficial parenchymal transection all along the way to the right hepatectomy area. Then this is exactly quite the same as preoperative simulation. We use, by the way, a double bipolar method for a parenchymal transection. We try to expose the mid-hepatic vein and also referring a green. So it's exactly this on the plane for ICG coded area. Then the B5 is divided. And again, we just following color coded area, non-color coded area. Then we only encounter the hepatic veins, a crossing, a preserving. So this is the main hepatic vein, main mid-hepatic vein. We should preserve. This is the V8. We should divide. So our liver resection becomes much more simple once you know how to perform a Graysonian approach and how to perform ICG negative staining and how to perform intraparenchymal Graysonian intersegmental sectional parenchymal transection. By the way, this is a cholangiogram. Then we can finally divide the right portal pedicle peripherally as much as possible. So parenchymal transection keeping using a double bipolar method, and the paracable portion of the left side paracable is preserved. Then we try to expose middle vena cava, anterior face of vena cava. V8 is now divided. Another V8 is now divided. So finally, short hepatic vein is clipped, and the right hepatic vein is taken. Then right hepatic vein is staple divided. So there are two main hepatic vein drainage from the tumor. One is short hepatic vein, is enlarged, and another one is inferior right. It's also enlarged. So we use the staple to divide those two drainage vein from the tumor. So finally, we're going to mobilize the right liver. I think it's safer. This is also our way for laparoscopic right hepatectomy. Mobilization should be the same. So, you feel fine. So this patient is a 90-year-old patient, and it's a cholestatic hepatocellular carcinoma, nicely removed. Next, please. Next. So actual patient, 90-year-old, only 8 postoperative day by walking like this. Next, please. So robotic liver resection benefits elderly patient like this and will become a standard of care soon. Next, please. So thank you very much for listening. Next, please. So we're going to host a single topic conference on October 1st and 2nd in Kyoto. Next, please. Theme will be simulation, navigation, and robotic. As you know, Kyoto has a history of a 1,000-year capital in Japan. So food is really good, authentic Japanese food you can enjoy. Next, please. So abstract, re-extended, will be the end, this will be the last extension. So the deadline is the next Monday. If you haven't submitted any abstract, please submit. And also we hold a 3 preoperative pre-congress hands-on seminar using robot, ICG guided robotic anatomical liver section supported by Intuitive, and will take place in Kobe. And the next one will be precise laparoscopic liver section using CUSA in goats, supported by Integra in Narita. This will be organized by Goro Honda. Next one. So this is a made in Japan robot, Hinotori. Rubina, it employs a Rubina and the double bipolar method and water jet. So you can enjoy parenchymal transection by water jet, and also you can enjoy IR camera Rubina. It's much better than the camera now and Da Vinci has. Next, please. So I'll see you all in Kyoto. Next. Thank you very much for this kind invitation. I wish I could be there, but I always appreciate my team. Thank you. Next, please. Thank you very much for your listening.
Thank you.
Thank you, Professor, for a wonderful and enlightening lecture. So is there any question from the audience? We have time for about 2 questions before he goes away. Any comment from the chairpersons?
Thank you. Thank you, sir.
Thank you, sir, for your presence and your talk, and we all enjoyed it thoroughly. Thank you very much.
Thank you.
So, Dr. Unni? So we go back to our previous talk. We didn't have time for question answer for that. So is there any question for Dr. Unni Krishnan for his talk on laparoscopic right hepatectomy?
that we are leaving the segment only the donor side, the baby of who is not there. So you have some preoperative and or monitor is the non-nature of this.
So the first question, Foley's, Pringle, I guess. When do you do Pringle was the first question. So we do Pringles mostly in all cases. Initially, our unit never used to do Pringle. The belief is in a donor. You should be very careful. Then when we started the robotic program, we started doing Pringles, especially around the MHV division part or towards segment 8. If something bleeds, we would quickly put a Pringle. Even though it's a hepatic vein, theoretically, you'll think it won't bring down the bleeding, but it significantly brings down the bleeding. It becomes more or less dry. So we thought we'll do it as a RCT, and we've done quite a large RCT, 100 in each group, with 3 Pringles versus no Pringles. And there's absolutely no difference in either one of those groups. We've presented it. We're publishing it also. So now our unit has gone to a standard Pringle technique where we do a Pringle at MHV division. Also at the bile duct division, the hilar plate can bleed a lot. So at that point also, sometimes we put a Pringle, but we never go more than 3 Pringles. We've had no issues with post-hepatectomy liver failure for the donors. The patients that we've had a few issues have been more because they were fatty livers and we've gone too far on the MHV and other issues. It wasn't from the Pringle. So Pringle, I think, is safe. Our unit believes it's safe. The second thing about the modified right lobe, 4B is always taken. Only then if you don't take 4B, it becomes a graft without, that means you're dividing segment 5. So it's a graft without MHV totally. So 4B is always taken. Modified right lobe means 4B is divided and you divide the MHV before 4A comes. So the donor keeps 4A and the second half of the MHV. The graft keeps segment 5 and MHV on flow. You reconstruct it with the PTFE or Dacron or whatever.
You need to use it and second question is village feeding will be handled by using donor machines, things will be less than around 10%. So do you think the village feeding when the center thing based on your
So Pringle is not needed, definitely. Probably most centers in the world don't do Pringles. It's not needed. It's just done. You can bring down the blood loss. In our paper, you'll see 200 or 300 ml is less. And more than bringing down the blood loss, I don't think 200 ml or 300 ml makes a big difference to the final patient outcome. It's more about speed and it's more about a clean transaction plane. Even if you go on the Cantill's line, you'll still have a small portal pedicle that crosses. You'll still have some veins that you don't see on the CT. So it is much cleaner when you put Pringle on. Again, you don't have to. I said we do 3, but that's maximum of 3. Sometimes we use only 1. Definitely when we're going to go under and above and loop the MHV, we definitely put a Pringle on just because it happens much faster and it's much cleaner. But you don't have to do a Pringle. Most centers don't do a Pringle. Yeah, we always do. Many centers like Dieter Breuering and many of the other robotic centers, they always standard divide at segment 5. You can, there's no problem, but your reconstruction of the MHV will be a much smaller vein and it can get thrombosed. Even ours, that being said, probably 60 or 70% of the MHVs get thrombosed, but it gets thrombosed by 1 month. So what we have seen and published also is your MHV only has to be on for about 3 to 4 weeks. If your MHV is on by 3 or 4 weeks, your graft is hypertrophied and you're okay. Even if it thrombosis, nothing will happen. It's the early thrombosis that causes the problem. Our unit believes smaller the vein, the chance of an early thrombosis is higher. So we always go when the MHV is slightly larger so that reconstruction is possible. Warm ischemia. Lap versus open, you mean? Is it a difference? The difference is only 3 or 4 minutes. It's all about having that fan and steel ready so that when you actually divide, you can just put your hand in and take out the bag immediately. So there's no difference. It is longer. It's longer by maybe about 3 to 5 minutes, depending, but it has no impact. We've published our series of 400 cases. There's no difference in graft outcomes and this thing, warm ischemia.
Dr. Naik.
The center has essentially whenever it says the closer. What are the indications when you do an open donor?
Open donor hepatectomy. Initially, it was all complex anatomy, obese patient or large graft more than 1 kilo. So the first 100 cases, we would do only straightforward cases. After that, we changed to our complex graft. We've published that where we take type 2, type 3 portal vein, we take complex biliary anatomy, big inferior hepatic, obese patients, 1.5 kilo grafts. Definitely, it's more difficult. Even lifting the liver and mobilizing is sometimes impossible. So it's much more difficult, but over our learning curve, we have shown and published 100 cases that are straightforward anatomy and 100 cases that are complex anatomy. With experience, it's exactly the same. There's no difference. But again, it is much more difficult. But now our unit does every anatomy. We do open only if the patient cannot afford robotic. The bench part. So initially, because there's no tactile feedback, we used to have lacerations when trying to lift these big grafts. So there you'll have to put some fibular inside, take some stitches and all. But other than that, it's more or less the same. The reconstruction is the same as open. You're putting we don't use a vein graft for portal vein. We use always a Dacron. So the Dacron reconstruction MHV is exactly the same open and robotic. It's only sometimes you have lacerations, which is mainly in our initial learning curve. Now it's not there.
Excuse me. Was there any difference in the post-operative morbidities in the donor in laparoscopic versus open, especially the biliary complications, biliary leak or pictures?
So robotic versus open is what we've published because we've not done that much lap. It's all robotic. So the biliary complications was higher in our first era. We've published in eras of first 100, second 100, third 100. Of course, with learning curve, there was some bile leaks, but that has come down. Now it's essentially the same. So because actually we feel now that even bile duct division is even superior than open because you have ICG, you can really clearly see when you cut. Whereas in open, it's a little bit more blind and out now that we think about it. ICG, it's much more under vision, the cutting of the right duct. So complications are about the same.
Dr. Nair.
Hello.
An excellent video. So it's an outflow. You staple the vein on the liver side. So do you put a patch or something on the hepatic vein while you're reconstructing? Because the right vein will become very narrow because it means lesser in the open. We put a clamp down and divide, so the wider right hepatic vein. Do you feel that it has an outflow problem?
Yeah, in open, we put the clamp down, you get a slightly better cuff. In robotic, yes, because of the staple has 2 layers, sometimes 3 layers on each side, depending on which staple you lose some length. It does retract into the parenchyma a bit, but you just have to suture the Dacron to that using 5-O-proline is what we use. We don't have to put we never put a cuff. We just, segment 5 is anastomose to Dacron, then you connect segment 8 from the side, and then you go and put it as a single outflow to the RHV. We do not put a graft.
And the last question, you put a clip on the donor side, bile duct. So do you get sometimes more ducts on the recipient implantation compared to the, when you do a duct division, does it thin out because you are putting a clip? You usually free cut, so there will be sheath around the bile duct. So
the graft side clip is what you're talking about.
Yes, yes.
We never put it. This particular case we had put it because there was a second bile duct, and we had ended up putting it lap. But in robotic and in lap, but mainly we do robotic. We never we just cut it. What you said is correct. It thins out and it can even kind of crush the vessels and the vascularity of the duct. We don't put a clip.
Thank you, Dr. Unni, for your talk. Now we move on to the debate. And it's a debate on 4 centimeter size HCC at segment 4, transplant versus no transplant. And we have 2 speakers, Dr. Sudeep Shah and Dr. Anand Kakkar. And as far as I'm told that this match is not fixed. So now Dr. Sudeep Shah is going to talk for non-transplant. Dr. Sudeep, please.
PDF. PM. Thank you, Chairman, sirs, and thank you to the organizers for this absolutely beautifully organized, very hospitable meeting. The match is actually been fixed by Professor Go Wakabayashi, who showed a liver resection in a 90-year-old. I don't think anyone in their right mind would think of transplanting 90-year-olds, 80-year-olds, 70-year-olds, the people with all sorts of comorbidities and have them strolling around the next day. So I think the first thing is to set the parameters of what we are debating, to be fair to Anand so that he has something to say. So out of 100 people with HCC, you might want to transplant 1 or 2. So let's have an even playing field. So you have a group of patients with localized HCC, CT, chest, abdomen, bone scan, PET scan. The majority will be cirrhotics. So out of your group of cirrhotic patients, there will be a group of cirrhotic patients who will merit transplant for sick livers. You will not even try and operate on these. So these we will exclude from the debate. Of the HCCs that you will see, they've smartly chosen a 4 centimeter HCC, which is within criteria. But that is not the only criterion. You also have to think of things like alpha fetoprotein, whether all the 3 markers are positive or not. So we could summarize the criteria to be no vascular invasion. So we pray for that. And there are clear-cut candidates within this. So if you had a sick liver and HCC within criteria, you'd obviously go for transplant. You were non-cirrhotic, you'd be stupid to transplant, you'd obviously go for a resection. So what we are talking about are those patients who are within criteria, maybe some who are beyond criteria, where because we have lots of relatives in India or lots of money where we can make some relatives, you would consider living-related liver transplant. So Anand would say, why transplant? So removal of the entire liver is the most radical surgical operation for HCC, no denying that. And the background pre-carcinogenic liver is removed. So this is the kill 2 birds with 1 stone hypothesis, which we are all familiar with, that you get rid of both at the same time. But unfortunately, there is also kill 2 patients with 1 operation hypothesis that we can get into, because donor mortality for LRLT is a small, definite, and in India, completely underreported pathology. Even if you're doing a cadaver transplant, you are actually depriving someone else, because cadavers are few and far between in India, as we all know. So someone else who's deserving of a liver who doesn't have a live donor, his life is being deprived because you are performing an unnecessary transplant where a resection can be used. So why should we not transplant? Transplants are inherently risky. Worldwide, the mortality of transplant will be 5 to 6 times more than that of an equivalent resection. Tumors recur even in transplanted organs. There is a native disease recurrence. Alcoholics will recur, NASH will recur. In fact, diabetes and hypertension will worsen with immunosuppression after transplant. Hepatitis C recurs, hepatitis B recurs. It is risky for the donor living-related liver transplant, and huge logistics about the cost and availability of liver. So on all these fronts, liver resection wins. So this is a very fancy English word. It is equipoise. And what it means is that you have to balance the risk versus the benefit. So we need to balance the chance of recurrence, the risk to all involved, and you do not deprive a deserving other, because we know that donor livers are a rare commodity within our country. Surgery is effective as a cure in a child's acirrhotic. And for a 4 centimeter tumor within segment 4 of the liver, surgery, anatomical resection, and we've seen many videos during this workshop on that, ICG guided, would definitely be a curative option. So how does this compare with transplant? So it is very, in all meetings, we want to look at the literature. So I have put up the literature. So this is an old meta-analysis, which starts in 1991, as you can see the top here. There is a recent one. So these are all the studies. This was published in 2022. Now, the problem with this is that though these studies look impressive, and maybe Anand will say that all this favors transplant, there is not a single randomized control trial. So how is this meta-analysis being created? This meta-analysis has been created by figuring out within your center, these are the ones I've transplanted, these are the ones I have resected, and the outcome for this group is better than that group. So now, for example, you have a 90-year-old patient and a 25-year-old patient. You will transplant the 25-year-old, you will resect the 90-year-old, and guess who will have the longer 5-year survival? Whether it is a very obvious finding. So there is absolutely no literature, no randomized control trial on which we can base our conclusions. And there is 90% heterogeneity in this meta-analysis. And this is therefore a meaningless comparison. We know about the Milan criteria on which we are basing our transplant outcomes, that within this criteria, we are not really going to get a recurrence. But what is all this data based on? We are talking about resecting a 4-centimeter tumor. We are talking about transplanting a 4-centimeter tumor. But are these really equivalent? And try and understand this. The data is based at the size of tumor on transplant. So transplanting a 4-centimeter tumor is not the same as listing a 4-centimeter tumor. When you transplant the 4-centimeter tumor, the tumor is 2.5 centimeters at listing, or 2.5 centimeters when you start your workup and your committee takes 1.5 months to give you permission for it to actually go ahead with the transplant. You're counting your outcomes of equivalent survival on what you are seeing in the graft. When you're resecting a 4-centimeter tumor, you are seeing in the OPD today and you're operating in 3 days' time. So your 4-centimeter tumor which you're resecting is actually a 4-centimeter tumor. But when you look at the equivalent transplant outcomes, you should be comparing it to 6.5 centimeter tumors, which will then be dangerously outside the Milan criteria. We know that for Milan criteria patients, resections also have a 5-year survival. And this is the data I put up. This is from the Hong Kong group. And this is the ELTR registry, I think 22,500 patients. And look at the 5-year survivals for transplant for cirrhosis in various etiologies. Even without a tumor, you'll find that the 5-year survival is exactly the same as 75%. Because transplant itself has an intrinsic mortality. A certain amount of primary non-function, a certain amount of rejection, a certain amount of technical complications like hepatic artery thrombosis and sepsis, bile leaks will intrude. You get a small amount of tumors post-transplantation, a certain degree will go into renal failure. All these will be 2%, 4%, but all these add up. And there is no series of transplant which will tell you that there is a 90 or 95% survival at 10 years after transplant, even in the absence of tumor. The question here is that who will tolerate surgery? We have a Western view of the BCLC criteria where you have a child Super A patient, solitary lesion, normal bilirubin, platelets more than 1 lakh and no portal hypertension. All transplant surgeons would love to transplant this patient because your transplant will end in 3.5 hours without transfusion and you will have a spectacular outcome. But these are wonderful to resect. And you are going to get an excellent 5-year survival with these resections. The Japanese are a little more aggressive. You would see a bilirubin less than 2, no ascites, some portal hypertension, and good ICG clearance. In this series, you'd have maybe a mortality of 2% with the resection, but you would still have a mortality of 5 to 7% in this population over 6 months with a transplant. So a tumor like this, I'm sorry, I couldn't get pictures of the exact 4-centimeter segment for lesion. So this is 6 centimeters, open resection, segmental, perfectly feasible, 10-year survival, no recurrence, time to treat the hepatitis B, because these patients are diagnosed with tumor. They have an ultrasound, tumors detected, then you find out their hepatitis B. You have time to treat the baseline liver. because not only have we progressed in the skill of transplant, we have also progressed in the management of the underlying pre-carcinogenic liver. So our management of hepatitis B, hepatitis C has revolutionized, management of NASH is improving, and we can also now reduce the incidence of having recurrent tumors in this group of patients because you are taking down the inflammation, which is the carcinogenic insult in this group. So when we look at series in 1990 and 95, those don't represent values because the recurrences were very high after resection. Now with good viral control, you have an excellent outcome. And if you have a lesion like this, you go ahead, you do a laparoscopic resection, you have recurrent foci of tumor, you have the option of salvage transplant, and with minimally invasive liver surgery, which is the theme of this conference, the transplant does not become more difficult because you have hardly any incision. There are no adhesions with portal hypertension, which make your transplant difficult. And someone with the skill of Anand will easily be able to do these transplants without any additional morbidity. And I'm sure he'll be the first to agree to this. So salvage transplantation is definitely the way forward. In this meta-analysis, which I showed, those who had enhanced surveillance had a far better outcome as those who had a non-enhanced surveillance. So then you get an equivalent survival because you're looking for new tumors and you're transplanting them in time. So your transplant HCC actually gives you an idea of the biology. We know that those with poor differentiation will recur after transplant. Multifocality and satellite nodules can actually go and ab initio transplant. So you know that they're high risk and you can offer them an earlier transplant. And in future, they're likely to be molecular markers to tell you when to do the transplant, salvage transplant on size. So surgery is the best biopsy and surgery is the best bridge. So the first line treatment should be surgery rather than upfront transplant so you can weed out the bad performers. So to summarize, surgery is effective. It is easier, it is safer, it is 10 times cheaper. It allows you time to treat the virus or the background liver disease. It allows you time to judge biological behavior, and transplant will be rescued. LRLT to expand criteria, AFP in the thousands. This is a philosophical issue. You know, you need to be fair to the donor and the recipient family. You cannot say that the only chance to survive is an LRLT, ask a family member to donate, even if there's only a small chance to survival. So you cannot blackmail someone saying that your relative has a tumor, please go ahead with transplant. So in summary, biology is king and resection gives you a chance to find that out. Thank you very much. I'll end at this point.
Thank you, Dr. Sudeep. Now it's Anand Kakkar's turn and he will defend transplant.
Good morning, chairpersons, and my senior and the dueling colleague, Dr. Sudeep Shah. It's an unfair world, Bhavin and Daivat are such nice people, and yet they decided to pick a bone on you. Why would they give you a topic which was, foregone? I mean, it's unfair to give you this topic. He's already disadvantaged you by putting you on the wrong side of the truth. And I just hope that I'll be able to stand up against your giant persona and your eloquent vocabulary, which has made the audience so spellbound that it will be difficult for me to prove the truth, at least, truth itself. But I'll try. So hepatocellular carcinoma, and this is a picture with Tom Starzl, showing the kid that he had transplanted with a tumor beyond 30 years. And I thought it was very apt to present this at the start. So we have a lot of hepatocellular carcinoma on this planet because of viral hepatitis and a lot of other etiologies that lead to cirrhosis. And these are some of the earliest transplants, and most of the early on transplants between 1968 and around until 1980 were done for transplants. These are the first 7-8 cases, all of which were done for HCCs and cholangiocarcinomas and other liver tumors, and all of them did very badly. In fact, we didn't know how to select these patients in the beginning. And so at some point in time, it was considered a contraindication to transplant a patient with hepatocellular carcinoma. And up until Vincento Mazzaferro presented the Milan criteria, as is seen here in the European Liver Transplant Registry report, the early experience was large but dismal in terms of outcome, and therefore at a certain point in time it became difficult to continue the massacre. But once we realized how to select out patients who would do well, gradually, and again, the very proof that UNOS and every other registry or every other transplant organization across the world has decided to give extra merits, be it MELD exceptions or be it in any other form. They seem to favor patients in the selection criteria for allocation of livers to them. And what we are doing here between me and Sudeep Bhai is that we are trying to decide whether the rest of the transplant community across the planet is on my side or his, obviously. So I stand with like 1,000 transplant surgeons behind me and he stands alone. So similarly, it has also, this debate is more relevant also because we have seen over the years that the incidence and the cause of mortality has been rising, attributable to the increased incidence and prevalence of primary malignancies in the liver. Now, we all know this. This is like the first lesson that you learn when you start doing a transplant fellowship, that HCC, I mean, cirrhosis is a field change disease. It is, the entire liver is carcinogenic. And unlike what he has been harping on, viral hepatitis, hepatitis and hepatitis B and C maybe comprise about 30% of the transplant, but the other 70% are non-viral etiology related cirrhotics, and even they have a very comparable incidence of HCCs in them. And that is because it's a field change disease. The entire liver is carcinogenic in a cirrhotic milieu. It is the rapidly amplified rate of replication in a very hostile environment that leads to those errors in which there is a certain incidence of those fatal errors which allow the immortalized hepatocytes to become or to avail carcinogenic properties, like being able to angiogenetically invade the surrounding tissues, be a parasite at the cost of the rest of the liver, and so the malignant behavior. It is like saying that the land on which you are standing is poisonous, and that's why it is growing cactus. Now, what are you going to do about it? Are you going to change the land on which you are standing, or you will just pluck out the cactus? Who knows? The next cactus will grow right below your feet, and it will fix your feet to the ground with the cactus. The next tumor recurrence may be inside the portal vein, or it might be just outside on the surface, invading a peripheral intra-abdominal extrahepatic tissue, making your transplant futile and therefore the outcome dismal. The very fact that we have been trying to stage these hepatocellular carcinomas in many different ways than the rest of the tumors in the body, the TNM staging classification, does not stand up when it comes to hepatocellular carcinomas. We have a variety of other classification tumors, the Okuda, the CLIP, the BCLC, the AJCC, we know the most expanded criteria, the BCLC, also haven't stood the test of time. And then we have the Toronto criteria, and then we have the Medanta criteria, and the list goes on and on. What does it mean? It means that we have not learned yet satisfactorily on how do you stage these tumors in a way that you can select survivors versus not. And the best criteria that has stood the test of time is the size. Right from the time Milan criteria came forth, up until Joseph Lovett, Beckenstein, and Francis Yao, the UCSF criteria have been showing, and similarly BCLC as well, have tried to show that the biological behavior of HCCs is predictable based on the increasing size of the tumor. It somehow happens that the Pittsburgh TNM criteria looks at the number of loss of heterozygous foci on the genome, the number of foci on which the heterozygosity of the tumor genome is variant, and even something that is so deeply biological also correlates with the rise in the size of the tumor. However, the UNOS still considers this is basically thematically this is the concept why a rising size of the tumor should be guarding against, and that is probably the strongest predictor of the outcome in these patients with HCC. There are several non-surgical treatments of HCC, and Dr. Sudeep Shah, being an astute surgeon, dealt mainly with the surgical techniques, and there are other ways of dealing with these tumors if you decide not to transplant them, whether it's a senior citizen or other reasons. And probably the only thing that might stand up in this day and age is the emerging role of immunotherapy. But the rest of the others, they have always been proposed as a bridge to transplant. You call alcohol injection, acetic acid, radiofrequency ablation, whether it is cryotherapy, chemoembolization. Chemotherapy, we don't even need to talk about it, it's so futile. But everything else is essentially a bridge to transplant, indicating to you what the mindset and the proven belief has prevailed across the planet so far. And similar to him quoting literature, I thought if I should show you, if you start, these are I've kept it a little small so that the audience can usefully interpret. I think he was trying to hide the truth by giving so much data that I couldn't see across it. So here, starting from 1991 until the turn of the century, the recurrence versus the risk of recurrence following local resection versus the recurrence following a liver transplant is shown in red and blue on the top of the chart. And if you go through the details, you will realize that the risk of recurrence of the tumor following a local resection is incomparably higher as compared to the risk of tumor following liver transplant. And this includes those early series where the tumor size was much larger than what is afforded and accorded within the Milan criteria. Similarly, if you talk about patient survival versus tumor recurrence, which is actually the more relevant criteria, even there, if you look at the 5-year survival rate following liver resections versus following liver transplant wins hands down by a significant large margin. So, to summarize the data that I presented, the 1 and 5 year survival following resection is 25 to 72% versus that following liver transplant is 69 to 75%. The upper level is what he was talking about. I'm talking about the minimum versus 25 versus 69. That means there is no comparison. And if you talk about other ablative therapies which are non-resectional, even there, transplant is insignificantly superior. So this is the landmark New England Journal article from Vincento Mazzaferro, where which got Milan criteria its place into the UNOS recommendation and all other transplant societies recommendation, the 4-year survival of 75%, which was comparable to patients without a tumor. So when you transplant a patient within Milan criteria, you afford absolutely zero disadvantage to anybody else, because these patients with cirrhosis and HCC have an outcome which is in absolutely no way inferior to those patients who are undergoing transplant with cirrhosis but without an HCC. So I think one of the arguments that Dr. Shah put forth was that you are disadvantaging somebody with by transplanting the patient where a condition is already something that reduces the survival or benefit of using that scarce resource. Now, even in the utilization of the scarce resource criteria, the UNOS criteria or Milan criteria already defeats the point. Now, there are a lot of factors we use for risk stratification when you want to resect a tumor, and I've outlined most of them here, the same as he has said. But again, in spite of all these, we have, even going down to gene analysis as per the Pittsburgh TNM criteria, we have not found ourselves to be any wiser, to a point where even Pittsburgh does not decide the resection or transplant of a patient with HCC based on the criteria they promoted across the world. So this is something that I did as a part of my training, doing research on what are the criteria that would increase the lethality of the HCC tumors. And this is what I published, that even whether it is tumors within Milan, outside Milan, or outside UCSF as well, there are certain histologic features that you see in these tumors when they grow in size, which kind of makes them more malignant in their biological behavior. So with the current level of understanding that we have, biologicals, the size is the best predictor of the biological criteria. Talking about segment 4 is something that I don't know if Daivat Bhai and Dhiren Bhai wanted to emphasize us on the location being segment 4 because it was so specific. I want to say that 72% are on the right lobe, 2.8 in the caudate lobe, and 25% on the left lobe, of which a small fraction is in segment 4. And again, segment 4A being posterior superior in location has several disadvantages when you talk about either an ablative procedure where the veins are heat sink, as well as the diaphragmatic and cardiac movements being a hindrance to a precise ultrasonic location of the probe when you're trying to ablate or ablate the tumor, like I showed here. So these are several disadvantages of segment 4. So particularly if you're talking about segment 4, oh my God, you are further disadvantaged than what I already denoted. This is just the standard criteria to say that if at all you want to resect non-cirrhotic child, a single lesion, no meds completely, that may be the only little space in which I may concede to Dr. Shah, but for the rest of it, he has to concede to the truth, which is what I'm talking about. And I want to say that this is still the bottom line, and this is the moral of my entire conviction, and the reason why I stand up against what he wants to say is that please remember that we are not talking about in this talk the main, and in our country particularly. The emphasis is not just on the judicious use of a scarce resource. You're talking about what is most beneficial to an individual. Like, I am a patient or somebody near and dear to me has cirrhosis and an HCC. What is the best treatment for that patient? If you feel that the society or the liver transplant community may want to decide better on the judicious use of a scarce resource, and mind you, that is not the case. Whether it is UNOS, whether it is UKTX, or whether it is the Indian Noto Soto Rotos, they have all decided to favor the transplant of patients with HCC based on data, based on long-term survival studies and outcome studies, recurrence studies, yet they support that. But even otherwise, if you were to consider it for an individual, the most beneficial treatment for an individual is liver transplant. And you can take away the disadvantage, if you feel so, from the community by offering living donor liver transplant. That's what we do for 80% of the times. The acceptance of donor morbidity and mortality is something that we have accepted much before we start talking about transplanting patients with liver transplantation. Thank you very much.
Thank you, Dr. Anand. And Sudeep, you have half a minute to rebuttal.
Thank you. I think you've shown more or less the same slides, except Anand didn't have any reference after 2002. So in case you notice that. So I think this is a very important statement because the transplant community in India wants to transplant everybody. So, sometimes I feel if I go to, certain parts of India, I have to walk with my hand on my liver just in case while walking down the corridor, I might receive a liver transplant. But what you're saying is correct. As long transplant is the best option for tumor, as long as there is no donor morbidity, as long as there's no transplant complication, and as long as the person is affording. But all this, only the affording we know in advance. The morbidity and complications of transplant, we really don't know. So my statement is very simple. You have a much simpler, more effective, safe, universally applicable treatment such as resection. Use that to judge the biology and selectively transplant. And that is the worldwide philosophy of every guideline of every society, that if your HCC is resectable, there is no guideline, whether it's the American or the European or the Korean or the Japanese, which will say that you will transplant first. It will always say resect first and transplant later. So I just want to conclude.
Thank you, both of you. Okay. Yeah. You can also rebuttal.
Yeah. So I knew this is the statement that would come. And this is to say that, ultimately a lot of us propose what we know best. Like, if I am a guy who does more transplant than resections, I will say transplant. He's the guy who does more resections than transplant. He says resection. So this is where the belief comes from. But that's not the truth of the science here. So I wanted to put just, so this is what I wanted to say, that the risk of microvascular invasions as well as the risk of histological upgradation of the tumor is directly correlated with size. And this is a publication in 2022. I mean, I also knew that he would pick up on my publications. This Paulik et al. Is from 2022, as late as that. And he has also shown that the the incidence of microvascular invasions as well as the histologic, the rate of, anaplasticity of the tumor is higher with size. And while I may say that 20% only of the HCCs are in non-cirrhotic livers, where what he says may have a certain validity. But if you look at the 1, 3, and 5 years disease-free survival in non-cirrhotic livers also is inferior to the transplant outcomes for the same patients. And this is not just me. This is a guy, his name is Joseph Lovett. Joseph Lovett was the founding secretary of the International Liver Cancer Association, and the rest of the crew that founded this society. If you look at his literature, he has published extensively on this topic about what would be the best. There's something called individualized approach. Like, you're not talking about a society. When you talk about the society, you talk about rationing a resource, you talk about justifying it, like he said. Nobody talks about it. Nobody talks about it because that is the guideline on how the professionals should approach this, because there are only so many livers. But when you talk about an intention to treat analysis, when you talk about an intention to treat analysis, when you take a certain set of a number of liver patients with HCCs, cirrhotic as well as non-cirrhotic, and look at their outcomes 5 years down the line, those who were transplanted versus those who were resected or treated with non-transplant ablative therapies, what is the survival at the end of 5 years? And you will see that transplant wins, hands down, irrespective. Thank you very much.
Thank you. And in the interest of the time, we'll not have further questions, and we conclude the session. And we can.
Hello. Yeah. Thank you so much, all the respected panelists, all the respected chairpersons, and the moderator, Dr. Chirag Desai, sir, for their valuable presence. Moving on to our next topic. Probably if I ask 100 surgeons which is their favorite organ in the abdominal cavity, they would say, I think, gallbladder. Gallbladder, out of 100 surgeons, 98 would be agreeing that gallbladder is the best organ. And the same session, the biliary tree, we will call upon the next moderator, Dr. Kaushal Anand, sir. He's also a senior gastroenterologist who has been working in the field for a very long time. And the chairpersons for the same session, Dr. Sadik Sikora, sir, Dr. Rajan Patel, sir, Dr. Karthik Sutaria, sir, and Dr. Amit Shah, sir. Can we have all the chairpersons on the stage, sir? Dr. Sadik Sikora, sir, Dr. Rajan Patel, sir, Dr. Karthik Sutaria, sir, and Dr. Amit Shah, sir. I'll hand over the mic to Dr. Kaushal Anand, sir.
Yeah. Good afternoon, everyone. And now on the biliary session, there is some change in the sequence. And I would like to call upon my professor, Dr. Adnish K. Singh, to talk on how do I do it, robotic hepatical jejunostomy.
Thank you so much, Bhavin Dada and Daivat, for honoring my travel commitments, but I think the session is running late. So thank you so much, Chairperson sir and moderator, for giving me the opportunity. When you talk about we're looking at complex resection since morning, whether it's ripples, whether it's malignancies, and so on and so forth, we forget that the Achilles heel ultimately lies in a very, very insignificant looking anastomosis, and that is hepatical jejunostomy. I put robotic there, but the same applies exactly to laparoscopic. And I guess that a whole lot of you would be interested in doing this laparoscopically or robotically if you have the armamentarium. But the measures remain the same, because doing a complex ripples, or for that matter a colorectal cyst, or for that matter a liver resection, and then realizing that your bile duct leaked because you couldn't win out, you didn't pay much attention to the hepatic jejunostomy, is a big no-no. And that is why I decided to concentrate on different diseases and the same operation. So I'll present 3 cases here. Broadly, most of the hepatic jejunostomy that we do in GI surgery are related to either benign biliary strictures, colorectal cysts, or CBD excisions. And of course, a whole lot of them others as well, which are more complex than this, that is liver resections, pachyduodenectomies, or stone disease. I just picked up the first 3 examples of how I would do it, how I kind of standardize this, and maybe you can modify your own based on what I'm going to present. the salient points of, and this applies to laparoscopic hepatogenostomy as well, would be that you would need to retract the liver. And the way I do it is I use a Nathanson for the left lobe and the segment 4. And then you obviously need another small retractor at times using the assistant to pick up the segment 4 or the right lobe, depending on the anatomy you have or how much hang of the liver you have. Stabilization of the jejunal limb is very commonly done in open surgery. However, it's a big problem when you start off with this operation in laparoscopic or robotic surgery. If the loop is not stable, the suturing is very, very inadequate. And you might think I'm doing a good job, and that's why they leak. Enterotomies are generally larger. I have kind of generally standardized on a left to right approach on interrupted suturing. I have not desisted from, initially we tried continuous suturing. We completely gave it up because this particular method that I'm going to describe is pan-applicable to all hepatic genostomies, be it the complexity higher up or lower down. The leak test, well, you usually use a white gauze, and I'll tell you why ICG was not a good idea in testing leaks later on. In benign biliary stricture, ICG was not helpful because most of these livers tended to retain the ICG for a very long time. I'll show you pictures of that same. And so therefore, identifying the bile duct in a fibrous hilum was a very, very difficult proposition. Occasionally it helped. Majority of the times it did not help, despite waiting for 6 to 8 hours after the injection. Choledochosis, anyway, it was not very useful. Leak test, well, the problem was that you open the bile duct and you spill a whole lot of bile. So if ICG was there, it would stain the entire HDL. So looking, using ICG, I think I've heard Calais talk about this, it helps. To my mind, it doesn't really help in checking for a bile leak. This is my standard port position. Laparoscopy is slightly different because in robotics, you're far away from the target organ. Remember that you have to pick up a jejunal limb as well for Roux en Y anastomosis. Hence, you have to work in the infraocular compartment. Hence, this port position. I use 2 assistants, both of my residents, one on the right side, one on the left side. The left side one is usually the person doing majority of the job. The right side one is usually the person retracting the right lobe if required. And at the end of the day, those same ports are used for drainage of the orthohepatic jejunostomy. The first case was a choledochal cyst, a standard of run-of-the-mill type 4 choledochal cyst with some twists which I'll kind of describe here. And the twists are this, and this is important, that doing a choledochal cyst excision laparoscopically or robotic is no big deal. But looking at the small things is a problem. And that is, one of them is that usually sometimes you have stenosis where the left duct or the right duct joins the hilum. And so you have to look for that stenosis, because if you do a subhilar anastomosis and leave that stenosis intact, your HGI is not going to work very well. And second problem, especially in laparoscopy and robotic, is this is the anterior right hepatic artery. It's a big problem for you to anastomose there. You're looking for at the hilum from below upwards, not from anterior posterior. And the right hepatic artery comes in your way, and a big problem. So some of these points I'll touch on quickly. Since the operation has to be described in a whole, so that's the initial part of the operation. This is a choledochal cyst. I kind of skipped most of it, I'll guess. And that's the choledochal cyst, the stent being taken out, and the cyst being divided at the lower end, as low down as possible. These are not the crux of the talk, so I'll just kind of move them quickly up. Now, this is the cyst being divided in the subhilar location. Remember, you can see the right hepatic artery there, which is right now anterior to the hilum. Now, you have to move it posterior by mobilizing it somewhat and get this cyst up. Otherwise, anastomosing from behind the right hepatic artery is a big problem. And remember, there was a stenosis of the left duct junction with the hilum. So, opening the left duct in this particular case is a very good idea. And this anatomy has to look for in the cholangiogram before you choose the subhilar anastomosis. Beyond this, it is a matter of picking up the jejunal limb. And that's what I wanted to again describe here. So that's the retrocolic window and creation of the jejunal limb. Now, this is important. How do you stabilize? The way I described it is I tag it to the Nathanson retractor. You can choose any other way, but stabilizing the limb is important. Otherwise, precise suture placement can be a big problem. And we struggle with this in the initial part of our experience of laparoscopic or robotic. Unstable jejunal limb, and you are just floundering all over the place, you can't take a proper bite. And the inter-suture distance, suture thickness, all becomes a problem. You can see the left to right approach. It's not a pre-placed suturing. Hence, you keep on tying from the left to the right. Since the left is tied to the stabilizing area, which is the Nathanson in this case, so the right is free. So you keep on moving the jejunal limb and taking bites. all interrupted, fine suturing. Most of the suture bites are taken with backhand, and same is true for laparoscopy. It's much simpler to take a backhand bite in this case from duodenum to the duct than take a forehand bite. Most of the preplays are not done except for the last few sutures, because then the vision disappears. So 3 or 4 last few bites are pre-placed and tied at the end of the operation. That's the way I do the leak test. I found no better way so far, unless there's a PTBD in situ, wherein you can inject some water and check. Okay, sorry. Right, this is a extrahepatic cholangiocarcinoma, which again, I'll just show you the cholangiogram. That's a papillary mass in just the subhilar location and it was stented. Again, the operation is nearly the same, except in this case, the excision of the CBD involves all the lymphomuscular tissue, which goes with the CBD and the nodes. The Nathan becomes standard in most of my practice because it helps a lot in picking up a bulky left lobe and occasionally in good anatomy, the segment 4B as well. In this case, the CBD division was far higher, almost above the bifurcation with the septum intact. So that's the excision part of it. And the right hepatic artery was going posterior to the CBD. Hence, you have to dissect it completely of the cyst first. The lower end is marked with a clip in case margin is needs to require some radiotherapy. So that is the CBD we divided. Actually, it's just above the hilum with the septum, which is intact. So the right and left ducts can be seen separately with the retrieve. That's the ruling being prepared. Now, coming down back to the same issue. So that's again the limb being stabilized. Actually, let me just describe the same operation 3 times, but kind of making a few points. I'm not able to move this forward, yeah. So interrupted 5-0 monofilament, that's PDS, and left to right technique. You might question that you could do this in a continuous fashion. Well, you could, but from our experience of the benign biliary stricture, where an anastomosis sometimes winds and waxes all over the place, interrupted suturing has been standardized, at least in my practice, for this operation in all the renal anastomosis, at the hilum, that is. Hope I can. So last 3 or 4 sutures are pre-placed, and then you can kind of tie it up. Not able to. So that's the last one is the patient of a benign biliary stricture following a cholecystectomy injury, and the MRCP is thus, and that is the. So these are easier cases that I kind of picked up from our video library of sorts to be able to describe. There are more complex ones, isolated right duct injuries, little hepatotomy is required to go at the right lobe and all the so forth. So that's what I was trying to say. Let me just kind of go back a little here. Yeah, this is 8 hours following injection of around 5 milligrams of ICG. And the liver is still retained it. You can barely see the bile duct. So that is why I said, to my experience, it has not been a very, very helpful thing to pick up locate the bile duct in these kind of patients. So always identify the sectors, sectoral ducts, to be able to be sure that you've got all the anastomosis done. So again, stabilizing it, and then the rest of it is almost the same. But I'm trying to focus on the fact that it's a very underrated operation. It can cause a lot of heartburn after you've done a lot of hard work in resecting or draining or doing anything in the HDL and realizing that post-operatively your drain shows bile. So the suggestion is that if you are going to do this operation by laparoscopy or robotically, do standardize it. Don't keep on changing a technique in patient to patient. That will cause you a lot of trouble. Some of the things which caused us trouble and the way we found solutions to it, maybe there are better solutions you can find from other people, but you need to find solutions for these problems. In summary, all the technical endpoints of open hepatic jejunostomy can be met with a robotic jejunostomy. The standard of care is an open hepatic jejunostomy. If your practice involved open hepatic jejunostomies, then that is the standard of care you have to meet when you do a invasive or a laparoscopic or a robotic hepatic jejunostomy. There are some modifications. Your angle of view is different. It's caudocranial. Hence, your view of the HGF will be different. Liver retraction is important in this case because in open, that's not a big problem. You can easily retract whatever you want. And laparoscopic or robotic, you have to decide which approach you want and what instrument you use to retract the liver. Stabilizing jejunum, to my belief, is a very important part of the operation because floppy jejunum causes very bad suturing. Preplace sutures are broadly not possible. You can use a few, but otherwise beyond that, you will entangle them so badly that you won't be able to work on them. We worked on a left to right interrupted suturing. It's held us in good stead. Leak test, ICG, I believe has not been very useful in our own practice. Thanks. Thank you.
Thank you very much, Dr. Anish. And now we'll talk. So what was your, the continuous suturing you must have tried in a...
We did try a couple of problems. One, less than 40 is not available in the either STATA-FIX or VLOC. I think only STATA-FIX gives you 40. Even 40 for fine suturing becomes, the needle is very bulky. And when your suture line is not straight, for example, in biliary strictures, then continuous suturing can cause a lot of trouble. So we've had instances in the initial part of experience where leakage happened because we weren't very happy with the suturing, but we persisted with it because it seems simple. Continuously run the sutures and you don't have to handle so many knots. But broadly, I thought this is a better way of doing things. Seems a little more complex, but once you have standardized your suturing and knotting, you're very good at it.
Sir, what's the tiniest duct in your experience?
Sorry,
the smallest size of the duct.
Size of the anastomosis, you mean?
Yeah, by robotic technique.
Yeah, so you have to achieve an anastomosis of around a couple of centimeters. Even that means, yeah, I'm going with that. So, for example, we did a right duct anastomosis. The duct itself was around 5 millimeters, but we do a small hepatotomy and extend it. So, anastomosis itself becomes 1.5 centimeters. You have to achieve that for a biliary stricture, for example. You can't expect that you will do a 5 mm anastomosis and then hold the patient for the rest of his life. Can't happen.
Stabilizing the genital thing. In my experience, when we place a quarter suture and then the fourth arm is being folded down and then place the next suture, that prepares us very well for the next suture. So I didn't know the fourth arm being used in your video. Fourth arm or usually work with?
Yeah, good question actually. So I'm working in a setup, it's a government hospital, but we charge everything to the patient. So operation which costs me something like 2 lakhs for hepatic jejunostomy robotically. If I use a fourth arm or a fourth instrument, it costs another 25,000 to the patient. In the initial part of the experience, we were using 3 arms because we thought that let's cut down on cost to 1. We realized that we're using 3 instruments anyway. It's monopolar scissor, the Maryland bipolar, and a needle driver. So at times, the third instrument is lying idle because there is no fourth port placed. We started using the needle driver. I haven't showed this all this. All these are very ridiculous modifications all of us do in our practice to cut down cost as well as do the job. So use that needle driver to do what you said in the fourth arm now for the last 10 cases or so.
So may I make a few comments? I think it's worth reiterating that About the fact that how all the three anastomoses were done in the similar manner, suggesting that it's a standardized way of doing it. The second important point, which I think is worth reiterating in this setup, is the stabilization of the loop so as to be able to do an interrupted suturing well. And the third important point is that it would be as we would do in an open, which we've been able to do all along. And I think these points reassert the fact that the same process, if followed consistently, you would get good results. So they have extrapolated their open practice onto the robotic and expect the same kind of results. And I think all those points have been very useful and valid. I'm just wondering whether ICG, if you give earlier, say in a biliary stricture case, much earlier, because you're anticipating that this would be what it is, it may be worthwhile seeing that when it's about 6 hours or 8 hours delay of giving ICG, it may be able to help identification of that if it is difficult. But I agree that leak test would be useless doing with an ICG at that point.
We tried with that idea of increasing the duration, and instead of giving it at induction, we started giving it at 6 a.m. in the morning. So those livers that you saw were at around noon, approximately. So 6 hours already elapsed. So I spoke with a lot of people who are used to ICG and ICG experts. Unfortunately, it seems that nobody has a clear idea of how much duration you should be able to enlarge that delayed liver excretion so that you get none in the liver and all in the bile duct. We probably can expand it to the evening before. I'm not too sure whether it will work. But so far, it has not done us a world of good. In some cases, it was useful, all right. But identifying the bile duct at the hilum requires a combination of good dissection, high plate lowering. The needle aspiration still plays a role. I did show it in one of the sections that we use a needle the urologists use for pyeloplasties. It's a flexible needle, goes through the assistant port. Most of the needle is flexible, it's plastic, tip is metal. So the surgeon gets the tip, then he can inject, he can poke it inside, the suction apparatus is outside the patient, and the assistant tells you he's got bile or not. So that's the same way you used to do it in open surgery. So those things are still holding good steam, despite technology, which is ICG here. Right. Thank you so much. You can be loud, sir.
Excellent talk and video. Just a question about in the choledochal cyst, do you also do hepatocardiostomy in some cases? Why I ask this because in a lot of patients we do a coding labs of hepatocardiostomy for choledochal cyst, and taking a cue from that, and with our results, we have now moved on to in some of the biliary stricture also. We do hepatocardiostomy. I would like your whether you should do sometimes and for which are normal.
Never done it, sir. But I take a point that there is occasional patient where the duodenum seems floppy enough to reach the hilum. 2 points I would like to make for people who would like to practice this. One, don't compromise, if it's a choledochal cyst, don't compromise on the resection margin. You have to resect the choledochal cyst at the hilum. Just because you want the duodenum to go there doesn't mean that you leave half the cyst there, which I think Dr. Sadiq pointed out in one of his comments, that people leave half the cyst because they want to anastomose of duodenum. So that's a bad idea. However, having said that, there are occasional patients, and especially pediatric patients, where pediatric surgeons swear by it, wherein you can resect the cyst at the hilum and still the duodenum will reach the hilum. So yes, it's not my current practice, so I'm sorry, I don't have any experience to comment on it.
I think because when you excite the choledochal cyst, you do not keep in mind whether you will take the duodenum or
I'm just kind of reiterating that occasionally it is sort of.
That has to be, because when you're resecting, if the duodenum comes easily, you do it. If it's under tension, then you make it.
And also, I must say that, last 2 robotic choledochal cysts have done a hepaticoduodenostomy. So it does reach, and Hyler also. But so it's an option now. I've kept it open, though I used to think that it is not worth doing and only doing a Roux-en-Y hepatocystectomy. But I realized that it does come up to the hilum if you mobilize it well enough.
So what about the distal part of the cyst, like the intrapancreatic portions? Were we able to dissect it with the robotic approach?
Yeah, you can do exactly what you do in open surgery or laparoscopic surgery. In fact, better than laparoscopic surgery because you can mobilize the pancreas very well up to the lobe. The problem is exactly the same. You have to follow the same principles when you're digging into the pancreas and reach the tapering part of the cyst.
Thank you so much.
Thank you very much, sir.
Thank you, sir.
And now we'll come to the second part of this talk. So we are going for the debate. And this debate is MIS versus open radical cholecystectomy. And we'll call Dr. Anil Agarwal, sir, to talk on a MIS approach.
Good afternoon, and thank you IASG and the organizers for giving this opportunity. It's a pleasure to be here, as always, in Ahmedabad. And my brief is, in this debate, to talk about MIS for gallbladder cancer. And I think Chetan would say that feasibility, which has been shown in various studies, it can be done. But however, the moot point today is that should it be done? And he would raise to say that, can it be done safely? And feasibility is not the only thing. Can it be done as well as you do it in open? And whether port site metastasis, which is what has prevented its percolation, is a real or myth or reality. I'll come to that. And whether as good R0 resection can be done laparoscopically, and does it impact the early and late results? So I think I have remodified that into saying that port site metastasis, because this is one thing which has been in the people's mind, because the literature which was there from several decades said that port site metastasis occurs if you do a laparoscopic cholecystectomy for gallbladder in an unsuspected gallbladder cancer. But I think these kind of papers are the ones which said that the incidence of port site metastasis is high and which prevented. However, we have learned over the years that actually, as in various other malignancies, it is more to do with the technique. And I think as the techniques are refined, I think that same issue was there even in colonic malignancy. But however, we moved on. And role of pneumoperitoneum is negligible. And so what paved the way, I would say 2010 was a watershed. And when Professor Hahn, he showed to the world with a median follow-up of 27 months, which you would all agree is good enough for port site metastasis if they were to occur. And that, in fact, changed the world's practice, and so did we. And 2011, we started doing laparoscopic radical cholecystectomy, and we initial experience that we analyzed, and we also had no patient had port site recurrence. And now let's see, because this is crucial, because I think Chetan will probably highlight several studies that, oh no, the risk of port site metastasis is high. All the data which has come for incidental gallbladder cancer. And you have to realize that is an inadequate operation done because you never suspected that there was gallbladder malignancy. So you caught the gallbladder from wherever you wanted. We know that that percentage may vary, but a significant percentage of patients, there's a bile leak, which would contribute to dismal results. So extrapolating that is not good enough. And so in this tabular form, we have put this to say when you do a laparoscopic radical cholecystectomy, which is actually the appropriate operation, and you take it to go through the normal liver area and take out in a bag, because in fact, if you look at Indian practice also, some centers have moved to taking out the gallbladder in a bag, but that's not what is done for a routine laparoscopic cholecystectomy. So I think even extrapolating that is not a good idea. And it is very happy to see that this study by Tian Ran, in fact, they said that when we compared port site metastasis, and actually it is important that whether the gallbladder came out intact in a bag, then there was no difference. So what they were talking about, that incidental gallbladder cancer, if they excluded from this data, they realized that the port side metastasis incidence was not different. Because meaning thereby that if you have removed the gallbladder without bile spillage in a bag, then you're fine. So I think just coming to the technical parts, that you need to do liver resection, lymphadenectomy, all these group of lymph nodes needs to come out, agreed. And similarly, segment 4B5 or whichever you are a believer of. But the same thing can be done by laparoscopic. And so I think this is just pictorially showing the segment 4B5 resection, and also that you take care of all these group of lymph nodes. And you will have a picture similar to what you do in open radical cholecystectomy. Now, just to, I know in the interest of time, I did not want to include too much of the video, but so I'll rush through. Just trying to show to him, because Chetan again may say, oh, you didn't remove that group of lymph node or this group of lymph node. So just trying to show that once you have done that, taken out the lesser, momentum, and then we usually start from the 8A lymph node. That was the 8A lymph node, and that is the 8A lymph node, and going towards the celiac. And this is the anterior sheath being lifted. You can see that anterior sheath. So, yeah, that's the anterior sheath which has been lifted off. And let's just take it. This is the artery. And this just taking it from the undersurface so that you have the entire thing bared. You can see the portal vein, left portal vein beneath. So you take out all this. Probably rush through that a bit. That's the hepatic artery being looped, going towards the portal vein. Taking all those group of lymph nodes. You can take from left to right or right to left, and it'll gives you, I mean, it's important to remove all the lymph node, not necessarily in one. You can see the posterior sectoral duct. Oh, sorry. I don't know. And you can see all the hepatoduodenal structures, and you'll see this is the chain of lymph nodes. And just Chetan, for this thing, in the next few things, we have talked about the various lymph nodes and corroborating with that. Oh, sorry. So taking all these groups of lymph nodes, and then because also the argument is that are you doing enough liver resection? So I think this is all the lymph nodes. Then taking segment 4B5. That's the segment 4B pedicle taken from outside. You can see the demarcation. And then marking it out. Coming to segment 5. Oops, sorry, again it moves. Yeah. I just wanted to show the segment 5 because that is a matter of debate, and people would talk about that. Are you doing segment 4B5 as you would do in open? So you can see with the segment 5B pedicle taken from 5 pedicle taken inside, and you can see the demarcation. And then just completing the resection. Just to show you in the end what is left behind, just trying to show that all areas have to be cleared. You can see behind the pancreas, the retropancreatic area has to be cleared. So has to be behind this is the entire in the hepatoduodenal anteriorly. And we'll just show you along yeah. And that is the left gastric and just that one, right. And so then it gives a cosmetically good result. And Tata Group, Mahesh and the team, they have done the same thing robotically with good results. And this was our first robotic case. We have done about 5. And in fact, yes, Chetan, I hope I have been able to convince you and the audience here that there is a case for doing a laparoscopic radical cholecystectomy or minimal invasive. Now, this result with the Professor Hahn group, which talked about long-term results with good survival, and there was an expert consensus statement in 2016, and later updated series by Professor Hahn group talking about short and long-term survival outcomes of laparoscopic hysterectomy are comparable to open surgery and is safe, effective alternative for open surgery in the treatment of gallbladder cancer. And there are plethora of literature now available. Of course, they were not very large series, but you can see that these are the papers, 30 to 70 cases in various series, some talking about equivalence in terms of the operative time, the lymph node yield, and R0 resection, and long-term survival. And this paper, there are several papers talking about the meta-analysis. And in this, they show that patient T1 to T3 stage appears to exhibit similar or more favorable survival rates towards the laparoscopic cohort. And similarly, this Wei Zhang group also talking about operative time, intraoperative blood loss, hospital stay being better, and comparable long-term results. Similarly, so long-term outcomes are comparable. And this is about the robotic compared to open, talking about the same good results of radical cholecystectomy done. So let's look at one of these meta-analyses and just trying to take you through that this by Zhu Fang, operative time, no clinical difference, blood loss, no difference, retrieved lymph nodes, no significant difference. This was our paper in which the median yield was 10 lymph nodes. And similarly in this, no difference overall in each group in terms of recurrence rate or overall survival. And this is a largest probably paper, which is of the multi-institutional series of 235 patients. And this also talked about that laparoscopic or minimal access radical surgery is safe. This is in tabular form. And this is our paper that we presented also in Cape Town recently, in which we had analyzed 239 minimal invasive radical cholecystectomy. 201 out of those were gallbladder cancer and with good results. This is just in details about that. There are several other papers which are meta-analysis. In fact, Chetan, you could argue that probably the numbers in each of the series from the meta-analysis are a bit limited. In the sense, more than 50 cases, there are only very few series. But if you look across all the series, individual or meta-analysis, all talk about good results. And so this is another series. So I think feasibility was proven. There's no increased incidence of port site recurrence. Learning curve is in tune with any other advanced laparoscopic surgery. Better early post-operative outcome than open. That is no debate. And oncological equivalent shown with respect to R0, lymph node yield, port site recurrence, and overall survival. I'll just take you through. So I think the oncologically it is comparable. Just take you in the next few slides about what about advanced, because I think as the debate in the Whipples was also there, that can it be applied to advanced gallbladder cancer? Yes, it can be. And this is some of the patients in which we have done with a duodenal or a colonic sleeve, or in fact, recently we have also started doing some with Hyler blocks. And this is a paper that we published. That time it was 11 cases. Recently, we also presented in Cape Town, in which Hyler block patients were also taken up, and some of them needing a CBD excision for choledochal cyst. Kalair Hasan, who's just left, he published these two papers, the Jipmer group, that they had laparoscopic and robotic HPD. So I think whatever you can do in open, you can do robotic or laparoscopic. And of course, you have to decide that in which cases what you choose. So in conclusion, it is feasible with adequate oncological outcomes. So probably there's no debate, and it has a potential to be adopted in surgical management of gallbladder cancer, fear of early and forthright recurrence notwithstanding, and for tumors leading in addition to liver resection, lymphadenectomy, and or adjacent visceral resection with reconstruction, minimal access approach can be safely and effectively performed. So I think now in this curve of innovation, it is now almost a standard practice in several centers. So I would probably, even though it's a debate, I would say there's hardly a debate now. And I think it depends on when you are going onto that bandwagon. And I think, Chetan, my suggestion would be get on with it before you are called a laggard. So I think, so there is no debate, MIS, radical cholecystectomy for gallbladder cancer. Thank you very much for your attention.
Thank you very much, Dr. Anil sir. Now I'll call upon Dr. Kantaria, sir, Chetan Kantaria, sir, to talk on open radical cholecystectomy.
So respected chairpersons, seniors, and my colleagues, at the onset, I would like to thank ISG and the organizers, Bhavin Bhai and Daivat, for having me here. The mandate given to me is to talk in favor of open radical cholecystectomy for carcinoma of gallbladder. So I have a disclaimer that the views expressed here are strictly for the purpose of debate, and I have no personal bias whatsoever with regards to any particular procedure or any individual professing a particular procedure. I'll begin with a very emphatic statement that open radical cholecystectomy is the standard of care for operable CAGB as of today. And I make this statement with conviction based on the literature evidence, recent literature evidence, through which over the next few minutes, I'll be taking you through. So we'll begin with this study published in 2022. It's a study from Korean group, which compares the oncological outcome of open versus laparoscopic surgery for T2 gallbladder cancer. So they begin their publication by stating that laparoscopic surgery is recommended for cases of suspected T1 or T2 gallbladder cancers, which were identified preoperatively on CT scan based on the International Association of Surgeons and Gastroenterologists and Oncologists expert consensus. But they go on to say that open surgery is recommended for patients showing extensive liver infiltration on CT, extrahepatic bile duct or adjacent organ involvement, and incidental diagnosis of gallbladder cancer after open cholecystectomy. So this is their method of doing, where they do an open cholecystectomy, where it is involving liver infiltration and where there is extrahepatic bile duct involvement. Now they go on to conclude that laparoscopic surgery would become the standard treatment modality for T2 gallbladder cancer, so owing to its favorable short-term and long-term outcomes. So if you read carefully, they say it could become. So it is not as of now, it can become in future. Now we go on to the next publication, published in 2020. So this again has entitled Oncological Safety of Laparoscopic Radical Cholecystectomy in T2 Gallbladder Cancer. So they begin their publication by saying that the standard of care for T2 gallbladder cancer as of now is still open radical cholecystectomy. And they go on to say that laparoscopic radical cholecystectomy can be performed only in high volume centers and where the expertise of HPB surgeons is available. So there's a rider where you can do a laparoscopic or a minimal access radical cholecystectomy in an institution where there is of a high volume and where there is availability of HPB surgeons. Now, let us see this meta-analysis published recently in 2023. It's a systematic review and meta-analysis comparing laparoscopic versus open radical resection in management of gallbladder cancer. So though they conclude by saying that the result of the meta-analysis shows that laparoscopic radical resection is not inferior to open radical resection in all measured outcomes. So I have no objection. They are showing it is non-inferiority, it's okay. But what is their conclusion? The later half of their conclusion states that surgeons with sufficient laparoscopic experience can perform laparoscopic radical resection as an alternative. When it's an alternative to open radical resection, means your open radical resection is a standard and you can perform it as an alternative to it. And they also go on to add that this may not be final conclusion and a more comprehensive meta-analysis is necessary. This is in 2023. Now, interestingly, if you study this paper properly, they have included 18 studies in this study, and all of them were retrospective and none of them are randomized or prospective studies. Besides this, if you study the analysis, there were significant heterogeneities in them. Besides this, the authors themselves say that the many of the publications which they have included, they may have a publication bias. And more importantly, none of these studies had given a detailed adjuvant therapy data, which may have contributed to a better oncological outcome following laparoscopic resection. For me, the biggest advantage of open radical cholecystectomy is more number of lymph nodes harvested than in laparoscopic group. And we all know the significance of positive lymph node ratio, how it is a good prognostic factor for a better outcome. And having said that laparoscopy is better, we all know that when we do surgery laparoscopically, we tend to be a little more conservative than when we would do an open, so resulting into a little less extensive liver resection as compared to open radical cholecystectomy, a fact which has been acknowledged in the recent publication in 2020. Now, the icing on the cake is the Japanese guideline, the Japanese Society for the HPV Surgery, in their clinical practice guidelines published in 2021 for the management of biliary tract cancers, have very clearly stated that open surgery is recommended as a rule instead of laparoscopic surgery for patients with suspected gallbladder cancer. Now, when we compare open radical cholecystectomy to laparoscopic radical cholecystectomy, no matter however much advances we have done, however much skillful we have become, the risk of tumor spillage, dissemination, and probe site recurrences still persist. Maybe their percentage may have gone down. Besides this, there exists a complexity of lymphadenectomy and liver resection. Now, and this is because the submucosa of the gallbladder wall is absent and the muscularis propria is extremely thin. Besides this, though theoretical, the chances of pneumoperitoneum causing distant metastasis also exist. When we compare the disease-free survival and overall survival compared to open versus lap, there are no meta-analysis which compares the survival rate between the two based on each tumor stage. Each one of them gives us that overall survival is this much, but they're not compared stage-wise. And most importantly, there is lack of consistency across all studies with regards to type of resection for each tumor stage has been done. So there is no consistency in what the procedure was adopted. Besides this, the increased disease-free and overall survival postulated by certain studies for laparoscopic resection could be due to the fact that because laparoscopic surgery has been done, maybe the patients return home early, and in them, the adjuvant therapy has been started early. So therefore, it is a better outcome. But that doesn't mean that a particular excess, it's because of a particular excess and not because of the adjuvant therapy. And finally, I would like to rest my case by quoting study published by my very senior and skillful colleague, Dr. Anil Agarwal. So they published a study in 2015, which he has already quoted. So if you read the conclusion of their studies, they say that from the present series, it is evident that careful patient selection and proper surgical technique can lead to a better outcome or outcome equivalent to open radical cholecystectomy. So again, there is a rider that you have to carefully select. So certain select group of patients only you can do it. Secondly, they say that it should be performed only in centers with sufficient experience in advanced laparoscopic surgeon. And they say that whatever, because their numbers were so small, the studies were not randomized, there could have been a potential for a bias. So they admit the fact that there could be a potential for bias. And they say that long-term follow-up is a definite answer to the question of oncological equivalence. So they have published these studies in 2015. Still to date, that is almost 10 years, there has been no studies from their group, nor anybody else has published a long-term follow-up as far as laparoscopic versus open is concerned. So I end my case by saying that as of today, open radical cholecystectomy is still the standard of care for operable carcinoma of gallbladder. Thank you very much.
Thank you, Dr. Chetan. And I'll call upon Dr. Anil, sir, to give his thought.
Thank you, Chetan, for still trying to make a case out of it, though without bereft of any literature or any merit. Because if I look at your first paper, you start off by saying that that paper talks about that till T2 it's fine, for advanced it may not be the right thing. So I think you given in the first slide itself, and I think even the Navarro slide that you talked about, not yet gold standard, should be restricted to high volume centers. Now, tell me one procedure which was not standardized or early results were not from high volume centers, whether it be open Whipple's or any other procedure for that matter. And third paper also that you talked about after the Navarro's paper, that it's an alternative. Like alternate, obviously we are talking about that initially there will be a select group of patients, like the first paper that you talked about, that maybe not for advanced disease. We also, in the paper that you talked about, 2015 paper, we were not taking patients which were adjacent viscera involvement. We were not taking patients which were, with biliary obstruction, but which we are taking now. And I think I am happy that you alluded to our paper 2015. I think we are connected with the reality. I would request you to do the same, because a lot of water has flown under the bridge. This 2015 paper was when we had, I think, 24 or something, and now the experience is almost 10 times. And as you said that no publications come, we have presented the abstracts, but the publication you will see it soon with 200 plus cases. So add the literature that I quoted in the paper, which will come out in the publication. So the thing is, what is only consistent is the change. So I think you have to change with time. And what the conclusion at that time, because even if you look at the expert consensus statement with Professor Han and others, it was that it is evolving. And now it is in a higher phase of evolution. And I think now more and more it is getting standardized. In fact, I would just quote an example which would one of the senior surgeons, one of the younger surgeons did in a city, a laparoscopic radical cholecystectomy. He asked me that, oh, has he been trained and this and that? So he had come for some time to us. After that, I was happy that in one of the conference, he looked through the video. He said, can I see your video? And 1 year later, he said, I have done 3. So I think imitation is the best form of flattery. And the thing is that you have to get convinced with the data which is emerging. And I think 2-3 things, just the last 2 comments I'll make. You talk about, oh, we are a bit conservative. That is your opinion. That's not based on the literature coming from high volume centers. You are doing exactly the same what you do in open. In fact, sometimes you start doing a little more in open after laparoscopy teaches you that, oh, you can see more, you can do more. And in fact, we have adopted that practice in several of our procedures, that it has become better even in the open. So I think you are saying more lymph node. That is again an opinion, because the literature says that the lymph node yield is comparable. So I think that more concern, and pneumoperitoneum, that has been thrown out of the window long ago, that people don't talk about pneumoperitoneum versus. So I would say, and even JPHPBS, Japanese society that you talked about, not as a rule. Yes, obviously, you are not saying that if you are not doing those procedures. So I think, and just the last point, early post-op, you talked about adjuvant treatment, and you are still taking away that benefit. Isn't that part of the thing that if you have done oncologically the same resection and able to get a patient home early, back to work early, and able to start adjuvant, I think I rest my case. You have only supported me. Thank you.
Should I make a quick statement? Yeah. So I agree that evolution is the way to progress. There is no doubt about it. But based on the current literature evidence, the available evidence, open is still the gold standard. Ideal procedure is one which can be emulated and followed by majority of them, to be done with ease, and at the same time can be replicated by one and all. That is an ideal procedure. Besides this, very important is there is a great difference what I can do it and what I should do it. So there is a great, you can do many things, but is that a gold standard? As of now, the answer is no. Thank you.
So shall I for somebody else to do it?
Shall I put a question? Because this for pancreatic odontectomy, now this and all. So we all understand that getting a proper surgery is the key. And all these MIS and open debates and surgeries have come to a point of equipoise, that it is equivalent. So is it fair for the minimal invasive surgeons to look down upon an open procedure and say it should not be done? Have we reached that stage?
I think you're right in saying you don't look down upon an open procedure. But here the thing is that certain advantages, we are talking about oncology, several advantages of minimal invasive surgery are already there. And if you have equivalence or a non-inferiority oncologically, then why go for open and give the patient an advantage of laparoscopic or a minimal access approach? That is where the thing is. And certainly you have to convert as and when you think that you can't do oncologically the safe procedure or the adequate procedure. So that is what would be my take.
So I agree. So it can be done in a certain sub-select group of patients, but for not all patients of gallbladder cancer.
So, sir, I have a question for you, Nitin, sir. Early gallbladder cancer, minimal invasion of liver, hilum is also very good, and you feel that you are very well expertise. You have expertise in your HPB laparoscopic surgery. Now, in this patient, would you offer them laparoscopic surgery, or you will still go for an open surgery?
So this is a subgroup of patient where laparoscopic minimal access will be beneficial.
Here, there won't be a bias from your side as well?
Absolutely.
Okay. Now, the question for you, sir, Anil, sir. There is something which is a little bit advanced into the liver. There is a growth is a little bit down towards the hilum, neck, and some infiltration of bile duct as well. Maybe good lymph nodes as well. Would you still, you are also a very well-trained expertise in your HPB minimal invasive surgery. Still, you would prefer to do minimal invasive, or you will still think of an open as a standard?
I mean, that has changed over a period of time. A few years ago, we would not take this for laparoscopic. Now we are taking, in my talk also, which I put that hide slide, there was a video in which bile duct involvement was there, and we did a laparoscopic. So what I would say is, if I thought that it is going to make a difference in resectability or non-resectability, I would convert. If it is going to make me feel that I'm not doing an adequate resection, I would convert. But otherwise, I would start laparoscopic and take a chance.
Thank you very much. MIS in gallbladder is still evolving from early stage to the higher stage. We can say that. We can take a note for the audience.
Yeah, thank you very much. I think there is a
I think the debate
normal consensus usually happens when we have to see from the junior surgeons to the excellent surgeon, and average we should do where there is a early cancer, localized disease, we can do a radical surgery with the minimal invasive. And when there is an advanced surgery, we should be open, can be still a gold standard. So thank you very much. And now we'll come to last talk on this session. And I will call upon Dr. Shraddha Patkar for talk on operative surgery for hyalocholangiocarcinoma.
So we'll take a very short break for lunch. I think so almost have finished, then we start our colorectal session very soon after this session, after this talk.
Thank you, chairpersons. And after that appetizing debate, I realized that I'm the one keeping everybody from lunch across the corridor. So I'll try to keep this short. And the topic I would be touching upon is operative strategy for hyalocholangiocarcinomas. We know that hyalocholangiocarcinomas is fraught with dismal overall survival with very low resectability rates. Our own data suggests that the resectability rates are less than 10% for perihyalocholangiocarcinomas, and hence the problem statement. The guiding principles, we know that we need to do a staging laparoscopy to rule out peritoneal disease. R0 resection is paramount. A complete lymphadenectomy is a must, and caudate lobectomy forms a part of every resection. Even with a good R0 resection, there is a significant morbidity and mortality. The chances of vascular involvement are high. It's difficult to achieve proximal margins, and hence a very high R1 rate. The problem starts with the diagnosis of a perihyalocholangiocarcinoma. We know that it is difficult to assess the exact extent with the best of the imaging available. A histological confirmation is not always available, and if a patient is a surgical candidate, it's not mandatory as well. The imaging we currently have is a good contrast scan and an MRCP. We have invasive studies like the preoperative drainage procedures which are performed to assess the proximal extent. Cholangioscopy forms a vital part, especially for exact mapping if we have it in our armamentarium. The variety of staging modalities available for perihyalocholangiocarcinoma suggests that neither is perfect. The key elements include the primary location, the exact extent of involvement, the vascular assessment, the presence of lobar atrophy, especially of the opposite side, a good assessment of the future liver remnant, presence of nodal metastasis, and assessment of variant anatomy, which may preclude a surgical resection. This is the most practical staging available for us to help guide our surgical principles. The biliary drainage, which is performed prior to surgery, is an essential part. We all in an ideal world would like to operate in an unviolated system, but for whatever reasons, the patient presents with cholangitis, we need to correct coagulopathy, correct undernutrition, and in some cases probably plan neoadjuvant therapy. Hence, the majority of our patients require some kind of drainage. The ideal procedure is a non-percutaneous one, but it is not always possible. Nasobiliary drainage, wherever possible, is the preferred modality. And we need to drain the future liver remnant if at all. If there is additional drainage required, then we are fraught with the complications of multiple tubes, and then the patient ending up with a vicious cycle of cholangitis. The debate on cholangiocarcinoma is always the right-sided versus a left-sided resection, primarily because of the location of the tumor. Right hepatectomy allows a more complete resection of the tumor. The left hepatic duct has a relatively long and straight course, so anastomosis is relatively easy. However, if we have to do an extended resection due to involvement of the segment 4 duct, the disadvantage is usually the segment 2 and 3 are small, and in these cases, we may need to augment the future liver remnant prior to a major resection. Left-sided resections performed mainly for type 3B blocks. In this case, the remnant is not a problem, but because the right hepatic duct has a short course, getting a margin may be difficult, and sometimes we may end up doing either an extended resection or a double duct anastomosis. As I said earlier, lymphadenectomy forms a major part of the surgery. The 5-year survival of a node-positive disease is less than 25%, and it is essential that complete hepatoduodenal clearance is done for accurate staging and prognostication. We still don't have a consensus on the adequate number of lymph nodes which need to be harvested. The range is between 5 to 15. Obviously, the more lymph node you harvest, the staging is better. There are different pathways which are described, and there's a superficial and deep pathway. Suffice to say that the complete hepatoduodenal ligament, station 8, station 13 need to be cleared to achieve a complete lymph nodal yield. Caudate lobe excision forms an important part. This is because the drainage of the segment 1 bile duct is at the confluence and it is prone to involvement by direct tumor spread. Excision of the caudate lobe increases the chances of an R0 resection, with microscopic tumor involvement reported in up to 98% in a Japanese series. And if you leave behind the caudate lobe, a 5-fold increase in R1 resection rate was found. Whether there is any role of doing a frozen section to assess the intraoperative R0 resection status, well, the verdict is still out. Some people do propose doing a routine frozen section to assess a negative margin, but whether this actually results in achieving a negative margin and this translates into an overall survival is a matter of debate. Our own data suggests that an initial positive margin is associated with poor outcomes, and an intraoperative positive frozen section indicates poor prognosis. There is questionable benefit of additional resection. However, the aim is to achieve a negative margin in a perihilar cholangiocarcinoma. So I'll just have 2 short videos on how we approach. One is a left-sided tumor and other is a right one. This is a 38-year-old lady with past history of obstructive jaundice with an ERCP and stenting done elsewhere. He presented to us with this CT scan, which showed crowding of the left ductal system, a lesion in segment 4. You can see that the stent has placed in the segment 4 duct. An MRCP revealed the same thing, a lesion in the segment in the left hepatic duct. After confirming an adequate volume, we went ahead. This is a standard Makuchi incision for an open surgery. The first step is doing an interaortocaval nodal sampling, sending it for frozen section. Once local operability is to be assessed, we start with the PROTA first, do a cholecystectomy, ligate the cystic artery, cystic duct, do a complete lymphadenectomy of the hepatoduodenal ligament. In a left-sided resection, it is important that we first ascertain that all the right-sided structures, the vascular structures are not involved before we commit on the bile duct. Sometimes it's a difficult call to take whether we can assess this without division of the bile duct, and invariably we may encounter a scenario where a vascular resection is needed. A good preoperative triphasic CT helps us identify this. As we can see, all the lymphatic structures in the hepatoduodenal ligament are bare. This is the station 8 node and the common hepatic artery just below it. So once we are sure that the right structures are okay, we can see the portal vein coming into view. It is taped. And we can go ahead and safely divide the bile duct. As I said, we do send the margin for frozen section to confirm that it is negative. Once that is done, the left hepatic artery is ligated and divided. So this is the division of the distal bile duct. The stent which was previously placed has been removed. And this is the margin being sent for frozen section. We just ligate off the proximal end to prevent further bile spillage. And then the tumor is carefully dissected off the portal vein. The right portal vein is identified, made sure it is safeguarded, and then the left can be ligated safely. Once the margin is confirmed to be negative, we can go ahead, suture it off, and once the portal vein is divided, we have the line of demarcation clearly visible here. The mobilization, we usually leave it as a last step. The POTA is something which we have to tackle initially. Mobilization of the left lobe doesn't take too long. caudate lobe has to be completely lifted off the cava right up to the insertion of the left hepatic vein. The short hepatic veins which drain from the caudate into the IVC are carefully ligated. And this is the last bit of the attachment, which is now being dissected off. Parenchymal transection is standard with a combination of a ligashore and whatever transection device is comfortable with. The hepatic vein tributaries are carefully ligated. In this case, the MHV was slightly pulled because of the tumor, so care was taken to identify the MHV as seen in this video. That small rent in the hepatic vein was we had just kept a small surgical piece, and that gets usually sealed off. And we continue transecting. The hepatic vein tributary again ligated. The right hepatic duct is divided intraparenchymally. This is a standard practice that all our hepatic duct divisions are usually done intraparenchymally to avoid any inadvertent injury due to variant anatomy. And then we proceed upwards along the middle hepatic vein, which is kept under vision. This is the last part of the transection. The hepatic vein, the left hepatic vein is sealed with vascular stapler. We can see that the MHV is seen on the surface of the liver that kind of formed the boundary and was carefully safeguarded. The proximal margin was also negative on frozen section, and then a standard Roux-en-Y hepatococcegestomy was performed. This is a right-sided perihilar cholangiocarcinoma, which needed a portal vein resection. A 68-year-old gentleman with soft tissue of the periportal region at the confluence with a high CA19-9 underwent drainage of the future level element with an internal external catheter. This was the CT scan picture. We can see both the systems dilated. I will just show the part where we've already done the portal dissection, transected the bile duct, found separated off the hepatic artery, and just come to the area where the portal vein is involved by tumor. This is the left hepatic artery being safeguarded, and that is the involved right portal vein with the hilum mass. Careful dissection at the hilum helps separate off the left portal structures. The main portal vein is taped, and the tapes are switched to encircle the right portal vein. We performed the portal vein resection in between the transection. So I'll just come to that part. Sutures were taken to on the anterior surface to avoid twisting. Similarly, on the main portal vein, the left portal vein was then clamped. Then the main portal vein. A sharp venotomy was performed with scissors, and the resection was completed then. In this case, we had enough length, so a primary end-to-end anastomosis could be secured. As we can see in the picture that there is no tension on the portal vein. And these are, this is the anterior layer being taken. The last couple of sutures are left long, growth factor is administered, and the suture line is complete. So we all know that despite our best efforts with a curative resection, the chances of recurrence remain high, and more than half the patients experience recurrence, especially in the first 5 years, so an intensive follow-up is needed. This is a benchmark study from 24 expert centers and says that surgery for perihilar cholangiocarcinomas is associated with high morbidity and mortality rates. There is a eastern to western divide. The east don't, especially the Nagoya group, have reported low mortalities, but overall the picture is little bleak. There is an upcoming role of liver transplantation. The Mayo Clinic published their experience of excellent 5-year survival in unresectable cholangiocarcinomas. They were treated with preoperative radiotherapy before subjecting them to transplantation. However, we know that this results haven't been duplicated anywhere in the world, and not many centers as of now offer liver transplantation, though it is an attractive option for unresectable cholangiocarcinomas. Since the theme of this conference is minimally invasive surgery, there has been some effort towards offering minimally invasive surgery for perihilar cholangiocarcinomas, and a recent systematic review says that the short-term outcomes are equivalent. However, given the technical challenges, it should be performed by experienced surgeons in high-volume centers and on selected patients. We know that recurrences are common and there is high morbidity rate. Our own experience suggests that we have a futility rate of almost 41%, which is defined as early recurrence, postoperative 30-day mortality, or intraoperative unresectability. And we have made efforts to identify preoperative factors to help us select patient optimally and improve outcomes. So I would like to conclude with the message that surgery, as of now, remains the only curative treatment option. Lymph node metastasis is a harbinger of poor prognosis. Surgery definitely has high morbidity and mortality rates. Preventing futile surgery remains a challenge. There is some role of adjuvant and neoadjuvant strategies upcoming, and liver transplantation offers an attractive treatment option, especially for unresectable disease. Thank you.
Thank you very much, Dr. Shraddha. One point, see, you do aortic lymph node dissection at first and do sampling. So you do laparoscopy, or you, in this left hepatectomy, you showed you are open and then you send a...
We have done open, and we don't do a lot of minimally invasive for cholangio. So we usually go ahead and do an open sampling. But doing a minimally invasive sampling as alternative, a good option just to avoid a futile laparotomy, probably sending it for frozen and then not going ahead with a laparotomy if it is positive.
And second thing now, because we see the problem with the right hepatectomy, the post-operative morbidity and mortality is more. So in this World Congress also, there's more going towards the left hepatectomy. They are promoting most toward the left. So what is your...
Yeah, so that remains a challenge always to decide the sidedness of resection, right? Obviously, because then FLR is an issue. Some people have propagated doing preoperative portal vein embolization in case you end up doing an extended resection. Left hepatectomy, on the other hand, has a problem of the RHD being small and having to at least do a trisectionectomy or having to anastomose 2 ducts, which is also again technically challenging.
You mentioned that your preference is nasobiliary drainage in hilar cholangio, but to my understanding and my experience, it's a really difficult procedure. Means very few endoscopists could do it successfully, number one. And number two, majority patients needs bilateral drainage. So what is your experience?
So it is a utopian view that all patients would ideally get a nasobiliary. Ideally, scenario, we don't want drainage, but that doesn't happen. Next best thing is a nasobiliary drainage, which also happens in a very few selected patients. We end up doing percutaneous drainage for most of our patients, and this is where they'll end up in those vicious circle of cholangitis, drainage, repeated, and unfortunately, because of that, a lot of attrition happens, and we end up operating less than 20% of what we thought we could operate.
And my second question is about the neoadjuvant therapy. In which patients do you advocate? Number one. Number two is every time they ask for a histopatho evidence. Sometimes it's really difficult to prove on histopatho, and they don't deny for neoadjuvant. So, what's your?
So that remains a challenge. Achieving tissue diagnosis in perihilar cholangiocarcinomas is difficult. With the best of the cytology which we have, the yield with PTBD is not upwards of 60%. Cholangioscopy may aid it and help little bit more. But with a surgical candidate, we don't need a tissue diagnosis. I agree, giving neoadjuvant is a challenge. For now, we don't have an approach of giving neoadjuvant for perihilar exactly because we don't have a tissue diagnosis. Sometimes in intrahepatic cholangiocarcinoma, if we see a large nodal burden, then we subject them to neoadjuvant.
Thank you, Shraddha. As always, very good presentation and good videos. Since this was a detail in the devil, I just want to make a few points. I think hilar cholangiocarcinoma is a very, very challenging surgery which any of us would encounter. But the lot of work is to be done pre-operatively. And I think that's the devil is in that detail, that you prepare your patients. So there's decision-making about future liver remnant, decision-making about drainage, preparing your patients with prehabilitation, and having a plan and plan B in terms of, do you know there's a vascular invasion? And if it is, how you're going to deal with it. And I think that aspect, that preoperative planning of surgery is probably the one which would give the best dividends. And I'm sure that is what you do. And I thought this should be highlighted to people, that that is the critical component of surgery for hilar cholangiocarcinoma.
Agree completely. I think well begun is half done, but we end up doing it half only in cholangiocarcinoma is our experience, because even with the best of optimizations, we have an attrition rate of up to 50%. And there are some things which are beyond our control. And there are some patients who don't get optimized despite our best effort. The volume does not increase, even if we do a preoperative portal vein embolization. And sometimes they just don't recover from cholangitis. That's the unfortunate truth. We have to deal with it. I don't know what is the way to circumvent it. Probably early detection, getting them to referral centers before they end up in this vicious cycle would be the way forward.
Yeah. So, Dr. Shraddha, just you are the highest center who is getting the patients with the hilar cholangio and cholangio cancers. So, out of how many patients you got in the OPD get with diagnosed? Ultimately, they end up with the
my
surgical.
it was 10% for perihilar cholangiocarcinoma and 14% for intrahepatic cholangiocarcinoma.
So that is the take-home message. See, so everybody who's there in the base center, even with all the equipments and optimization, 1 of 10 patients will get a surgical outcome.
Yeah, Dr. Shraddha, nice presentation, enjoyed it. My question is related to the duct transaction. You know, when you have divided the parenchyma and now you're dividing the duct. So you, on one hand, you are conscious about achieving the R0 resection, and at the hilar plate, multiple chordate ducts opening. And not infrequently, I would say that you end up injuring some chordate duct, and then you suture it. And occasionally you run the risk of, or occasionally or more frequently, you run the risk of a leak from that duct as well. And with a borderline remnant, you know, it end up in a liver failure. So what are your tips and tricks of dividing the duct such that you achieve a R0 resection, as well as, you know, doing it safely in terms of not injuring the chordate duct?
So that part would be mainly when we are not dealing with perihilar cholangiocarcinoma. For a perihilar cholangiocarcinoma, a complete chordate lobe excision is mandatory. And if you remove the chordate lobe completely, you invariably won't end up with notorious leaks. The problem arises when you leave the chordate lobe, either when you resect in an HCC or a colorectal liver met. In that case, what we routinely do is do a leak test at the end of surgery, completely suture the caudate with a running suture. And if there is any doubt, do an intraoperative cholangiogram to confirm.
Yeah, thank you very much. And we'll end up this session. Thank you very much, all the chairperson and all the speakers.
So I must congratulate you for a very nice video in the era of minimal access surgery. The open videos were at par and in fact better than actually minimal invasive.
So we are taking a very short break for 15 minutes only. 15 minutes. Yeah, most of us have taken the lunch. I think so. Very few of us. Khana khana. Yes, sir.
Now we'll start our post-lunch session in colorectal surgery. I will call on stage Dr. Rohin Mittal sir for moderate this session. And this session is about optimal strategies for resection of colorectal cancer. And I will call our chairperson, Dr. Jayesh Prajapati sir, Baiju Patnaik sir, Neerav Wakani, and Dr. Awadh Patel. Dr. Joy Abraham. Dr. Neerav Wakani sir. Now I'll hand over to Dr. Rohin Mittal sir to moderate this session.
Hello and welcome to the post-lunch and the last session for the CME, which is on colorectal cancers. I will invite Dr. Ashwin D'Souza to give the first talk on robotic low anterior resection, how to dive deep in the cave. Dr. Ashwin.
Good afternoon, and thank you, Dr. Bhavan, for this very kind invitation. I would like to share our technique on robotic total mesorectal excision. I didn't have a good video for LAR, so this is in an APR, but I will add the stapling bit at the end. Yeah, so our patient is a 65-year-old male, non-metastatic rectal cancer, right levator involved. He received long course chemoradiation, good response, wanted organ preservation, got brachytherapy. 6 weeks later, he was put on wait and watch. At 6 months, he had probable local regrowth, but he still refused surgery. So 9 months later, he said, okay, he'll go for the APR. That's our port position. I like to use the camera in R3 and keep 2 instruments on the left and 1 on the right. The R1 takes the progress, which gives our traction. The R2 has the bipolar, which gives counter traction, and the monopolar scissor cuts in between. So I try to keep this not more than 5 centimeters above the umbilicus. I use just 1 single assistant port in the right hypochondrium. I usually gain access with the optical trocar access. It's important to note that the tip of the trocar is 2 centimeters in front of the cannula. So you have to be a little careful when entering. We can see the external oblique aponeurosis, followed by the internal oblique, and then the transversus abdominis. Immediately after that, we gain entry. Here, the trocar is still not in. The cannula is still not in the abdomen. Just the trocar has gone in. So I see this field and move the tip of the trocar just against the anterior abdominal wall with the omentum on the other side for about 2 centimeters inside. So this prevents any damage to any internal organs because actually there is little negative pressure in the peritoneum. Once we do that and get the cannula in, then we can start the pneumo. And this technique sort of prevents injury by trying to push blindly with the negative pressure in the peritoneum. So once the pneumo is established, you first check for any iatrogenic injury down and over in the gallbladder area. Everything looks clean. Do a quick staging lap. Then we create our operating environment by moving the omentum and the transverse colon below the left lobe of the liver. Patient is put into Streep Trendelenburg position and bowel is reposited in the right hypochondrium. Little obese patient, BMI of 28. We use full-length gauze piece in the right iliac fossa to help hold the bowel in place. Targeting, I target at the sacral promontory itself. It gives good access on either side. Patient had a very a redundant sigmoid colon. And if we go to the root of the IMA, everything was flopping down there. So I decided to take down these adhesions in the left iliac fossa, but only enough so that the colon can be straightened. If you take down all these adhesions, then the colon will keep on flopping into your view. So we take down these adhesions so the colon can be straightened out and put in the left iliac fossa. And then we go for the IMA. The progress holds up the IMA. Because this is redundant, the assistant had to hold up the rectum there. There was some further additions between the IMA and the root of the small bowel mesentery. These are taken down until we see the second part of duodenum there. We need to take these down completely because this will later gain us access to the IMV. Once that is done, we can begin our dissection on the right leaf of the rectal mesentery. It is important to identify the correct plane here. And the cue to that plane is to identify the superior rectal artery and take the plane that comes just posterior to the artery. If you go deeper to that, you will be injuring the hypogastric nerves and the plexus on the abdominal aorta. So that's the undersurface of the superior rectal artery. That's the cue for the correct plane. And then careful dissection to try and identify the retroperitoneal plane. Again, the cue here is the fine retroperitoneal vessels, which have to be taken down. That is the left ureter. We like to identify that or at least see that through the fascia before we go for IMA dissection. Then I went for the IMV to just create the plane there. As I started dissecting, I realized I was in the wrong plane. Because I could see the aorta there. So I readjusted the prograsp, gave better traction. Fair amount of fat in the retroperitoneum in this patient. So if we give good traction, we see the plane is way up there. It is not next to the aorta because then you're damaging the aortic plexus there. We need to identify very carefully this Tal's fascia and take that down. Once again, the plane here is just behind the inferior mesenteric vein. So once we get into the correct plane, then it's just by serially moving the scissor and the bipolar, we can develop this. We just need to develop it for a short distance. That will help us to do the IMA dissection. That's enough for now. With that identified, we can begin our nodal dissection at the root of the IMA. All the nodal tissue is taken down to expose the IMA right down to its root. I usually do a high ligation, but this patient had a very redundant sigmoid. So I decided to test the integrity of the vasculature first. I didn't see any significant pulsation after clamping the IMA. So I decided to preserve the left colic and to do a low ligation in this patient. Oncologically, it does not have much significance if you complete the lymphadenectomy. Becomes a little more difficult, so we had to identify the offshoot of the left colic artery, then continue the dissection along the left colic and take all that nodal tissue towards the specimen side. The IMV can be ligated low for APR because we don't need that much length. For an LAR, we would take it at next to the duodenum. So we can ligate the IMV here at the level of the left colic itself. Once the IMV is taken, we can proceed for further dissecting the IMA and complete the lymphadenectomy. We see a trifurcation here with the first sigmoid and the superior rectal arising almost together at a common point. So we would have to take these branches individually if we would have to do a safe low ligation. So the branches are individually isolated, clipped and divided. If you notice till now, I have not used much assistance because if you keep all your three arms together working and retracting only in the field where you're operating, the robot serves most of the purpose. The lymph nodes from the posterior surface of the IMA are then taken down. And then we have to develop this plane. That is the Tal's fascia there. As we go medial to lateral, we can see the gonadal vessel that is getting lifted up. Sometimes we have to actually incise this layer. The cue again here are these fine retroperitoneal vessels that have to be taken down. So we have to go on a plane that is superficial to them. Once we enter the correct plane, then it becomes fairly straightforward. We keep on advancing the scissor with the bipolar for short distances. We don't need big retraction when doing robotic because the field is very much zoomed in and magnified. So we need retraction only for the field which we are working. Once that is done, we can take down the lateral attachments of the left colon. Here again, the progress bipolar move together. Progress gives the traction. The bipolar gives the dynamic traction as you're cutting. And we keep on moving this as we progress towards the sphenic flexure. So although this robotic surgery, what is unique for colorectal that it crosses many quadrants, but if you keep on moving the arms and keeping them in your field and knowing and putting them all to work, then we can get traction and just take this down with monopolar. When I go to the sphenic flexure, I use both arms for traction. So we didn't take down the full sphenic flexure here because this we just needed for APR. Rectal dissection, I like to make the incision in the peritoneum on the left side first because I feel this loosens that up and helps to retract the rectum up a little bit. Then we shift the entire rectum to the left side. The descending colon also has to be flipped, otherwise it keeps on falling into the field. Here the assistant comes in and holds the cuttage of the mesentery. The progress lifts the rectum towards the pubic symphysis, and then we get good access to begin the posterior dissection. Posterior dissection, we have to be very careful to dissect between the mesorectal fascia anteriorly and the presacral fascia posteriorly, keeping both these facial planes intact. The intact mesorectal fascia is required for the good TME, which Dr. Rohin will later on elaborate on. And the presacral fascia is what we require to keep intact to protect the nerva erigentis and the hypogastric nerve that all lies posterior to the presacral fascia. So the cue again here is to just follow just outside the mesorectal fat, keep on advancing the bipolar forceps, getting our retraction. We see a lot of edema here. That's because of the 9 months from radiation. So I could not get access there with a lot of fogging. So I decided to do a little bit on the right side before completing the posterior dissection. For the right side, I begin anteriorly first and keep the lateral part for the last. We'll see that this approach helps a little bit. So we retract the semivesicle anteriorly with the progress and then incise the Denon-Villiers fascia and continue dissecting just posterior to Denon-Villiers fascia. There again, we can see the edema. We are going to see more and more of these rectal cancer patients as we see more TNT and more attempts with brachy at organ preservation. So the more time we take from radiation, we are going to see all these late radiation reactions as we operate. So significant amount of edema here. After doing a little bit on the right side, we can go further posteriorly. Just keeping the suction here, we can see the assistant is just holding the suction there. All the traction is being provided only by the robotic arms. And we have a very zoomed in view. Keeping the suction there really helps to decrease the fogging. As we go down below the semivesicle, the mesorectum has a lateral recess towards the lateral pelvic side wall. So you have to religiously follow this fat and continue until we see the endopelvic fascia there. That completes the TME. Otherwise, there's a risk of leaving the lateral peritoneal recess. For the left side, I switched the monopolar with bipolar. So the arms have the memory. So just a question of switching the instruments. Doing this is that although I'm operating the scissor with the left hand, I'm getting real significant amount of traction with the bipolar on the right. Again, do the anterior part first. And once the anterior is defined, you can see here how easy it is to connect the posterior with the anterior around the rectum. The lateral part is probably where the plane is least well defined. And you can also appreciate the amount of traction the bipolar gives on this rectum, just hooking it and pulling it completely to the right side. As we continue, we go down to the levator here, right up to the pelvic floor. We can complete the posterior now. Very narrow pelvis with an obese patient, but proceeding robotically, I think it helps in the retraction. Posterior is then completed down till the levator. Then lastly, I do the anterior. The ProGrasp holds a bladder up. The assistant just straightens out the rectum, and the bipolar gives posterior traction. So anteriorly on the bladder, posteriorly with the bipolar, and the entire plane opens up just posterior to Denon-Villiers fascia. We can take this down right down to the prostate, separate the prostate from the rectum. So for an APR, this would be more or less fine. We have reached levator on either side. We select our point of proximal specimen transaction and divide mesentery. We can use an energy device with the assistant, but the bipolar also works very well with the robot itself. And take this division down and then staple that and bring that out as a stoma. So just to show the use of the robotic Surform stapler, this is the LAR dissection already done. So we ask the assistant to pull the rectum out and towards the left. The ProGrasp again lifts up. Even the robotic stapler does not achieve 90-degree flexion. The max is we get 120 degree. So I get a 90-degree by pushing the rectum almost to the other side, so that it forms a more or less 90-degree with the stapler. And I intend to take only half of the rectum because eventually we require two. So by taking half, the point of intersection of both staple lines ultimately comes out to the donut. So if we plan that well, then we don't have a risk of leak from intersecting staple lines. So that's half divided. We have to be careful to straighten this stapler because sometimes it gets locked. This happened once with me. And then once half is taken, we can see it becomes relatively easy to position the next staple exactly where the first one has stopped. And because it's robotic, the firing is absolutely stable. There is no movement at all. You can see a near transverse transection of the rectum as the stapler is removed. That's the staple line on the specimen side. Then the anvil is put in. I try to get that intersecting point within the donut, so the risk of leak there also is minimized. The anvil is connected, and keep the mesentery at 9 o'clock to prevent rotation. Then stapler is fired to complete the anastomosis. So this is the Covidian stapler with the tilt top head. So it's fairly easy to remove. And I always do an air test with the Foleys there. You can see the rectum is completely, the colon is well mobilized. And the air test is negative there. Yeah, thank you.
Thank you, Dr. Ashwin. Fantastic video. You made my work much simpler because I think a lot of what I needed to cover, you've already covered. Any questions from the panelists or from the floor?
Sir, excellent video. Sir, one of my question is, have you realized laparoscopic versus robotics, the outcome of the sexual functions, or in your personal experience, is it much better, or have you got some follow-ups of those things that
we have not compared our data for urinary and sexual function, but I think there are some papers from Korea which show a marginal benefit for robotic surgery. But again, if you search well enough, you'll find equal number of papers showing no difference. So I don't think there is any objective difference to say for robot has better urinary and sexual function for rectal resection. The word is still out.
Okay. Sir, very nice presentation. So, in case of prior surgeries, like in female patient, prior hysterectomy, something like that, where the left ureter comes slightly medially. So, in robotic, we have an added advantage of an integrated ICG. So, do you think that ICG helps in identification of the ureter in previously operated female patients, or you have any technical point where you can identify the ureter, even in laparoscopy, in the lateral pelvic wall in prior operated patients, where the surgeon can avoid the injury to the ureter.
Yeah, if the retroperitoneal plane has not been breached in prior surgery, so if the colon has been mobilized priorly, then only I would think of doing something to see the ureter, because that requires cystoscopy. You have to put a uretrix, then put the ICG there. Then you should have the lab system with the ICG capability. But as far as we are okay, if the colon itself has not been mobilized, if we stay anterior to Tal's fascia, we don't actually look for the ureter at all if that fascia is not breached. I demonstrated the ureter here for the video actually, but if I'm confident that that facial plane has not been breached, then I won't look for the ureter.
Selectively divide the ureter also, sir, in few cases, especially if it is locally advanced and you are doubtful that dissecting the ureter out may actually lead on to devascularization of the ureter.
Yeah, surely. I mean, if there is T4B in that area, we would definitely go for ureteric resection depending on what side it is. But these T4 cases at the outset, usually they come in the recurrent or the primary tumor is usually large. Usually they are not for amines. Yeah.
Thank you.
Yeah. Fourth arm on the right side. Okay, yeah. Yeah, so what I find very comfortable is that for the fourth arm to be on the right side, it has to cross over your field and then give you your traction. It works well. It achieves the same thing. So the only thing that changes here is the camera shifts from R2 and R3. If the camera is in R3, that is, it is more towards the midline. So that will replicate the view that you normally see in lap. So by shifting the camera to R2, like you saw here, it takes a little bit getting used to. But if you look at the view, it's okay. So that is the only thing. You can keep two arms on the right. There's no problem at all. You just have to position it well, and it gives you the same traction.
Hello, sir. Yeah, one last question. How frequently you need spine flexor mobilization for low anterior resection? How do you manage with this docking, or you require another docking for the spine flexor?
Yeah, that's a good question. So I do it for all cases, regardless. I would actually begin the procedure by just taking off the momentum from the distal transverse colon laparoscopically with an energy device and take that right down to the splenic flexure, just separating the omentum and dividing the splenocholic ligament. Then I would put a gauze piece there and then dock the robot. I find that this maneuver saves about an hour of time, because as you go more towards the transverse colon, the robot loses its functionality, and you end up undocking one arm, then struggling for another half an hour. This simple maneuver, then you can do everything medial to lateral. You see the pancreas, go above the pancreas, enter the lesser sac, take it down to the splenic flexure, and just meet your gauze piece. I think we have a lecture on splenic flexure mobilization. Yeah, maybe
there is one talk on minimally invasive splenic flexure mobilizations. We probably hear more about this. But yes, splenic flexure mobilization with single docking is always a bit of a trouble. So you do it laparoscopically. We sometimes have 2 extra ports and sort of do port hopping and try and do the left side. So
problem in Tata is I get robot once a month. So I try to do 2 cases, and I try to optimize my time the best.
Fair point. I think there are different techniques, and whichever works for everybody, they should follow that. Thank you. Thank you once again. Next topic is minimally invasive complete mesocolic excision of colon cancer. And I'll invite Dr. Mayank Tulguthu.
Good afternoon. Today we'll talk on minimal invasive complete mesocolic excision for colon cancer. It's a little bit controversial topic till now. CME concept that came.
Near this half, please.
As we can see, the TME came for the rectal cancer and it reduced the recurrence of local recurrence. As the same concept was applied by Dr. Hohenberg in 2009, he published his study that TME, we are dissecting the embryological plane, we are preserving the mesorectal fascia and minimal breach of the mesorectal fascia. Same concept was applied and embryologically Hohenberg told same fascia is continuing and covering the mesocolon. Hence, we have to preserve the mesocolic fascia and it should be no breach. He published his article in 2009 and which showing that we should do a sharp dissection between the mesocolic fascia and retroperitoneal fascia, avoid any breaching to mesocolic fascia and central vascular ligation at their origin to ensure the maximum harvesting of lymph nodes. In his study, he observed that local recurrence was reduced from 6.5 to 3% in 10-year studies. 10 years ago, we were doing conventional colectomies and then we shifted to CME. In 5-year survival, we noted is 89%. But here we can see the literature. There are the various definitions are there, and that all are confusing. First is CME. As earlier we told, we have to preserve the mesocolic fascia, and the CVL, that is a high vascular ligation of the proximal aspect of the feeding vessels, artery, and vein to be ligated. But another terminology which is used in Japan, Japanese colorectal surgeons, they have given a concept of D1, D2, and D3 lymphadenectomy. In European side, we can see the CME with CVL, that terminology is used, but in Japan, D1 means we have to remove the pericolic and epicolic nodes, D2 intermediate nodes, and D3, it's D1, D2, plus we have to remove the nodes at the SMV and lateral to the SMA for right colon. So this have a very minor difference between these two. That we'll see in the next slide. Here we can see this is the D1 resections and D2. Conventional our colectomies, they are all are the D2. We are dividing the mesocolon at the midway. And D3 means we have to remove all the tissues, fibrofatty tissues over the superior mesenteric vein and lateral border of artery. But here we can see what is the difference between D3 and CLE. Once we can see in Japanese, according to D2 lymphadenectomy or D3, we have to, for the cecal cancer, we have to ligate the ileocolic vessel only, and they recommended the 8 to 10 centimeter of margin. And no need to divide the branches of middle colic artery. But when we can see we are going towards the CME, we should ligate for the cecal cancer or ascending colon or hepatic flexure. We will go for the ileocolic vessel ligation and right branch of middle colic vessels. Hence, when the study which is comparing the CME versus CVL and D3 lymphadenectomy, in that the main difference is lymph node harvesting is more and the length of specimen, that is more. In Japanese, they are removing only 10 centimeter, but in this, they are harvesting more lymph nodes and more amount of mesentery. And another for CME that is most important is to learn about the vascular anatomy and its variation preoperatively, so that unintended vascular injury or intraoperatively we cannot identify any arteries and we could not know what is this. In this, most importantly, the bleeding is most commonly from SMV or mesocolic trunk. So artery branches and tributaries of mesocolic trunk, this should be identified. As we see, left colectomies or LAR, the left colon arteries are same, but there is a variant arterial anatomy and vein anatomy for the right colon. Hence, the right hemicolectomy is little different. How I do that port placement for the laparoscopically will put infra-umbilical port, and these are the 3 of our working ports. For robotic, we'll put in oblique line all 3 ports, and this is an assistant port. And we are doing a dissection with 2 instruments. Here, the first, we are identifying the ileocolic vein. Here we can see the bluish hue, and we'll lift up the ileocolic pedicle, and at the time we can identify this ileocolic vein. Here the right hemicolectomy, we have 3 approach from caudal to cranial, cranial to caudal, and another 3 is transmesocolic mesocolic tunnel approach. Here we can see we have to preserve the fascia over the mesocolon, mesocolic fascia, and this is the retroperitoneal fascia. This is all the mesocolic fascia and retroband. We should avoid the breaching over the, and that should be a sharp dissection. After doing this mesocolic tunnel creation, we will proceed towards the dissection over the ileocolic pedicle and SMV. Here we can see this is the ileocolic pedicle and this is our superior mesenteric vein. And all the fibrofatty tissues over the superior mesenteric vein, we should be removed for CME and CVL. We will continue our dissections over the SMV. And here we can see this is a pedicle of ileocolic vein and artery. Most of the time, we'll try to dissect the ileocolic pedicle, vein and artery separately, but sometimes it's not possible. We'll ligate simultaneously, same the pedicle. See, as we grow, proceed cranially, we can see here, this is the pancreas came into the way and this is a duodenum. If our dissection plane is wrong and we are dissecting into the retroperitoneal fascia, and the duodenum will come superiorly in our plane, hence we have to put it down. We should understand that plane is wrong. And we can see while doing the lymphadenectomy, there is a most common complications is the vascular injury, that is most dreaded complication, and most common vascular injury is SMV. And another the vascular injury is the branches and tributaries of mesocolic vein. In this case, we have ligated the pedicle, both combinedly, vein and artery. And after dividing the remaining the mesocolic tunnel, which we proceed, because without dividing, we cannot proceed ahead. And here we identified this is an artery, that is a right colic artery. So the preoperatively imaging and to identify the vessels is most important. And after dividing the right colic artery, we'll proceed ahead. All the fibrofatty tissues were removed. And this is we encountered, that is a right colic vein. Generally, the gastrocolic trunk is formed by the anterior superior right colic vein, pancreacoduodenal vein, and the right gastroepiploic vein. But that is a variable anatomy. And see here, this is the superior right colic vein. But according to that, we have seen that in Japanese, this is a cecal growth. We should not to dissect into the middle colic and middle colic branches. But if we are doing a CME CVL, then we should dissect over this area. So in these cases, we are harvesting the more lymph nodes. But it has an actual survival benefit or not, this requires the more studies. After dividing the right colic vein and artery, we have proceed cranially. And this is we encountered, this is a right branch of middle colic vein, which was ligated. This was earlier, it was blade, and we have done a bipolar, and after that we have ligated this. We have to remove all the fibrofatty tissues over the middle colic vein and the right branch of middle colic artery. And here we can see this is we encountered, that is the right branch of middle colic artery. In the right colon surgery, there is most common, the problem is vascular injury and bleeding. And here you can see that we have done all the dissections from this only two ports, the forced bipolar and the monopolar Caesar, and the one assistant port. Here we didn't use the fourth arm. After dividing all the vasculatures, the dissection was proceeded and mesocolic tunnel was completed. And then we have started a dissection cranially. At the time, the assistant is retracting the transverse colon caudally, and the omentum from the mid-transverse colon to the hepatic flexure was divided. Some people in cranial to caudal approach, they will ligate the vessels, branches of middle colic and gastrocolic trunks, they will ligate from superior side, cranial to caudal approach. Now the hepatic flexure mobilization and EL mesentery was divided. In this case, we have done extracorporeal anastomosis. We didn't use the intracorporeal anastomosis for this patient. Hence, I will show you the next video. In that case, we have done intracorporeal anastomosis laparoscopically. This is the laparoscopic case of right hemicolectomy. Here we can see that we have ligated all the pedicles. I am showing this only the anastomosis part. After removing all the fibrofatty tissues and over the proximal transverse colon, we have divided the transverse colon with the help of linear cutter stapler 60, blue color. And this is ileum was divided with the same stapler. And the specimen we kept over the liver, and we have planned for the isoperistaltic iliotransverse anastomosis. Hence, we have taken a stray suture and the side-to-side anastomosis was performed, and the enterotomy was closed with the help of stratafix suture. Now we'll see the is it a benefit of CME? We have done a short-term outcome of the complete mesocolic versus the D2 dissection. That was a RELAC trial. In that, we have observed that post-operative surgical complication rates are same. Intraoperative complications, mainly vascular injury, was significantly more in CME group. That increased from 1 to 3%. This is a small amount, but we can see it's 3 times. But we are doing all the CME dissections, D3 lymphadenectomy. But is it applicable to all the patients? No. If the patient having a T1, T2 stage, then we can see there is a main lymph nodes are only less than a 1% involved. But we can see that T3, T4, then it's a 3 to 5% involvement of the central nodes. So in this type of cases, it will require a CME versus CVL. This is a meta-analysis which showing that 3-year and 5-year survival, disease-free survival and overall survival. It's showing that all the, it improves the overall survival and the disease-free survival. But we can see in the detail of this meta-analysis, all the studies, they were included there, the retrospective studies. And in the literature, till now, only 3 RCTs is done between the for CME, CVL and conventional colectomy. Hence, we require further RCTs to decide whether we should go ahead with CME, CVL in all cases, or we should go ahead with for the T3 cases. And we can see this guideline from American colorectal surgeons. They have given consensus that a routine extended lymphadenectomy is not required. If any suspicious lymph nodes are involved of central lymph nodes, then we should go ahead with the central lymph node lymphadenectomy. Thank you.
Thank you. Excellent videos and excellent talk. Any questions, both from the floor and from the panels? So I have a question. So what is your practice? In which patients will you do this kind of surgery? We have seen, in all conferences you go, there will always be demonstration of CVL and CME. And the concepts are not very new. The concept of a mesocolic excision has always been there. It's just now been given a name. But this CVL and going and dissecting the SME bear, how often do you do it and when would you advise?
We will do all the patients of T3 or N+ disease if it is a node positive. But in our Indian scenario, we'll see all the patients will come to with the symptoms and they will have a thing. So all the patients will be the T3 disease definitely. So that patient we are doing a CME versus CVL. If it is an early tumor, incidentally detected or routine checkup, if they are less than T3, then we are doing a routine conventional colectomy.
Yeah. So again, what complications are more? And
Yeah.
there is no current, like you have said, there is no current benefit, survival advantage that has been proven on these cases.
Yes.
So I would be very, very careful in doing it on all patients. Yes, there
Yes,
is a
definitely.
role for a niche group of patients where this can be done, but it has to be done carefully and in experienced hands. Any thoughts, Panji?
Definitely, there is a vascular complications is more in these cases over the SMV.
If not, thank you very much.
Thank you.
Is actually mine, so I'll be talking about optimizing TME quality. A lot of what I have said is already been covered by Ashwin, and I think some of it will be covered by Dr. Haribhakti in the next talk. So we saw an excellent video earlier on laparoscopic TME, and my talk is on how to optimize quality. We all perform TME. We know that TME is the standard approach to rectal cancer. I don't think there's anybody in this house who will say we will do a non-TME approach for rectal cancer. And the meaning of TME is essentially excising the rectum and the mesorectum along with all the nodes in one package. And we all know that it improves survival and outcomes. And incomplete TME leads to worse outcomes and increased recurrence. Now, how do we judge the quality of the TME that we have done? This has to be done macroscopically. It's ideally done by the pathologist. But as surgeons, I think I would encourage everybody to look at the specimen after it has come out to see whether your TME quality is complete, near complete, or incomplete. And you look at 2 or 3 different factors. You look at the mesorectum. Is it smooth and intact? Is it sort of irregular? Or if most of the mesorectum is left behind in the patient and you have very bit of mesorectum left, are there defects in the mesorectal fascia? Is the muscle visible? And is the CRM smooth and regular or irregular? And based on this, you yourself can judge the quality of the TME that you have done. So this is from the paper that was published by Phil Quirk on the types of TME. So this is a good TME, which is complete. You can see the mesorectum is intact. This is nearly complete. And this is an incomplete TME, where you can see that actually the muscle is visible and there are chunks of mesorectum that are missing. So this is what we should aim for. So this is how a good TME will look. These are some of the specimens from our hospital. So this is an ultra-low anterior section. You can see that the whole mesorectum is nicely maintained. There's a glistening fascia that you can see. There are no breaches. The muscle is intact. This is a partial TME for an anterior resection. Again, the whole thing is intact. The cut is perpendicular. There is no coning. And the specimen looks good. So this is what we all should aim for. Now, there are potential areas for compromise of quality. And I'm going to address 3 of these potential areas where quality of TME can be compromised. One is if we identify the plane wrong. If you go in the wrong plane, then obviously we will not get a good TME specimen. The other thing is coning while doing distal transaction. And this is again a potential problem which can lead to increased recurrence. And then last but not the least, I'm going to talk about wasting of the APR specimen. So just 3 points, and each of these I will cover in the next few slides. But before I start any of this, one request to everybody is to look at the MRI yourself and plan your operation. So if you're going to do a rectal resection, look at the MRI, no matter what the report says, look at where the CRM is and imagine it and say, this is my plane for resection, and see if there are any potential problems. So like if you're doing an APR, the tumor's here, you can sort of draw out the CRM or the mesorectal fascia and see, okay, this is going to be my plane of resection. In an upper rectal tumor, you can sort of imagine where your plane is going to be. If the tumor is going to reach that plane, then you've got to be doubly careful. Again, look at all views on the MRI, plan out your resection margin. It will give you a lot of confidence when you actually do the operation. Now, identification of planes. I think Ashwin again mentioned some of this. Few pointers. I'll go through a couple of videos, but few pointers to look out for in these videos. One thing that, my professor always used to say, the plane is always higher than you think. We tend to go lower, we'll go into the wrong plane. Second, there are always 2 avascular planes. It's not a avascular plane. There are always 2 avascular planes. There's a right plane and there's a wrong plane, and I will show that. And always when you're dissecting a plane, there are 2 sides to a plane. There is a rectal side and there is a visceral side. And you've got to stick to the rectal side.
This is one of the things that I picked up. Look out for triangles and circles. I'll explain this in my videos. And then always remember the left hand is actually what is doing most of your operation. And you have to have a very strong left hand. And you have to imagine your left hand retraction in 3 dimensions. You always tend to push it or pull it, but we've got to imagine it in 3 dimensions so that we get adequate traction and counter traction. So here's a low anterior section. So here, see, the plane is high here. So normally the instinct would be to go down here because that's where the sacral promontory is, but the plane is always about 1 centimeter or 2 higher. So if you go here, you'll actually go below the nerves. So plane is always higher than you think. See, the left hand is actually doing quite a lot of dissection. I've slowed this video down. You have seen that the left hand actually goes up. So we A-frame and then pull away and out so that we get a good retraction. And then open out this Tal's fascia. You can see here the ureters here. That's the gonadal vessels here. You got to go just above that and keep pulling it down. It's an avascular plane. There are a few vessels here which might bleed, but it's relatively avascular. The other thing is to look out for triangles. So again, look at this. All these areas form triangles. And it's a good idea to keep at the apex of the triangle. So this is a triangle. You dissect at the apex of the triangle. You can see that the tissues are again forming triangles here. You go to the apex of this triangle and pull it down. So that always easy to identify where you need to go if you go at the apex of the triangle rather than the base of the triangle. And again, this triangle is formed. You keep pulling it down and you keep pulling down. Again, you can see here, same thing. We keep going into this avascular plane. The left hand has to do a lot of dissection, but you keep going there and you can actually reach the lateral abdominal wall very easily. I will fast forward this video a bit because these bits are not relevant at the moment. So again, once the vessel is divided, the same thing being done here. And you see A-framing and pulling the left hand up and away towards the spleen really opens out this whole plane. Now, once we come to the pelvis, again, like I said, there's always, this is the plane here where the mesorectal fascia will be on this side, the presacral fascia is on this side, and there's this beautiful areolar tissue which is in between. And this is the plane we need to keep to. Again, keep looking out for these potential triangles and keep going to the apex. If you go here, we'll injure something. You'll see in a moment the ureter is right there. So there it's being pulled down there. So you can see the ureter being pulled down there. Again, as you go posterior, this plane opens out. The aim is to stick to the rectal side of the plane, not on the presacral side of the plane. Again, same thing here. Once you've done the lateral dissection, stick to the mesorectal fascia rather than to the lateral side. And that just makes things easier. And let me fast forward a bit. Again, same thing on the right side. Posteriorly, again, you see there are these, everything gets pulled up, and as you give good counter traction, these triangles form and you stick to the top of the triangle rather than to the bottom of the triangle. As you go towards the pelvic floor, you'll see the pelvic floor sort of coming up over here. And again, you stick to the mesorectal fascia, staying just outside of it. You can see the pelvic floor is coming up over here. And as long as we hug the rectum, we'll be in the correct plane. Then same thing laterally and anteriorly. So again, the mesorectum is here. This is the side wall. And there's this areolar tissue right in between. You keep hugging that and you keep going down and you can go right down to the pelvic floor and even in the intersphincteric plane if you actually keep following this plane over here. Same thing can be done robotically. So I talked about triangles. Here I'm going to show you something which will tell you whether you are in the wrong plane or not. So this is a robotic rectal dissection we are doing. We are going posteriorly and you can see the same areolar plane. We are sticking close to the rectum and we are going here. So same thing, stick close to the mesorectal fascia. And if you see here, here I have gone into the wrong plane. Can you see the circle that is formed? That means we are too close to the rectum and the mesorectal plane is almost about to be breached. So I'm correcting myself over here and going one plane behind that. And the correct plane is actually here. So if you see a circle which is forming instead of a triangle, that means you're potentially going into a wrong plane. You got to go one plane, just probably less deep than that. And that's an easy way for you to identify whether your plane is correct or not, even within that area of where you're dissecting. The other thing is coning of the specimen. If the tumor is here, what you want is to go down along this green line, transect perpendicular, and then go up along this, or you dissect on both sides along this, the outer green line, and then transect perpendicular. What very often happens is we are in a narrow pelvis and we start cutting the mesorectum at an angle because we are approaching it from an angle, and you end up cutting along this red line. And so a little bit of the mesorectum gets left behind over here. And if that happens, if you leave the mesorectum here, this mesorectum potentially might have nodes which are left behind from this tumor. So that is coning because the specimen is coned, and that should be avoided. And for that, we need to have a good distal transaction. So this is a specimen which is not coned. You can see that the cut is perpendicular over here. A coned specimen will probably have mesorectum missing on both sides. How do we avoid coning? First, be aware that this is possible. Second, do a good distal mobilization. Beyond the point of transaction, mobilize 2 or 3 more centimeters at least, and then plan it out, mark your resection, and then transact. So just being aware and planning it out will help you prevent coning. Last but not least, avoid wasting in a APE specimen. So what do I mean by wasting in an APE specimen? So now this is how traditionally we have been doing APEs. So you go down the mesorectum, go to the pelvic floor, and you mobilize the rectum as much as we can, right down to almost the intersphincteric groove. Then we go from the perineum and then cut and get our specimen. And that leads to a specimen which is like this. So you've got a specimen which goes down here. Then it narrows down to the pelvic floor because we go along the mesorectum. And then you've got the perineal dissection which meets up there, and we have got this narrow waist on the specimen. Now what happens is this is where the tumor is in an APR. And that's where you get the least margin. And there's a risk that it might be positive. What we want to do actually is to go along it and not go along this and sort of mobilize right to the pelvic floor. But we stop the dissection once we start seeing the pelvic floor. And then we do the rest of the dissection from the perineum and cut the pelvic floor, not very close to the rectum, but slightly away from it. This is a concept which is similar to the extralevator APR. And if we do that, we get a cylindrical specimen like this, where you see that there's definitely more bulk in this area. There is no wasting, and you get better margins. And so therefore you get a margin where actually your tumor is and the margin is less positive. So those are the 3 tricks that I had for getting a better mesorectal excision. Sometimes a TME is not possible. You will get a positive margin. So you have got to go extra mesorectal. You might have to take adjacent tissues, and you might have to even do excentrations. And you should also realize that a TME is only as good if you get a negative margin. And sometimes you go extra mesorectal to get negative margin. So here's a patient who's had a hysterectomy along with a rectal dissection. Here's a patient where we have taken a vaginal cuff because the margin was going to be positive at that point. Here's a 3-compartment total pelvic exentration just to get a positive margin. And here's a patient who's had a bit of a sacrectomy to try and get a negative margin. So TME is not the answer to all. Sometimes we have to go beyond the mesorectal plane and take adjacent tissues to get a negative margin. But finally, a good quality TME and a negative margin are of utmost importance to get the least recurrence that is possible. In summary, high quality TME is essential. You have to plan preoperatively, identify the planes correctly, do a good distal transaction, and avoid wasting of specimens in an APR. Thank you. Any questions? Any thoughts?
ये जाइडस में अपने जाइडस और 3 में देना है ठीक है मैं एड्रेस
So ideally, in an ideal world, the pathologist should give a grading of the TME quality. In a pathology report, you should have a grading of TME quality. Ideally, you should also look at it and grade it. But very few pathologists do that. But if you have a pathologist who is interested on, you can speak to, they should grade the TME. Also, in these kind of specimens, we are supposed to bread slice the specimen and get rings and do the margin. Again, a lot of pathologists don't do that. But that is also, in an ideal scenario, that should be done. One thing that we used to do maybe 10 years ago is cut the specimen and then send it to pathology. We have stopped doing that. That really helps in the pathologist giving us a better report. So we have stopped, sort of cutting open the specimen after the surgery and then putting in formalin. Yes, Dr. Ashwin. Yes. Yes.
So then what they do is they go and look for party artifact. There is no party artifact there because this is not as that is one important point that is coming with MIS for admission. Maybe intact, but pathologists will be aware.
Yes, absolutely. It happens. We've all seen the radiated, the post chemo rectum, you put a retractor and it tests. So that's a very good point.
Thank you, sir. Now, next talk is by Dr. Sanjeev Haribhakti, sir, and that is on optimizing the distal transection and anastomosis for low rectal cancer. Tips and tricks.
Good afternoon. I can see a good crowd and everybody is awake. So that's a good thing. I'll be talking on distal transection and the techniques of anastomosis. Rectal cancers divided into lower, mid, and upper thirds based on the centimeters from the anal verge. It's very important to understand the anatomy in this area before we embark onto rectal cancer surgery. What is the surgical anal canal? What is the anatomical anal canal? About the sphincter mechanisms and the folds. Now, for the upper rectal cancer or the rectosigmoid, an anterior resection would be mostly needed because the distal 5 centimeter of TME clearance and rectal margins would be needed. Most of the times, the anastomosis will be at the level of the peritoneal reflection. As you know, anteriorly, the reflection is much lower than on the sides. For the mid-rectal cancers and for the, it will be a low anterior resection where the anastomosis will be below the peritoneal reflection, whereas for lower rectum, which is less than 5 centimeters from the verge, you need special techniques to preserve the sphincter in form of ultra-low anterior resection, either intersphincteric resections or coloanal anastomosis. Now, this is a very wonderful classification that we use clinically to decide what kind of procedure to use for low rectal cancer by Eric Rude from Bordeaux. And for this kind of tumors, they have classified these low rectal cancers into 4 varieties, type 1, type 2, type 3, and type 4. And based on that, we can decide what is the best form of treatment, resection, and anastomosis. The type 1 tumors are called the supraanal tumors, which are more than 1 centimeter from the anorectal ring. And here you can see the dotted line denotes the margin of resection. So this will be our margin of resection because the tumor is at least 1 centimeter away. And that's why you can do a coloanal anastomosis in these situations. However, for the type 2 tumors, which are juxta-anal, there is a very little margin from the anorectal ring. And that's why what you need to do to get a better margin, you'll have to do a partial intersphincteric resection. For the type 3 tumors, which are intra-anal tumors, which infiltrate into the internal anal sphincter, you will need to completely remove the internal anal sphincter, which is the type 3, where you need a total intersphincteric resections. And it's only for the type 4 tumors, which involve the external sphincters or the levator ani. Only for these tumors, you need an anto-APR or abdominal perineal resection, the type 4 tumors. So most of the tumors, you can do sphincter preservation, and there are several techniques which are important to know how we can do sphincter preservation. So this is again based on different types of resection, what are the different types of anastomosis that you do. For LAI, mostly a double stapled anastomosis is done. For ultra-low also, mostly we can do a double stapler, or one can go for a
hand-sewn coloanal anastomosis or a stapled anastomosis. And for ISR, when you do an ISR, you need to do a hand-sewn coloanal anastomosis. Now, for all these patients, the anastomotic leak is actually seen for most of these reconstructions. The leak rates vary from 3% to up to 20%, and radiological leak rates are even higher, up to 30% for the colorectal anastomosis. And as you go down on the rectum, the risk of anastomotic leak increases. With the risk of anastomotic leak, the morbidity, mortality goes up, the hospital stay, cost of treatment, reoperations, local recurrence, and even with very low resections and reconstructions, sometimes these patients can end up even with a permanent stoma. There are several factors which are related to the anastomotic leaks, either patient-related or surgeon-related factors. Most of the modifiable factors we should be aware of so that we can modify them by either doing some prehabilitation or intraoperative adjustment to the operative plans. Whereas for the non-modifiable factors, there are different techniques that I'm going to describe, especially the male narrow pelvis, obese patients, preoperative chemoradiation, large bulky tumors. These are some of the very difficult cases, especially low down in the rectum. Then we need to use some different techniques. The patient position and the port placements this is our standard port placements for colorectal surgeries. Adequate exposure is very important for colorectal surgeries. And then the TME has very well been covered by Rovin. The only thing that I would like to cover is the nerve preservation. And I prefer to use the monopolar current because you can see here that how you can actually see the areolar tissue and you can preserve the, get into the correct plane. That's the left hypogastric nerve with a stretch on the rectum. Both the nerves on both the sides can be seen. You can see how the areolar tissue actually guides us to the correct plane. The left hand, as he said, is very important to give a counter traction so that the plane opens up and you can remain in the perfect plane as you go down into the rectum. And this areolar tissue plane opens up with the pneumoperitoneum. It beautifully opens up and you can completely maintain be in the right plane as you go down posteriorly on both the sides. So with the stretch, you can see that is the TME plane as you can go down. It's an avascular plane, and that's why I don't prefer to use any energy devices because it denatures the proteins and you tend to lose this plane when you use energy devices. So the right hypogastric nerve also is here seen. Here you can see with the traction on the right side and as well as on the left side. Both the sides you can see the hypogastric nerves, and this should be preserved for all rectal cancer or for benign rectal surgeries as well. As you go down, I'd like to fast forward this video. It's very important to have circumferential rectal dissection on all sides before you get your staplers down. And this circumferential dissection has to be all around as you go low down to the pelvis, anteriorly, posteriorly, on both the sides. You can see here in a female patient, the vagina has to be, completely mobilized and separated as you go down in the low rectum. Only then you'll be able to get a good staple down into the pelvis and do staple transection with minimum amount of or number of staplers. There are different techniques used to divide the rectum low down into the pelvis. Here, this is one of the techniques that we use, especially when there is a narrow pelvis. We use 2 firings of 45 millimeter. These are articulating staplers. As you go down, you need to articulate the staplers. And the first firing will take care of almost 70% of the rectum, but you need a second firing, which will take care of the rest of the rectum. With this, we need to make sure that the alignment of the staple line is preserved as you go down. Sometimes there can be stapler mishaps, firing mishaps, and things like that. When you're using this technology, you need to use the right size cartridge and the right color coding in situations like this. And then based on that case, you have to decide what kind of technique you are going to utilize. There can be problems like this patient had a stapler malfunctioning, and as this was a case that we did last week only, and when I felt from the below in between the sphincters, we could see a defect, a finger is seen on the defect, and then when we put in a Hegar's dilator, we could actually see the defect well. I could see all around. It's a very difficult situation. Laparoscopically, we don't have any other way to increase the, increase the resection or get another stapler down on this. If it is a higher up transaction, then definitely we can put in a, dissect it further and put another stapler and fire it here. But still, it is possible to even laparoscopically repair this kind of defects low down onto the pelvic floor. You can see the right and the left, the levator and eyes, both sides. It is a very low rectal stump, but we could close this adequately and then could fire the stapler and complete the anastomosis. So there is good evidence to suggest that the number of stapler firings has a correlation with the anastomotic leak rates. The more number of staplers you fire, higher is the leak rates. And that's why one must try to fire minimum amount of staplers. And for patients in whom there is a good, access, low down, pelvis is wide, the tumor is not so bulky, we would try to do it with a 60 millimeter stapler. And here also, when it is low, to tend to make sure that, you can try to get it in one staple, or if it is not, then you may have to use another stapler. But the idea is to reduce the number of stapler firings as we go down. So this is an articulating stapler low down onto the pelvic floor with a single 60 millimeter fire. The anastomosis generally is a double staple technique. As you come out, one has to be very careful because the rectal cuff is very small. When you insert the head of the stapler, generally we prefer to use the 28 millimeter stapler, the smallest one that is available. And when you fix the anvil to the stapler head, make sure that that orange thing is not seen, a click is heard, so that the stapler engages into the housing. And then make sure that there is no rotation while you close the stapling. We use the purse string as a guide, which is anteriorly placed, and that helps us to guide as we get the stapler in. Even the anterior tinea coli also helps us to make sure that the right orientation. And then, of course, we will trace the bowel and make sure that there is this is a vaginal examination to make sure that there is nothing comes in the way as we fire the stapler. We prefer to use this tiltable anvil so that it's easier for the stapler to come out. And we always use a leak test at the end of the anastomosis and then decide about the stoma placement. In difficult cases, one can resort to hand assist techniques. Through the hand assist technique, you can put in your hand and use this for dissection, for traction of the rectum, getting the stapler down, doing the pushing the anvil, and rarely one can use even the open contour stapler with the hand assist ports. There are certain drawbacks of double staple technique. There are certain structurally weak points on double stapling techniques, and we need to be aware when we use double stapling techniques that there can be dog ears, and these are the areas which are prone to anastomotic leaks. And this paper also brings out the same, that how many are the intersections of the staple line is correlating with the anastomotic leak rates. So we can use modified single staple technique, use a purse string below the rectum, and then use a single staple technique, which is something that we use in transanal surgery. Also, this technique can also be used on the robotic platform, because robotically suturing and taking a purse string low down is very easy. And there are definite benefits of using robo in the lower rectum. And people have said that nerve preservation can be better and the dissection can also be better. But transanal surgery is a fantastic tool because you are dividing the margins and the vision from below for very low tumors. This is a very good technique, doing a transanal resection and getting out. One can do the TME from above laparoscopically as much as you go down, and then can divide the rectum from below with a purse string and then perform a single stapled anastomosis. So TME also can be done completely from below. And intersphincteric resections are the ones, is a technique which we can use for very low tumors where there is not much margin. And there are indications are well to moderately well differentiated T1 to T3 lesions. It is not a good idea to use it for poorly differentiated or T4 tumors because there is a higher local recurrence rates. And people who have poor anal function, we must evaluate by doing an anorectal manometry before doing ISRs, that how much is the tone, because these partial or subtotal ISRs or even total ISRs, less than 1/3 is partial, up to 1/3 to 2/3 is subtotal, and more than 2/3 or complete removal is a total ISR, have a compromised functional outcomes. And the functional outcomes are not so good. One has to be aware when you are doing the ISRs that these patients, the the perfect satisfaction is only for 70% of patients, and almost 30% of patients have lower continent problems related to either incontinence, soiling, daytime or even nighttime soilings. But having done that, the oncological outcomes are quite good with either open or laparoscopic or even robotic ISRs. So with this, come to the end of the presentation. Lower rectal cancers is not the one for the occasional surgeon. One has to be a skilled colorectal surgeon with experience, either open, laparoscopy or robotic, whatever technique one is using. Know that multiple rectal transaction techniques that are available today to do sphincter preservation. Do not force a single technique in all situations. Try to divide the stapler in a single firing as far as possible. Avoid zigzag stapler lines. Resort to single stapling techniques, robotic or transcranial divisions whenever one is in a difficult situation. Thank you very much.
Thank you, sir, for that excellent presentation. Any questions? Panelists, anybody from the floor?
Yeah.
Isn't it much more, should be used more often in terms that whenever we are actually taking out the specimen around that much centimeter of the incision will take. So is it in your experience that will be more promoted, or you are not, you are much more comfortable with laparoscopy?
Yeah, so there are problems and limitations with hand assist technique. If you do it very often, very early, we started doing hand assist surgeries very early on. 2006-07, we started hand assist surgeries. In 2010, I published the first hand assisted, it was a single incision RPC IPA. But hand assisted, whenever you put your hand, the space gets limited. The ergonomics are not so good. One is the hand is inside, one is instrument is outside. So the ergonomics is not good. The space gets very constrained. And that's why, it's better to use complete laparoscopy as far as possible. When you're in problem, you always have a choice. Because if you use a midline mini laparotomy, then your camera has to shift. You have to have another 10 mm on the right side to use the camera. And then your left, or you can use a hand assist port on the left flank so that your hand goes down and the camera remains here. But hand assist is a good technique in difficulty. Don't resort to complete open conversion. Always try to resort to a hand assist conversion and try to solve the problem rather than using an open conversion. So it's a good technique, intermediate technique. You don't need a hand port. Remember, for a hand assist, even surgery, you can even just put an incision and put your hand, there won't be any leak. If you have a hand port, that is fine. If you don't have a hand port, use a wound protector and a glove, or just use any, even without any hand port also you can do hand assist surgery. So it's a myth that you need always a hand port to do hand assist surgery.
Again, I think it's a useful technique to have, but it has to be used only selectively. In a very deep pelvis, sometimes your hand is bigger than the pelvis to actually go down there. But for difficult cases, yes, it is an option. So any experience on, we get a lot of this narrow male pelvis, which is extremely slow. And even, the smallest stapler also, you find it difficult to get there. So what would you do in such a situation?
So in such a situation, I think preoperatively we will be prepared for a transanal surgery. And my preference is to divide it from below rather than struggling from above, because with a bulky tumor in a male narrow pelvis, so these patients, it's very difficult, not just to pass a stapler, even to do dissection below the tumor. But nowadays, with the neoadjuvant treatment, most of the tumors have shrunk. We wait also quite a long, and that's why that problem of very bulky tumors is not very frequent. That's a major advantage of the neoadjuvant treatment.
Any other thoughts, comments from anybody? Thank you very much, sir, for that insightful talk. So we come to the last talk of the conference. It's on minimally invasive splenic flexion mobilization tips and tricks by Dr. Manish.
Good afternoon. I'm the last speaker, the guard of today's program. At the outset, I would like to thank Dr. Bhavin, Dr. Gujjar, and Dr. Dhaivat for inviting me here and giving me opportunity to speak in front of you. My topic is minimally invasive splenic fracture mobilization tips and tricks. SFM is an important step in left colonic rectal surgeries. It is technically challenging and requires advanced laparoscopic skills. It allows adequate mobilization of left colon. It facilitates a tension-free colocolic and colorectal anastomosis. Indications: it is a fundamental step for both benign and malignant colonic disease. Malignant diseases like left-sided colonic tumors, rectal cancers, especially post-operative radiations. Benign diseases like diverticulosis, surgery for colonic Crohn's. Indications for routine mobilization is distal, transverse, or descending colon cancers, splenic fracture malignancies. Selective SFM done in APR/AR for rectal tumors, rectosigmoid tumors, sigmoid colon, diverticular perforations, and resection rectopexies. This is a routine splenic fracture. So the meta-analysis for 14 studies was done, and conclusion was it is not routinely indicated. What dictates this SFM? Anatomical variations, taking of the mesenteric vessels, the length of mesentery, age, obesity, chronic inflammatory process, diverticulosis, location of the tumor, length of sigmoid colon. It may not be required in presence of redundant sigmoid. Timing of mobilization, and early or late. Early mobilization during the process advantages are ample time for proximal bowel ischemia to become apparent, allows surgeon to achieve better resection margin without a fear of tension at their anesthetic site. Late during procedure, advantages: operative time is less, lower risk of injury to duodenum and spleen. These are the port positions for mobilization. Steps. It looks complicated, but it consists of 5 simple steps. Dividing the lateral peritoneal attachment, line of Toll, division of gastrocolic ligament, and then entering the lesser sac, division of the splenocolic ligament, division of the phrenocholic ligament, and last is division of pancreatocolic ligament. Approach for mobilization is based on the method of entering lesser sac. Laparoscopic SMF is categorized in 3 types: medial to lateral, that is inframesocolic, medial to lateral supracolic approach, and lateral to medial approach. So coming to the first, medial to lateral inframesocolic approach. Dissection starts with opening of left mesocolon close to IMFV. Cold fascia is identified and dissected down. Plane is developed below the left mesocolon. Dissection proceeds towards the transverse mesocolon, as you can see in the last picture. Then mesocolon is dissected of the Zerotas fascia, as you can see there. Pancreas is identified, transverse colon, mesocolon is divided above the pancreatic body, and lesser sac is then entered. The dissection continues to free the pancreatic body tail from mesocolon. Dissection proceeds laterally to completely mobilize the splenic attachment of the colon, as you can see here. Then type B, that is supramesocolic approach. Gastrocolic ligament is mobilized, staying close to transverse colon, in figure 1. And in figure 2, as you can see, all 4 layers of momentum are identified, divided, and lesser sac is entered in this. Then lateral mobilization of proximal descending colon is started along with told line. Colorectal colon is reflected medially and dissected of left kidney. This one. The mobilization is continued medially towards the pancreas. The mesocolon is separated and from pancreatic attachments. The mobilization is then completed. Pros and cons of mesocolic approach. Pros are easy, less operative time, directly enter into the lesser sac, useful in descending colon growth, and cons are difficult in obese individuals. Injury to spleen, pancreas, and colon may happen. So lateral to medial approach. As you can see, this is the view, lateral to medial approach. Further dissection lifts mesocolon from gyrotous fascia and left kidney. Gastrocolic ligament is dissected close to the colon. Lesser sac is entered from posterior wall of the stomach and defied here. Safeguarding the stomach, dissection continues along the transverse colon. Lastly, attachment of mesocolon with pancreatic body is cut. Entire spleen fracture is then mobilized. Why different approaches? Disease is in question, benign or malignant, need of preservation of vascular arcade, limb lengthening, oncological clearance. What we have learned from different approaches. So this is the Volker has given this old is gold approach. What we have learned from different approaches, these are the complications which happen: intraoperative bleeding, colonic injury, splenic injury, ureter injury, pancreatic injury, blood transfusions, poisoning complications, and radial nerve palsy. So you can see in this chart. What we have learned from different approaches. Lateral approach may be associated with more intraoperative bleeding, need of transfusion, postoperative complications. So what is the take-home message? Selectively use, that is splenic flex mobilization, learn all methods and use them judiciously. Combination of the approach is good. Thank you.
Thank you, sir.
I invite all of you in the next national conference of IASGCon at Patna, Bihar. I am the organizing secretary for it, and I request all of you to attend it. It's from 3rd to 6th of October this year at Patna, Bihar.
Thank you, sir, for that excellent talk. Any questions, comments from the panel or from the house? Which is your favorite preferred method? If given all the choices, which one would you normally do?
Medial to lateral.
Medial to lateral. I think that is the most common that is used nowadays, especially in minimally invasive. Medial to lateral is most common. And do you do routinely or would you do it selectively?
No, selectively.
Selectively. Yeah, again, I think that is what is common. Any thoughts, any comments? If not, then we've come to the end of this session. A big thank you to all the speakers and all the panelists. I hand over the mic to the organizers.
So every good discussions and good things has to come and to an end. Just like a morning where every debate should have an equipoise word that we are listening since morning. So I'm here to for Thanksgiving. I would like to thank IASC for giving us this opportunity to hold such a meeting. I'm thankful to our IASC President, Secretary, and entire office bearers. I am thankful to all the faculties, speakers, those who have took time from their busy schedule to enrich the rich legacy of IASC academics. I would like to thank all the delegates. Without you, this may not be possible, and this conference was really successful because of you only, your large presence. I would like to thank all our sponsors, audiovisual team, for such an excellent support given to us. And last but not least, how can I forget our own team, Team Zydus, right from support from all the supports, and my senior colleague in our department, Dr. Bhavin, Dr. Mayank, both our fellows, everyone together only can make difference. And with this, I announce the ending of this meeting. Thank you very much. We have a tea outside. Sanjeev sir.